distinguished guests, colleagues, and friends. Welcome to the third day of the 2025 Taipei Valve Summit. We have an exciting and comprehensive agenda today. We have all day of lectures ahead, but right now we are excited to offer two special workshops, one on redo TAVR and the other on electrosurgery. Since we don't have enough equipment or space for everyone to join at once, we kindly ask those interested in hands-on practice to go to the clinical skill room, where the group numbers will be posted. Each group will have 30 minutes, starting from 1 p.m. Additionally, we've included a live case featuring a patient of very advanced age with critical aortic stenosis, scheduled to follow the demonstration of the mitral valve in valve and LAMPOON procedure. Let's begin our first session, 2025 Structural Heart Disease in Asia, with Dr. Yohei Ohno, presenting the insights from the Mitra Registry on transcatheter mitral repair. Thank you.
So can we start? Yeah. Okay, so good morning, ladies and gentlemen. Always so happy to be back here in Taipei. So over the several minutes, I would like to review the mitral registry in Japan. So as you know, the first in man for the mitral TEER with MitraClip started in 2003 in Venezuela. And actually after that, a lot of studies have been performed, incorporated in the guidelines. In Japan, first in man was performed 2015. As part of the clinical trial in Japan, and in 2017, Kentaro and the co-workers have reported in late-breaking clinical trials. Finally approved in 2017, and we started the program from 2018, accumulating the cases, and now we have a G4 system, which has four variety of the clip size, and recently Pascal has approved. So let me start with this Mitra registry. This is a nationwide registry, so all the participating centers have to provide the data set. This is a mandatory, and you need this report in order to renew the institutional certificate. So this consists of over 10,000 cases up to December 2024. The centers are gradually growing still, so we have 168 centers for MitraClip and 53 Pascal centers. So as for the gender, 60% is female, 3/4 is functional mitral regurgitation, as in line with the other registries around the world. Average age is 78 years old. In Japan, only still high-risk patients are approved for this treatment. So the STS score is relatively high, 11.5%, and mean LVAEF is 45%. As for the treatment effect, the number of clips used is majority is 1 clip, 80%, and 2 clips cases are around 19%. Discharge, 30 days mitral regurgitation is shown here, quite effective, and also for the NYHA class. Overall outcome is shown here. As for the 30-day mortality, 1 year and 2 year, considering the high-risk patient profile in this registry, I think the results are quite acceptable compared to the other registries or the clinical trials around the world. So mitral valve surgery before discharge is 0.4%. And let's say for TRAMI registry is 0.8%. LVEF at discharge is around 42%. And when we take a look at only for functional MR cases, 74.1%, including the mixed etiology like functional and degenerative cases. 60 to 70% are female. Non-ischemic cardiomyopathy is the majority of the etiology, and LVEF, three-fourths of the LVEF is less than 50%. Similar trend with functional MR, because this is the majority of the cases. And as for the outcome, although we deal with relatively low ejection fraction cases, 30-day mortality 1.6%, relatively good. And it was reported in this circulation journal. However, this is, although this is mandatory and deals with a lot of cases, it lacks in-depth data sets, so it's difficult to go for the in-detail analysis and lacks granularity. So for the last couple of minutes, I would like to share our OCEAN Mitra Registry. We are fortunate to have Kentaro here, president and founder of OCEAN Registry, and we have Daisuke on the podium. So, for now, we have 22 centers, and we have completed the data set of 3,764 cases. I think Kentaro will provide insights from the OCEAN-TAVI registry, but for the mitral clip, we have so far up to 2023, 4,400 cases. So our colleague Mike Saji reported as for the initial result of this registry. So if you take a look at which kind of clips are used for each etiology. So as for the primary MR, majority of the cases are used with XT type, whether it's XT or XTW. As for the atrial functional MR, NT and NTW are the majority of the cases. And as for the ventricular, it's kind of mixed. So this shows the baseline characteristics. Age is, median age is 80 years old, quite high age. 64% has AFib. Most of the cases are NYHA class 3 and 4. And as for the etiology shown here on the right-hand side, 3/4 is secondary MR, and about 20% is a so-called atrial functional MR. 1/3 of the patients is complicated with moderate or severe TR. So MR reduction over time up to 1 year, this was published by Shunsuke Kubo and the colleagues. MR reduction over time up to 1 year is sustained, maintained. Clinical improvement as well up to 1 year. So this shows 1-year outcomes, a cardiovascular death of 7.9%. As for the complication, single leaflet device attachment 1.7%, a leaflet tear 1.2%, mitral valve reintervention, whether for the additional clip or the mitral valve surgery, 2.4%. So how was the impact of residual MR for clinical cases, for clinical outcome? As shown in the other studies as well, if you end the case with moderate or moderate to severe MR, obviously the outcome is poor. And this impact is more impactful in degenerative MR. So you can clearly show that the more you end the case with residual MR, the degree of MR, you have more poor clinical outcome. So finally, I would like to share two cases, two publications from the OCEAN Mitra Registry. So for each mitral TEER case, I think you will set a specific endpoint for each cases. So the ideal scenario is to reduce the MR as much as possible while not increasing the mean pressure gradient. So there's always a trade-off, and we sometimes struggle with this result. So there's an optimal group is if we achieve both reduction of the MR and not increasing the mean pressure gradient. The poor group is defined as we end the case with significant MR as well as relatively high left atrial pressure. And there's cases with mismatched, whether each of these high left atrial pressure more than 15 or residual MR greater than 1. So this paper looked into the outcome of this group, specifically mismatched group. As you can see in the right lower panel, the optimal group obviously has the best outcome, and mismatched group has a quite poor outcome, similar with the poor group. So I think this tells that the careful observation with the endpoint using the hemodynamics. I always monitor left atrial pressure since this G4 system allows to do that from the guiding catheter. And when we look into the patients with significant MR, as I mentioned, around 1/3 of the patients combined with significant TR as well, moderate to severe TR. So we looked into the outcome of these patients. And TR is very dynamic before and after the mitral TEER procedure, as you know. So it's very dynamic, even with patients with significant TR at the baseline. Some can improve with less than moderate MR. But even with patient with baseline no significant TR could develop significant TR after mitral TEER procedure. So it's quite dynamic. So we looked into the outcome of these 4 groups, very dynamic. And we were happy to share this publication we recently published in European Heart Journal. So this is the summary of this paper. So baseline TR, no TR is like 2/3, and 1/3 combined with significant TR, which is defined as more than moderate TR. So as I mentioned, it's very dynamic over time. And obviously the most worst clinical outcome is the patient with actually new onset TR. So baseline with no TR, but after the mitral TEER procedure, if patients develops new onset TR, has poor clinical outcome. And what was the predictors of these worsening or remaining PTR after mitral TEER? As shown in the surgical literature as well, it's a dilated tricuspid valve annulus and long-standing AFib. So these are the good things to look at before the procedure. So these 4 groups has a significant impact in terms of several outcomes: cardiovascular death or hospitalization, each component, and all-cause death. So when we look at this is the spline curve analysis that checks the relation with pulmonary hypertension and the hazard ratio of each event. So baseline TRPG does not have impact. Actually, it does not predict the outcome. But more importantly, the post-procedure and this is the before discharge echo. And at 1 month, so post-procedure TRPG has more impact to assess the outcome. So these are the analyses I mentioned. So in summary, annual volume TEER seems to be increasing. Although still treating high-risk patients, early outcome seems to be feasible and favorable. But still some room for improvement. So the APS is around 24% and SDLA is 1.1%. Thank you so much for your attention.
Thank you. We have 1 minute. Any comments from the panelists?
What is the underlying mechanism about the aggravate the TL after the mitral clip? How do we explain such kind of phenomenon?
Yes, so that's a very good question. Thank you so much. So several factors we looked. Well, actually, as I mentioned, AFib is one, but we looked at the potential relation with post-procedure mean pressure gradient, and it has some impact for the post new onset TR. So if the patient develops significant mean pressure gradient after the procedure with elevated pulmonary pressure, it had an impact in the new onset TR.
Another one is your registry data is the high risk fact the patient.
Yes.
What about the expectation for the expand the indication to some moderate, and
Yes.
what is your expectation?
Well, I think we are all in the same page that for ventricular functional MR patients, because we have good result, including the Reshape Heart Failure 2, which was presented in ESC last year. So for VFMR patients, I think it does, even if the patient is relatively low risk, I think we can consider this treatment as an option. But for the primary MR, we still don't have those data. And I think like primary MR trial, which is a randomized controlled trial between M-TEER and the surgical mitral valvoplasty is running. So I think for the degenerative MR population, we need to wait for those results.
Okay, thank you.
Thank you.
All right, Yohei, for your excellent talk and informative data. So the next talk will be delivered by Professor Kentaro Hayashida, the OCEAN-TAVI implication and in long-term durability.
So thank you very much, Wei-Hsian, and good morning, ladies and gentlemen. So today I'm going to talk about the implication in long-term durability from the OCEAN-TAVI registry. So this is my disclosures. Actually, why we studied the OCEAN SHD family was we three of us were in France at the same time in 2012. And I was in Massey, and Yusuke Watanabe was also a fellow in Massey. And Masanori Yamamoto was in the Henri Model Hospital, and we started the two-center registry using a French data. However, we really believe that we need to publish the data from Japan or Asia to the world. That's the reason why we studied the OCEAN SHD family. And we studied from the three centers. Nowadays, we include 30 high-volume centers, including more than 300 members. And we have already enrolled more than 25,000 TAVIs and 5,000 mitral TEER and 3,000 appendage closure. That is sufficient volume to publish the data from our registry. And we already published more than 155 papers, including 126 TAVI, and 20 on mitral, and 9 on the appendage closure. So some of the papers are included not only Japanese, but also in American and European guidelines. I'd like to introduce some papers which might impact the durability of the leaflet. And the processive patient mismatch is quite an important topic in this field. And we published the data that the severe processive patient mismatch was noted in only 0.7% in a cohort. And that is much, much higher in the US cohort. That was reported in 12%, presumably due to the higher body surface area in the American cohort. That means sometimes the American patient quite fat or huge compared to our Asian cohort. And the incidence of the processive patient mismatch was updated in our latest publication published in Chae this year. And severe processive patients mismatch noted in 1.3%. And nowadays we're trying to treat much more complicated patient. And notably, the severe processive patient mismatch has some impact on the longer follow-up during the 3 years. That means that we need to avoid the severe processive patient mismatch, partly due to improve the prognosis, and also the may potentially improve the durability of the leaflet. And this paper compares the SAPIEN series. And if the patient received 20 millimeter or not 20 millimeter, and there is quite similar result in terms of all-cause of death, cardiovascular death, and the rehospitalization for heart failure. That means that as far as we can do very good screening, and we can also take into account the body size of the patient, we can also use the 20 millimeter valve compared to other size of the valve. That is also accepted in Chae. And leaflet thrombosis are also very important factor potentially affect the durability of the leaflet. And we published the data in Circulation Intervention in 2019 that we found the leaflet thrombosis, and they didn't impact the mortality or other hard endpoint in our registry. And we also explored the natural history of leaflet thrombosis. This is the single-center study from our Keio University Hospital, and we tried to not to treat the leaflet thrombosis as much as possible because most of the patients are quite high bleeding risks. Therefore, we tried to not to start the anticoagulation at all, and it didn't impact the late clinical outcome after TAVI procedure. And our fellow Juri Iwata also published the data that the long-term impact of the early halt after TAVI procedure from our Keio University registry. And during the 10-year follow-up, the halt didn't impact neither survival or structural valve deterioration. That is also a quite important finding in this field that is accepted in CCI. And she also published the long-term impact of gender difference after TAVI. And we also had the 10-year follow-up, and the female did better than male in terms of the all-cause mortality. That means the female are much stronger than us. And anti-thrombotic therapy is quite an important topic. And our former fellow Yusuke Kobari published the data that the comparison between clopidogrel and aspirin. And regardless of the anticoagulation, the clopidogrel did better than aspirin in terms of the decrease in mortality. That means that maybe we can think about clopidogrel after TAVI procedure. But sometimes the patient are really at high bleeding risk, so we cannot administer any antiplatelet therapy. And we call that the non-antiplatelet therapy NAPT, so named by Yohei Ohno. And if you look at the data, so NAPT didn't increase the thrombotic event, however, decreased the bleeding event. So that means that maybe we don't need the antiplatelet therapy after TAVI procedure as far as the patient doesn't have any AFib. And based on this data, so we studied the randomized control trial called the NAPT trial, and comparing the aspirin alone and totally no antiplatelet therapy after TAVI procedure. And we enrolled 400 cases so far, and we're waiting for the longer-term follow-up. And biprosthetic valve failure after self-expanding device is also quite important topic. And we published the data this year in the American Journal of Cardiology that regardless of the small aortic annulus or large aortic annulus, and the self-expanding valve did better. However, if we put the self-expanding device, the large aortic annulus, they were associated with some increase in terms of all-cause death or biprosthetic valve failure, and presumably due to the worse LV function, and maybe the LV was dilated a little bit. So we need to have the further exploration to elucidate the reason for this finding. And we also have the 10-year follow-up to 7XT series because we studied the TAVI procedure from 2013 in Japan. And this is presented in the JCS 2025, and now it's under submission to some journal. And we had very good sustainability of the durability of 7XT. And the cumulative incidence of structural valve deterioration was noted in the 20% moderate severe SPD at 10 years. And if you look at the incidence of BVF, the crude incidence of BVF was noted in 7% during 10-year follow-up. And cumulated incidence was 25% because some of the cases are censored or died during the follow-up. That means we have the 10-year durability data on the 7XT in our country. And if you look at the impact of the patient characteristics on the incidence of biprosthetic valve failure, And the age matters. If we put the bioprocessing in the younger patient, they may develop the BVF. And male gender was also identified as the predictor. And the body surface area matters, and presumably due to the higher incidence of the process-patient mismatch. And STS score matters, and if the patients are at the lower STS score, maybe they move around. That's the reason why the patient was associated with higher incidence of BVF. And my good friend Masa also published a data comparison between SAPIEN 3 UR and S3. And the UR did better than S3 in terms of decreasing the incidence of severe process-patient mismatch up to 0.5%, as well as the lowering the PPL. And I hope that this kind of improvement may lead to the much better durability during follow-up. And Dr. Hioki also demonstrated the very good result of the S3UR and Evolut FX in terms of the patient in the small aortic annulus. And because nowadays we have very good devices like S3UR and Evolut FX Plus, so hopefully in the future, this kind of improvement will improve the patient prognosis after the procedure. So in conclusion, ladies and gentlemen, the severe process-patient mismatch is rare, but associated with increased mortality. And the leaflet thrombosis is not rare, but not associated with neither mortality nor SVD at that time. So we need to have the much longer follow-up in the future. And SAPIEN actually demonstrated excellent 10-year outcome. And hopefully the latest devices may provide better durability. And thank you so much. And you're most welcome to attend our PCI Tokyo Valves meeting in 2026. Thank you so much for your attention.
Thank you, Kentaro. Excellent talk. We may have 3 minutes to discuss. Any question?
Thank you for your wonderful speech. If the patient have a need to use the anticoagulation, it means the clopidogrel is better than aspirin, right? So everyone you use the clopidogrel, even he use the aspirin, even he need the anticoagulation after the TAVR.
So your question is if the patient require anticoagulation and the clopidogrel is better than aspirin, and your question is the patient doesn't require anticoagulation, right? So our data demonstrate the clopidogrel is better. However, after that, we also checked the totally no antiplatelet therapy, and it didn't increase any thrombotic event. However, it decreased the bleeding event. In my personal experience, so if I check the bleeding risk of the patient, and the patient is at high bleeding risk, I personally stop any antiplatelet therapy. But we need to prove that that is correct in the future.
The other question is that for larger annulus,
yep,
the prognosis is worse. Why?
It's quite important, and I think that if we use self-expanding device, so we can avoid the PPM even in the small aortic annulus. That means the impact of small annulus is quite minimized with a self-expanding device. On the other hand, the patient may have the larger aortic annulus if they have the worse LVEF. We also find the same data in the study of the SAPIEN 3s as well. So hopefully in the future it will be published in some journal. It's under revision now.
Yes.
Thank you for an excellent talk. Your conclusion said that leaflet thrombosis not associated with neither mortality nor SVT. But if you observe this condition in your clinical practice, will you change your medical strategy, like add to DAPT or anticoagulation? Hey,
thank you. My personal take is to avoid anticoagulation as much as possible. But some doctors administer anticoagulation immediately after the finding some leaflet thrombosis. We need to find that which is correct. Maybe we can also tailor-made our approach. Sometimes the patients are really at high bleeding risk. So once we administer warfarin or DOAC, they may bleed. On the other hand, if the patient is much younger or healthier and at lower bleeding risk, we can also think about the anticoagulation to secure the longer durability of the leaflet. We need to explore much more in the future.
Okay, thank you.
Thank you.
Excellent talk and excellent data. Okay, next talk will be delivered by Dr. Ko from Korea, Cusp overlap and commissural alignment. Please.
Thank you very much. I will talk about the Cusp overlap view and commissural alignment. You see here is 3 cusp coplanar view, all 3 cusps in a line, and in the right-left cusp overlap view, you see the overlapping of left and right coronary cusp, and the non-coronary cusp is isolated. So commonly, this overlap view is obtained in areocaudal projection. The cusp overlap view has more elongated view of LVOT. Therefore, this is very helpful to assess the valve deployment depth more accurately, and it helps to reduce the conduction disturbance with a higher implantation depth. And also it reduces the parallax in the marker band of valve system. And also I will talk about the commissural alignment later, but it can help to manage the commissural alignment. As you all know, the permanent pacemaker implantation rates vary depending on the valve types implanted during the procedure. And commonly, self-expandable valve have higher permanent pacemaker implantation rates than balloon expandable valve. And depending on the study population, the pacemaker implantation rate is over 15 to 20%. And therefore, it is important, I think, to reduce the permanent pacemaker implantation rate. Actually, initially, the permanent pacemaker implantation has neutral effect on the clinical outcomes. However, in recent studies, the implantation of the permanent pacemaker implantation is associated with significantly increased risk of mortality and rehospitalization. So I think we have to do more effort to reduce the implantation rate. So, and the risk of permanent pacemaker implantation is related to the depth of the valve. As the valve implanted deeper into the LV, and then there is more risk of the contact with the conduction system with the valve. So implant depths more than 6 millimeters, there is a risk of permanent pacemaker reaching to 40%. So it's very high. So we have to try to reduce that. Therefore, there have been efforts to reduce the pacemaker implantation rate with a higher valve implantation using cusp overlap view. In this study, Dr. OCEAN demonstrated that the pacemaker implantation rate can be reduced from 10% to 0% in case of Evolut system. And also, new LBBB can be reduced from 11% to 4%. In case of SAPIEN valve implantation, the reduction was not significant, but the conventional technique, the pacemaker implantation rate was already very low. But the LBBB can be also significantly reduced with the higher implantation technique using cusp overlap view. But the downside of the high valve implantation using cusp overlap view is the increased interference of the valve skirt with coronary axis. So as you can see here, so with conventional implantation technique, the skirt interaction with the coronary axis is 9%, but with high implantation technique, 22%. In case of SAPIEN valve, actually there is no change in the interaction of valve with the coronary ostium, either with the conventional technique or high implantation technique. So in case of self-expanding valve, I think we can try to reduce the depth, but on the other hand, there is increased risk of coronary access. So we have to be careful about that. So, and also the high implantation can increase the risk of coronary obstruction due to sinus sequestration and lead to TAVR. So especially when the sinus reservoir is shallow and low, then I think we have to be aware of this kind of risk. So with higher implantation, there is a lower risk of permanent pacemaker implantation, but on the other hand, there is increased risk of coronary obstruction. Also, it's not often, but especially in calcified aortic valve, there is still increased risk of valve embolization. And as you know, there are several anatomical and device procedural factors impacting coronary access of a TAVR. One of the device factor is the commissural tap orientation. So commonly, the self-expanding valve has a taller metal frame, and also the commissurals are higher than the balloon expandable valve. So when this commissural posts, located just in front of coronary ostia, then the coronary access can be significantly impaired. And as you can see here, if the new valve commissure just aligns well with the natural commissures, then this is actually optimal situation for the coronary access. However, the worst scenario is like this. So if the commissural post just face the coronary ostium, then it is very difficult to assess the coronary arteries. So this can be severe commissural misalignment. This should be avoided with all effort. And not only coronary access can be impacted, but also the feasibility of the leaflet modification called basilica if there is a commissural misalignment. And also several studies have shown there is some association with hemodynamic factors with commissural alignment, but this should be more investigated in the future. And in order to adjust the commissural alignment, you have to know the fluoroscopic markers. So here, these prostheses have 3 markers, accurate neo and navitor. So you have to know these 3 markers. And Evolo system have only 2 markers, these 2 pedals. And Sapien have also double struts as the commissures, the attachment. But when the valve is crimped, then it's difficult to know where the post is. So ideally, if you have this 3 marker system in coplanar view, like in this configuration, 1, 1, 1, then this can be optimal alignment. Just the post, diverted from the coronary ostia. However, this can be also the worst scenario, like this, just post facing the coronary ostia. So to check which one is which, so we need to have the Cusp overlap view. If you look at the valve at this angle, then you can have, if you see 2-to-1 post configuration and with free cell here, then this is the optimal alignment. So when the valve is implanted, you see here 1 post and 2 posts here, so 2-to-1 configuration. And usually, if you use the accurate neo is now withdrawn from the market, but it is good device to understand the commissural alignment. So we introduced the valve, the system with the flush port at directed to 6 o'clock. And in coplanar view, you have 1-1-1 position. If that is not the case, then you can rotate the system and to have this configuration. And then you rotate the fluoroscope to Cusp overlap view. And if you check, if you find this 2-to-1 configuration with free cell, this is the strut that is not connected with other struts. So if you see like this, then this is the optimal configuration. So now here you have three posts, 1-1-1 configuration. And if I change the projection to Cusp overlap view, then we have 2-to-1 configuration, and the free cell is visible on the right side. So after implantation, you see here 1-1-1 configuration of post, and here in Cusp overlap view, 2-to-1 configuration. And with Navito, it is also similar. So this is three markers system. In Cusp overlap view, in three Cusp overlap view, 1-1-1 configuration. So the markers are not well visible as the accurate. However, you still see the markers. And in Cusp overlap view, you have 2-to-1 configuration like this. And after implantation, you will have 2 posts here and 1 post here, so 2-to-1 configuration. And we are with the newer version, so Navito Vision, which has the 3 visible markers at the implant depth level. So you can see here better the markers. So again, 2-to-1 position configuration in Cusp overlap view, and after implantation, you will have 2-to-1 configuration of markers, and in coplanar view, you will have 1-1-1 configuration. So it is not that difficult. So, but you have to always check the different projections, and that will be crucial for the optimal commissural alignment. In case of Evolut, it's a little bit complicated. We see 2 pedals, but only C-tab. C-pedal has the commissural attachment. But there is another orientation marker, which is the head marker. This is 90-degree counterclockwise relation to C-tab. So if you have this kind of configuration in Cusp overlap view, it is a little bit difficult to find C-tab on fluoroscope. But if you have a head marker just facing to the front side, in Cusp overlap view, then this is the optimal alignment. So like this. So usually we insert the system with the flush port directed to 3 o'clock, and then we try to position the head marker to the greater wall of the arch, and then in ascending aorta you'll have the head marker on the left side, and in Cusp overlap view, you'll have the head marker facing to the front. So that'll be the optimal position. And after implantation, you'll have the C pedal on the on this side, and the other pedal on this side. So if I introduce the system here, I check the position of the head marker in AP view. I try to have the head marker at face to the lateral, and then in LA view, I try to direct the head marker to greater wall. Sometimes as the system rotates, the direction of the head can be changed, so you have to withdraw the system and then adjust the system again. And then if you have like this in the LA view, head marker at the outer curve, and in coplanar view, you'll have this configuration, and in Cusp overlap view, you'll have the C-tab on this side and the other tab on this side. So this will be optimal alignment. So the introduction of Evolut F system in Korea is a little bit delayed, but this system has visible the depth markers, 3 markers. So it helps a lot to check the configuration of the valve system, and also it has a single spine shaft, which makes the system much more flexible. And as you can see here, 3 depth markers. Again, in Cusp overlap view, you'll have 2 markers on this side and 1 marker on the right side. So this will be the optimal configuration. With this method, there is a publication, Yun demonstrated with this technique, they could avoid the severe commissural misalignment in all patients, and severe coronary misalignment was only in less than 10%. So again, in the Cusp overlap view, you have to have 2-to-1 configuration for valves with 3 markers and 1-1 configuration for 2 markers. It is very important. So these are my take-home messages. Cusp overlap technique enhances implantation accuracy, optimized valve positioning reduces conduction disturbance, accurate commissural alignment, facilitate future coronary access, which is particularly important in young patients or valve-in-valve scenarios. Understanding the valve-specific markers is very important, and improved valve designs contribute to more predictable deployment, better visualization, and improved commissural alignment. Thank you very much.
Thank you. Very detailed description of the Cusp overlap and the commissural alignment method. Only one comment and question or question allowed? Any? No, you have made things very clear. Thank you very much, Dr. Ko. Then we will have Dr. Daisuke Hachinohe from Japan talking about coronary intervention time, pre, during, or post TAVR. Please.
Okay, good morning, ladies and gentlemen. I'm Daisuke from Sapporo, Japan. So I'm very happy to be here, and thank you for the invitations. So in this session, I'd like to talk about PCI timing pre or during post-TAVR. So this is our hospital case. In 2024, we did 200 TAVI cases, and also PCI cases, very, very high volume. So we have many PCI cases of the TAVI. And also we do Bajirika or TTVR or TTVR was the first case in Japan. So as for the PCI in patient with AS aortic stenosis, so this is our case, 85-year-old male. Oh, this is stopped. So moderate to severe stenosis at here, and the moderate stenosis here. So this is maybe 4 years ago case, and we did PCI for this region before TAVI. This is not working. So after a root ablation, we did balloon dilatation and implant synosis 3.0 by 48, and after that, we can see some delay at the diagonal branch, and patient has some chest pain comfort, but we stopped this procedure. But 2 hours later, so patient has some severe chest pain and fell into shock status, and we can see coronary delay at the diagonal branch. So we inserted the balloon pumping and did TAVI in this case. So from Rebusque TAVI registry, so PCI before TAVI and concomitant or PCI after TAVI. So this orange is PCI after TAVI. So in terms of all-cause death or stroke, PCI after TAVI is better strategy. So so why PCI after TAVI is likely better strategy? So PCI after TAVI can avoid ischemic compression in unstable aortic stenosis. Actually, aortic stenosis is the most difficult situation. So TAVI can improve microcirculation, and after TAVI, so we can assess coronary artery disease using FFR or IFR like that, so very accurately, and allows tailored revascularization only when truly needed. So if coronary access is preserved and the patient has stable coronary artery disease, so PCI after TAVI is maybe the optimal approach. So which patients benefit from PCI plus TAVI? So from Notion 3 trials, if patient has FFR less than 0.8 or more than 90% stenosis and diameter is 2.5 or more, so patient has fewer major cardiac events when treated with PCI and TAVI. So a PCI before TAVI led to unnecessary PCI and hemodynamic collapse. So we recognize the importance of prioritized TAVI first and performing PCI only when necessary at the appropriate timing. So our strategy now is the TAVI first. And if patient has very severe stenosis or patient has symptom even after TAVI, so we do PCI after TAVI. So when PCI should be done first, if patient has acute coronary syndrome, so we usually do PCI before TAVI. And if patient has left main disease or elevated proximal region, so PCI may be better before TAVI. So as for the PCI after TAVR, so there are some possible factors which affect coronary access. So I summarize these notions in this slide. So one is TAVI valve selection, and the other one is coronary risk playing, and the other one is commissural alignment, and the final one is space outside the frame. So I will explain each. So TAVI valves currently available in Japan is Sapien 3 and Navita and Evolutive FX. And currently, so Evolutive FX Plus is just launched. And difficulty in PCR TAVI. So Sapien 3 is actually very easy to engage. And Navita is the next. And previously, Evolutive FX is sometimes difficult to engage. So the coronary risk playing is very important. So until recently in Japan, very high implantation is some kind of a trend. So 0 position or minus position is very nice. So like that. But nowadays, we changed our thought to as low as possible thought. So this is Mary in his 80s, and membrane septum is 2.1, and we implant so as low as possible to avoid conduction disturbance. So if patient is, this patient has membrane septum 2.1 from CT scan, so we can implant just above the membrane septum. So this idea is very important to avoid conduction disturbance, and also we can easy to engage guiding catheter when we need PCI. So the commissural alignment is very, very important. Already Professor Ko presented this. So I want to avoid further examination, further explanation. But PCI can be very challenging due to these anatomic factors and the valve interference. So during TAVI, so we have to take care of this commissural alignment very strictly. And the final one is space outside the frame. So space within the SOV and the STJ and the valve size is very important, especially in the Asian patient. So, for example, this is actually a bailout case. Navita is popped out, and we did valve-in-valve TAVI procedure using Sapien 3, and we can see very narrow neosinus in this case. So in this case, we can stop the TAVR procedure, but 2 months later, so patient has had chest pain, and we have to implant left main stent, so like this. So this space is also very important for very small sinus valve, especially in the Asian patient. So as for the PCI after TAVI, so guiding engagement is sometimes difficult. So our friend Norio Tada and his colleagues published this paper, and we use this THB perpendicular and EMPHAS view when we engage the guiding catheter. So this is valve perpendicular, so we can see the valve like this, and we can identify the coronary height and the THB relationship. So this is the same patient, and this is aerial cranial view. So this is very deep aerial cranial, so we can identify the coronary axis, so the posterior or anterior, like that. And this is a SAPIEN 3 case. So actually, this case is not so difficult, but we can identify it using EMPHAS view. So slightly anterior side, so we can manipulate to the counterclockwise and engage very easily. So in the case of RCA, so sometimes difficult to engage. So in this case, slightly posterior, so we can adjust the guiding catheter within the strut. This is not working, I'm sorry. So within the strut, the guiding catheter should be clockwise and to the anterior, from the anterior. So we can engage like this. So this EMPHAS view on THB perpendicular is very important. So again, so this is very simple. So we can identify the coronary height using this valve perpendicular view, and also EMPHAS view can be identified coronary axis. So this 2 step is very easy to do the PCI. So nowadays we introduce role of virtual reality. So this is my junior, so he sometimes still using this simulation. So before PCI, using CT scan after TAVI, so they can predict the optimal axis. The left radial is better, or right radial better, or femoral axis is better, and the catheter type, and also the catheter size. So this is very useful. Actually, I don't really use this VR, but for junior, this is very helpful for PCI after TAVI. So nowadays, EvoluteFX is just launched in Japan. So there is very big window, and we may easily engage the guiding catheter. So this is our case. So this is a THB perpendicular, and this is EMPHAS view. So from this view, we can identify the big diamond window here, and here, and here. So like this. So if we can identify this diamond window during PCI, so we can identify the coronary height, and also which direction the diamond window is located. So we can control the guiding catheter. This maybe, but just in June we use this EvoluteFX Plus. So maybe this is very useful for PCI after TAVI when using EvoluteFX Plus. So the which timing, PCI timing is the best. So PCI may be performed for severe CAD involving a left main or proximal vessel in patient or in patient with ACS preferably before THV implantation. And THV selection is very important for coronary access. So commissural alignment is very important for PCI after TAVI. So it is essential to understand the structure of THV and the EMPHASIS view when performing PCI after TAVI. Thank you for your kind attention.
Okay, things may change after the introduction of the FX Plus. How's your viewpoint? You have already have that in Japan.
So actually, we studied the FX Plus from this June. I only used it in 2 cases. And I tried to identify the big hole, but it was a little difficult because it overlapped with other strats. But hopefully in the future, it will make our life much easier.
Maybe you can also make 3 dots at the top of the open cell. Yeah, Dr. Hong, any comment?
Frankly speaking, I learned your lecture is very impressive for me. I don't have any special comment. Thank you.
Thank you. Thank you very much.
Thank you very much.
Yeah. Then we invite Dr. In-Ho Chae to discuss complication during TAVR and how to manage. Please.
Okay, thank you, Chairman. So I'd like to talk about the complication during the TAVR procedure. So actually, this is the main 2 situation, the THV-related complication and the procedure-related complications. And the size mismatch and malposition and suboptimal placement and the paravalvular leak, embolization, and the balloon rupture is the THV-related complications. And the procedure-related complications, aortic dissection, annular rupture, and coronary occlusion, and conduction disturbance, stroke, cardiac tamponade, and bleeding. So from early TAVR registry, Korean TAVR registry, there's a high complication rate was permanent pacemaker implantation and bleeding and the following stroke. So the conduction abnormality after TAVR is related to 3 factors: ECG factors and patient factors and procedural factors. Usually atrial fibrillation, right bundle branch block, and then vascular blocks are related to high risk of conduction abnormality after TAVR. And patient age, gender, ejection fraction is related. And the procedure related is access route and then implantation depth. As I'd like to show my case, 70-year-old female. She already had right bundle branch block. The QRS duration was 164 milliseconds. And the CT angiogram showed like very heavy calcium in the valve area. And then annulus area was 464 square millimeters. And then coronary height was more than 10. The heavy calcium on aortic valve calcification between RCC and NCC extending to LVOT. So that is the little bit high risk for conduction abnormality after TAVR because of the valve itself eccentrically located in the membranous septum side in this special patient. So you can see here the final angiogram, Sapien 326, is successfully implanted in this patient. But this patient had a complete AV block, and QRS duration was 164. But you can see here, she got the complete AV block. And then during the follow-up in the intensive care unit, maybe 10 hours later, she got the bradycardia-induced non-sustained VT. So I had to implant a permanent pacemaker to her. And the next case is a 79-year-old male. He had a lot of comorbidity like this, stroke, and then CABG and MACE procedures, and the multiple PCI. And now he had very severe aortic stenosis. The ECG showed right bundle branch plus left anterior vascular block. The bifascial block is the higher risk for the conduction abnormality of the TAVR. So the diameter of the annulus was 24, perimeter 76. So you can see there's a little calcium around the valve. So this patient is a very good candidate for the self-expandable valve. But you can see here the valve depth is a little bit deep. But anyway, successful deployment of the valve, Evolut Pro 29. There was a 24% oversizing and very low precision. This patient had the AV block, so there was no improvement within 3 days. So I had to implant the permanent pacemaker. So what happened in the conduction system? As you know here, AV node is continuous to the membrane septum and the origin of left bundle branch. So this is the figure. So if you put the valve 15 millimeters past the annulus, this edge can touch the conduction system, but 5 millimeters past the annulus may be safe regarding the conduction disturbance. So already Professor Guo mentioned about Cusp overlap view. In this view, we can see the conduction system elongated in the Cusp overlap view. So this patient, so I used the Cusp overlap view to implant Evolut valve. The Cusp overlap was RAO caudal. You can see here. After successful deployment of the Evolut valve, there was no conduction abnormalities. So I started the TAVI procedure late in the 2017. So 7 years later in my hospital. In our hospital, it's not a big, large volume center, but anyway, so before adopting the Cusp overlap technique was a 20% pacemaker rate using the Medtronic Evolut system. But after adopting COT technique, so the implantation of the permanent pacemaker was 6.3. It's quite comparable to the Sapien balloon expander valve, 4.7%. And the accurate nail was only one. Now it's retrieved from the market. But anyway, and the 5%. So Navitor actually started Navitor last year. Every proctors, they didn't want to embolize the valve, so they recasted the valve in the deeper position. So that's why the higher the pacemaker rate. But anyway, it's not biased data because it's not randomized. But so if you think about the risk of the conduction abnormality after TAVR, we can divide and then select the proper right patient with the right valve. So what about the cardiac tamponade? 88 years old male. He had a severe aortic stenosis. So you can see here the calcium chunk and then heavy calcium around the annulus and the valve. this is a calcium chunk in the around the annulus. So I tried to implant 26 millimeters IFN3, and the position was very good. And then deployment was minus 3.7 oversizing. There is a parabolic, so I decided to do post-dilation. But 1 cc overfill, there was a 0.5 oversizing, but right after post-dilation, so he had a shock, and then you can see the pericardial tamponade here. After pericardiocentesis, the patient condition was not improved, so I had to refer this patient to the surgeon. So there is a annular rupture, the combined type, and so 1 to 3 and combined type. So the treatment for the aortic rupture is repaired by the surgeon. So the detection of aortic rupture is very important. The immediate suspicion and the early decision is very important using the angiography and echocardiography. And strategies to avoid the annular rupture, the first, you have to use small valve and a low pressure and slow implantation, inflation of the balloon expandable valve, and a higher deployment position, and avoid reballooning if necessary. And if it is necessary, it should be stepwise, use stepwise increase. And then use self-expandable valve may be a good option. And then the other option is surgical replacement. So this patient successfully deployed Acroneo 2 25 millimeter without any event, but she had a shock during the ICU stay. She had a pericardial tamponade. The CT angiogram and then thoroughly reviewed the procedure. There was nothing wrong, but she had a pericardial tamponade. So after pericardial synthesis, 3 days later, just the supportive care could recover the patient completely. So sometimes the pericardial tamponade is not the disastrous condition. The other complication is coronary occlusion. If the coronary occlusion had occurred, the mortality is very high. And so during the hospital stay, the tenfold high of the mortality, and 1 year follow-up period, the fourfold higher and the mortality. So if you check the risk of the coronary occlusion, you have to prepare the coronary occlusion. So if you have some question about the coronary occlusion, this patient is the longer leaflet length compared to the coronary height. Coronary height is less than 10. So in this questionable case, you have to check the angiogram and then simultaneous coronary angiogram. You can see the valve leaflet motion and then compromise the coronary flow. So in this patient, it's not occlude the coronary artery, so it's very safely to deploy the valve in this patient. And then what about the valve in Sabler case? So this patient leaflet was very long and have a calcium in the extended valve. So you can use chimney and the basilica technique in this patient, but this patient was not good for the basilica technique because of the valve leaflet calcium. So I chose the the treatment technique in this patient and successfully do the TAVI and SAVR. And then the patient had, during the TAVI preparation, the patient had hypertension. So it was related to the femoral puncture failure. You can see here. So I used the two coils distally and proximally in the rupture site of small vessel. And some patients had a shock after TAVR procedure. So you can see there was nothing before the procedure, but failure of the closure system. There's like a rupture. Yeah, you can. I could resolve this situation with balloon tamponade. So very safely finalize the procedures. So from our cases, you have to review your patient and clinical anatomical status thoroughly and make sure your weapons, your devices, characteristics of THV and all the devices, and preview and simulate all the procedures in your mind before TAVI procedure, and prepare treatment for any kind of complication. And the most important thing is suspicion and detection of possible complication as possible as you can. Okay, thank you. I hope to see you all in the ANCOSO 2025. Thank you very much.
Yeah, very excellent talk, and give us your experience on how to manage complications and the troubleshooting. Thank you.
I have
one question.
Yes, comment that he presented a lot of the variety of the complication, and that is that the real situation. We have to know that some presenters at our center, we did the TAVI procedure immediately without the general anesthesia. Procedure is less than 1 hour, and the patient was discharged. And the day after the TAVR, they advertised their outcome. But when we showed his cases, severe aortic stenosis, it is not a common cold. The patient and their family recognize severe AS is a very mild disease, easily treatable, and should be the discharge 1 day after the procedure. That is their perception. It's very different. And the second one is the annular rupture case is very severe. The calcium and extended, and the SAPIEN valve and the annular rupture. And when we this is extremely biased. My opinion is that in these cases I did the SAPIEN and make such kind of the serious complication. I cannot sleep in the day when I back to the home. Why I do it? And I never use it in the next such kind of patient. So I select that for the coronary, the rear access, and the others. But this case is, oh, what did I do? Really, really guilty feeling for the patient. That is the reality.
Yeah, thank you. Anyway, we should expect the unexpected and be ready for everything. Okay, the last talk of this session will be delivered by Dr. Alex Lee. Hi, Alex. Can you hear us? You are mute. We cannot hear you. Are you sharing your slide? Yeah, you are still on mute. Can somebody tell them? Alex, you are mute. Can you show the slide and turn on the microphone? So there are some technical problem. So now we need to troubleshooting. Complication of virtual meeting. Okay, we have you. You are still, please turn on your microphone, Alex. We still cannot hear you. Can anybody make a phone call? Or? Cancel? So there may be some technical problem. Okay, maybe we deliver the talk later, and we switch to the next session. Thank you. Alex, please wait for the fixation of the technical problem. Then we move to the next session and invite the.下一场的那个给我。Okay, we invite my colleague, Dr. Michael Lee, Cancel, 施志远, Junjie and Zhang 教授 online. Thank you. Wait a moment. We make a group photo before your talk. Thank you. Then
Joyce.
Please come to the front rows, and then we can make a group photo, please.
Please, all the attending experts and the staff members move forward for group photos, and you can see you can sit at the front third row and onward. Through this segment, Dr. Alex Lee will talk us through imaging optimization in mitral valve interventions. Please, Alex Lee.
Alex, please.
Hello， 聽唔到我講嘢？
可以。
聽到。
聽到了係咪？而家聽到，現在聽到我的。
Yeah， 很清楚 ，please。
Can you see my screen?
Yeah. Very clear.
Okay. So thank you. Sorry about the technical problem. Let me 他的声音，其他的声音能听到你的声音，请你把你的关掉。
我们这边的声音是不是要关一下？他是不是
其他的？
他那边是不是 echo 太大声？我这边也听到 echo。
请你好吧，你们这有些通过这个麦听到你的声音，请你把它关掉。Okay. So I'm going to talk about optimizing imaging in mitral valve intervention. I'm sorry that I cannot be physically present because we have another meeting crashing at the same time. So I hope that I will be available next year. So today I'm going to talk about mitral valve intervention and how to optimize the imaging. And this is my disclosure. So let's take a look of what is the mitral valve. Let's go back to the basics. So mitral valve has two leaflets, the anterior leaflet and posterior leaflet, and atrial septum and LA on the 3 o'clock and on the 9 o'clock. With that, we have these two structures. And then behind the mitral valve is the left coronary artery. The right coronary artery is behind the tricuspid valve. And then we have the aortic valve. In the home view, we want it to be at the 12 o'clock to make the surgical view. And we have beneath the valve, we have the papillary muscle. We have the lateral papillary muscle and the medial papillary muscle supplying caudate to each half of the mitral valve. And finally, we have the Carpentier classification. From the lateral, or the LAA, would be the ones, and then 1, 2, 3, and then the medial, most medial in septum is the 3. Okay, so let's go back to the mitral valve anatomy. So now we're going to do the TEE for the patients. Before we do the TEE in the cath lab, this is a very important trick. Ask the patients to be ask for a few pieces of cloth. Put under patient's right shoulder to tilt the patient up more, a little bit slightly laterally. This slight lateral position allow the heart to drop to the left side, and it will make your imaging entirely different from if the patient is lying flat. So it will improve your imaging. So you get something like this. Although sometimes may be worse, the apex will be point towards the left, like this one. So just a few pieces of cloth can make the image from cannot be seen to something like this. And then to make it even better, you have to do this. Move the TE probe up like this, and then retroflex like this. All right. Because the heart is a little bit tilted towards the downwards, so you must do this, and then your image will becomes like this one. So you mean more strict, and then with this kind of image, your X-plane will work. Otherwise, your X-plane can never be very nice. So you have to do this, and the X-plane will work. You can do the X1 at A1, A2, A3. With the explained work. Now, then you are able to, put down the probe. You lock the TE probe, but you put down the probe from this point on. So unless you are moving the probe to the transgastric view, which is not necessary, which is only rarely necessary in mitral clip, you are free from the probe. So you can let the probe rest, and no one likes a tie arm. You can use your both hands to control the echo platform. So you can free up the hands to do so. So that's how I do the TEE. Now we go to the TEE and go to the transeptal puncture will be the first step. The red area is the superior posterior aspects where we'll be performing the transeptal puncture. And this is a bicaval view around 90 to 110. And then we'll go to the short axis, which is 45 degrees. So we need this two imaging angle. And in the old days, we are asked to do a standard 4-chamber view, which is 0 to 10 degrees. But this view, you can see the purple line here. It can never, seldom possible to match the red area. So it's too low and too anterior. So nowadays we usually use do the reverse 4-chamber view with an angle of 150 to 180 to get the transeptal height and the puncture well within the imaging screen. And the transeptal zone is something like this. Something like this is the transeptal height, and usually it's about 4 to 4.5 centimeters. But if you are doing a commissure lesion, then you have to adjust your transeptal puncture position. So if you're doing a medial commissures, because the medial commissures is lower, is more towards the is here. It's a little bit lower than the lateral commissure. So you have to do the commissural, and you have to push the commissure more inferior, closer to the IVC, and use and the height you need to be higher because you need more room to turn the clips towards the medial commissures. And on the contrary, similarly with a lateral commissure, because it's higher, so you have to give a more superior to the SV, more superior punctures, and also because you have more room, so you like to have a more posterior kind of transeptal puncture to do the transeptal puncture. So, but importantly, we should actually use the 3D TEE to assess the transeptal puncture height, and more importantly, the relationship of the transeptal puncture with the commissural. So it's by here you can see the TE probe. You are looking at it on fast, so you can measure the transeptal height in this view. But more importantly is the transeptal puncture height and the commissural position relationship. So you do it this view. This is not more or less like a surgical view, and you counterclockwise rotate to the septum, and you see this transeptal puncture tenting, and this tenting has to be near to the commissures. Not too anterior, not too posterior, because this will give you likely the aortic hugging or the reverse aortic hugging. So then you morphology for the images. What you do to guide the CDS towards the mitral. So you just, this is what I asked the some new interventionists to do. So if we want the CDS to go anterior, counterclockwise the guide, and if you're going to go to posterior, then clockwise rotate the guide, and if you want to step down, sweep the CDS towards the mitral valve, and M0 will be used. And if you want to more lateral, you use the advanced destabilizer, and then more medial, you retract the stabilizer. So if you are doing a medial commissures lesions, then you can go to the explain and ask the patients. You can move the cursors towards the medial commissures, which is to the left side. And at the same time, the explained angle is not correct. You have to rotate it clockwise, counterclockwise, so both towards the left side, so that you can see the clip nicely. Similarly, for the lateral commissures, you by plane view, you move the cursors towards the lateral side, toward the right, and then you also turn the explained rotations rightwards, which is a more clockwise rotation to give you the good proper anatomy with the grasping view. Sometimes we go to the 3D NPR. We now doing more and more NPR because we tend to find it to be more able to anatomically correct. Especially we are doing the lateral medial commissures prolapse. So 3D NPR, some hard and fast rule here, and you want to make the frame rate as high as possible, so 8 to 10 hertz or higher. So it can be higher by reducing the volume of the sampling. So do not use full volume. Otherwise, you get a 6 hertz or worse. You do a 3D zoom on the mitral valve and then go to the 3D MPR. And you need to, the mitral valve focus, you zoom on the mitral valve and then start to adjust the RGB lines to make it anatomically correct. Usually, we want the green plane to be in the bicommissural view, the red planes to be in the grasping view, and then the blue plane should be a short axis view, and so on and so forth. And then you have to stay stationary. Now you don't need to move. You ask the interventionist to move. You ask the interventionist the images should stay fixed, and ask the interventionist to move the clip to the side of the best position, and ask the intervention to move the clip to the right position. And then you have everything in one wheel. You can confirm the position, the trajectory, the orientation of the clip arm and the gripper movement, all in a single view. Now you ask the interventionist to go into the LV, and then you can reconfirm the orientation of the clips by reducing the gain so that you can see the clip nicely. So the clip arm orientation has been confirmed right before you do the leaflet grasping, because when you enter the clip into the LV, it may change a little bit. So you should confirm it on an echo, but also on fluoroscopy, because on fluoroscopy you see the slight change of movements that may suggest you change the position, and you have to. And then grasping. So the clip is ready for grasping. You see the clip arm and the gripper there. It's leaflet. But if the X-plane is not clear, it's possible that X-plane is not having a higher resolution, because X-plane resolution is poor, and its spatial resolution is poor. Its temporal resolution is poor because you're gripping a large volume, so it makes the resolutions go down. So if that's the case, then don't hesitate to go back to X-plane. And X-plane, although it has a lower resolution, but it has a lower orientation, but it has a higher resolution. The resolution can be triple or quadruple. So you see the everything is clear on the X-plane. Finally, you done with the tissue bridge. You can see on the X-plane on the 3D. And it's very nice to look at the tissue bridge because it is a confirmation that sufficient tissue is being inserted. And finally, with color, of course, we use color Doppler on 2D as well. And finally, this is successful. So 3D, I've talked about 3D MPR on the commissural grasping. I think it's even more important than the central grasping. So you may need to practice, but this is very useful for this commissural lesion. So this is the simple contraindication for mitral clip. I think all the these are also important. These are always important, but you can easily pick up those ECKs like a central P2 prolapse or a narrow jets functional MR. So those who are rheumatic MVA less than 3.5, and there are lots of calcification leading at the grasping zone. These are the case that is contraindicated. So simple. Now, just one case left. I want to show you something about something relatively new. It's a 3D eyes, And we have 3D eyes available in various parts of Asia now. I think it's in Japan, they start to have 3D eyes this year. I think they already have 3D eyes. So there are 3 vendors of 3D eyes, Philips, Siemens, and GE. And GE has a rotatable head of the eyes probe, but unfortunately does not have left-right positions, left-right flexion. And its 0 degree has a much higher resolution than its 90 degree. Philips Ferrocite Pro, it has a left-right flexion. However, because of its rectangular head, its 0 degree is much higher resolution than 90 degree. But it's with a left-right handle, it can compensate for that. And then we have Siemens. Siemens, you have a unfortunately narrower sampling volume is 90 degree times 50 degree, but it has a helical array, so that the 0 and 90 degree resolution can be more or less the same. Now I'm showing you an interesting case. 74 years old with an atrial functional MR. Both atrium and both atria are dilated. The LV size is normal. The ejection fraction is 65%, but this patient has a severe atrial functional MR with an elevated NT-proBNP. And then this is a functional MR. You see the left ventricle is normal in size. The left atrium is dilated. There's a central apical atrial functional MR with a VCA of 0.6 centimeters squared. So we somehow start with eyes. We are doing this for no reason. We can do it probably with TEE, but we do it with the eyes just to test the eyes. But eventually, we found that actually eyes is particularly useful in this case, which I will tell you in the subsequent slides. Then we use eyes to do the transeptal puncture, the same as the using TEE, but everything is upside, is opposite. So, and then we entered the left atrium. This is the TEE. We use TEE as well. With the NTW at the A2B2 position, very nice. But we use eyes with the A2B2 at the with the NTW at the A2B2 position, and it's just exactly nice. It is very, very nice. You can see we do not need much adjustment of the. We place the eyes inside the left atrium. That's it. It's very beautiful. But we don't need it for mitral clip, but it's beautiful. Now is a time where we found that eyes may be needed in such a case. We put on the mitral clip. Everything is okay. The orientation is okay. The position is okay, but there is a residual MR jet on the lateral side, and it's more eccentrically oriented. So unlike the baseline regurgitation, its central jet is now changed its direction to eccentric jet. So make us suspect that this is something not related to the insertion, not related to the orientation, but something particular related to the mitral valve. So this is the apical functional MR at the beginning, and then it's the apical, and it's the atrial functional MR after putting in the one clip. What happened is when we use TEE to look at the mitral valve, we see there is a fibrocalcific changes at A2. It seems that it's only detectable on ice, but not on the TEE. Right? You see the fibrocalcium changes right here, and it's at the site where we put the clip. So it's actually, we suspect it is a commissural calcification. Maybe a grasping zone calcification, and we did not detect it on TEE, but we can review it using eyes. because of that, we moved the clip a little bit more medially and counterclockwise a little bit, and with that, there is no more mitral regurgitation result. You see, we grasp, this is the eyes, and we put on the clip here, slightly medial, slightly lateral to the this calcification. So we avoid the calcium grasping by using eyes. But it seems that TEE, in this case, cannot review the eyes at the calcifibrotic changes. So mitral clip was in place day one of the TEE, and bioresidual MR, no mitral stenosis, everything is happy. So I think that case, in this case, mitral valve may be examined more closely with eyes, that some pathology may be seen only by eyes and not by TEE. And with that, I would like to call to an end. I would be happy to answer any question. Thank you.
All right, maybe we can have 2 questions. And so you did a lot.
So, hi Alex, this is Kent. I remember the case that we did together for using the eyes. You're right that there's no reason why we use eyes for that case. It's probably, we're trying to, at the early phase, we're trying to explore the value of eyes in mitral valve intervention. So we know in tricuspid, the eyes has a supplementary value. So with your case, what do you think will be the major role of eyes, 3D eyes in MT?
Wait, what's the last question?
What do you think will be the major role of 3D eyes in MT?
Mitral clip,
Yeah.
I still think TEE should be the modality of choice in almost all mitral clip, but I think that eyes with it closer to the mitral valve, it may be able to pick up things like, for example, this case, fibrocalcific changes. I would not say TEE should be able to pick up true calcification. TEE can be able to pick up true calcification, but in terms of the fibrocalcific, so it's not full-blown calcium, it's fibrocalcific changes. Then 3D eyes may be able to pick it up, but the TEE cannot. And in fact, CT may also mean that because this case has CT done before the procedure and cannot reveal the fibrocalcific changes. So I guess this fibrocalcific changes may be picked up, or other pathology may be picked up by the eyes, with the eyes probe being so close to the valve. So it may pick up. So I think the role of eyes on mitral clip is if there is suspicions of some abnormal pathology, such as fibrocalcific changes that cannot be revealed by the TEE, then you can use the eyes to confirm it. You suspect that fibrocalcific change may be present by, for example, in this case, after put in the first clip, it's just some eccentric MR appear. So you know the orientation is okay from TEE, you know the insertion is okay, everything is okay. But after grasping, just a very peculiar eccentric jet appear. So this is something that makes you think of pathology such as calcium, such as fibrocalcific changes. So that's the time I think that inserting an eyes to look at it will be beneficial. But most of the case we won't use eyes. Yeah.
Well, Alex, Michael Lee here. Thank you for your very practical lecture. You know, we all hope that we can do these procedures under local anesthesia. So you mentioned 3D eyes cannot replace TEE for now, but what do you want to see in the improvement of 3D eyes so that it can eventually replace TEE?
So so every time I put eyes in my slide, someone will ask me about LA. This is what we want, but probably cannot be done right now because the eyes image resolution is good, but it's not that exact. Still, TE is better. So I deliberately put an eyes and TE side by side together. You can see that eyes is very, very good, but it's still the TE is better. So for simple valve lesions like a P2 prolapse, and especially with a pre-op 3D TE already done, for those cases, you may try to use eyes alone. I think can be done.
Oh, okay. Thank
you. Of course, better if they have in the first 2 cases probably a patient with contraindication to eyes, then will be more straightforward, normal to use the eyes. But I think in the long run, this simple mitral valve prolapse case or simple functional MR case can be done by eyes. But for those who are more complicated but cannot be done by eyes, as it has to use TE.
Yes, sure. Thank you again, Alex. Thank you for your marvelous lecture. Let's move on to the next session. So Professor Yin is going to introduce the next session.
Okay, let me have a brief overview of the TAVR for pure aortic regurgitation. As we know, there are many reasons or etiology of aortic regurgitation. Surgery is the gold standard for treatment. If untreated, left untreated, the mortality rate of severe aortic regurgitation is high. However, current guidelines still recommend wait for the symptoms, wait for the LV dysfunction, or wait for severe LV remodeling. Then the patient should send for surgery. However, this recommendation has not changed in decades. So we need a transcatheter approach to solve this problem. But to be honest, I am reluctant to do TAVR in pure AR without calcification before 2018. This is because that in pure AR there is absence of valve calcification, hypercontractility of the left ventricle, and excessive stroke volume, dynamic regurgitant jet, and the dilatation of the annulus and the artery root. All this may make positioning, anchoring, and difficult, and resulted in residual AR. So in early days, the need for 2 valves is more frequent in TAVR for pure AR without any calcification. Up to 1/3 of cases, including our early experience, showing that may need a second valve. 你们那个回音怎么那么大？今天的声音看错。So we may need some technique in doing the procedure, such as rapid pacing, two-tail technique to localize the button of to localize the annular ring, or use a safari wire to stabilize the device. Sometimes we have to use the second valve because it may embolize or mallocation. After the introduction of the newer generation device, such as the retrievable, repositionable device as self-expanding Evolute R, we can make things easier. And in some cases, we also tried to use balloon expandable valve to fix the aortic regurgitation. But in some case, we combine with mild stenosis. This is extreme case with mild AS and severe AR, we use 29 Sapiens 3 to fix the aortic regurgitation and aortic stenosis. So even with the newer generation valves, the result was still suboptimal. As you can see, the need for a second valve is still as high as 18%, and the residual aortic regurgitation may be significant more than the tricuspid counterpart. This is a latest registry data on second generation valve. As you can see, the technical success was relatively low, and in 12% of patients will develop valve embolization and migration, needing a second valve. So we are waiting for the transfemoral dedicated devices, which will be presented later by distinguished speaker in this session. This is one of them called Jena-Valve. The device has 3 dedicated locator or grasp to grasp the leaflet, and then the self-expanding valve can be put inside. In this way, we can eliminate aortic regurgitation successfully. This is another device called Jena-Valve. Similar mechanism, but different design, but end up with a very good final result. This is the earlier data. As you can see, with these 2 new devices, the aortic regurgitation can almost completely eliminated. However, before the introduction of Jena-Valve and the J-Valve to the Asia-Pacific region, we have to deal with this kind of case in our daily practice. So in China, they developed an Aurora AR calcification using self-expanding valve to treat pure aortic regurgitation. If you can find a secondary anchor point in addition to the annular level, then pure AR can still be treated successfully with self-expanding valve. I think Dr. Zhang Junjie later will discuss this in detail, so I skip this. Now, we can see that with this Aurora classification, if you can identify suitable cases, the device success rate can be achieved 91%. So in summary, in the foreseeable future, new generation devices, including the dedicated valves for pure AR, such as J-Valve and the Jena-Valve, are expected to solve the problem of AR. As with all TAVR, AVR identification of patients who fail to respond to TAVR, as well as those hyper-responders is important. I think conventional triggers for AVR will be re-evaluated in light of the ability to offer newer therapy modality for this patient. This is a paper published last year. As you can see, if we can identify this high-risk marker for AR patient, maybe we can treat them earlier. I thank you for your attention.
Thank you, Professor Yin, for your very nice overview of the problem here with the pure aortic regurgitation. Thank you. Maybe we can continue with our talks. Professor Yin mentioned about 2 dedicated devices and a self-expanding device. So we will examine them one by one. First, let's invite Dr. Zhang, he's online, who's going to talk to us on the dedicated device with the J-Valve. Please go ahead.
Yeah. I'm here. I try to share. You see it?
Yes, we can see very clearly.
Hi, Dr. Lee. Thank you, Dr. Lee and Dr. Yin, and thank you for the committee inviting me to share the Jena-Valve insight here. I really appreciate. As everybody know, and Jena-Valve, we have two versions. One is transapical, and another one is transfemoral. And transapical, we already had more than 10,000 cases. And the transfemoral just introduced a total probably around 200 cases worldwide. Lucky today, we do have some data, but first of all, I still want to continue for give an overview for those two devices. You can tell this first. This is the transapical. The device going in from apex and shooting out clasper, or you can call it a locator. The key difference is this locator can be a full open. It's open to the size bigger than the valve. The whole idea is that you can catch all the leaflet. For the pure regurg patient, the leaflet is so far apart, but this clasper still be able to catch all the leaflets. Once they catch the leaflet, then we lower the valve to the ideal position, then deliver the valve from there. So that's the transapical. And transfemoral is the same thing. I'm not sure you can hear they have a animation announcement. Yeah. So you can tell those devices in the principles similar. We use the anchor to locate the to the bottom of the sinus, and then shooting the valve accordingly. And that's the idea for the stenosis patient. But for the for the regurg patient. For stenosis patients, we don't have to, the clasper don't have to all the way to the bottom of the sinus. And the device can be deployed according to the most narrow area. And this is what you see in the deployment you see on the fluoro DSE. And this is similar to the both the transapical and the transfemoral is similar. And lucky we now have our little data. So I just overview those data. Transapical, we already have 10 years data. So the mortality only 34%. And the stroke, we have a stroke is less than 10% over 10 years. So it's quite good. And 5 years always only a 7.5%. And for pacemaker, 10 years only 10%, 5 years 7.5%. And the reintervention rate is very low. It's only 3.7%, which is the case indicate the valve deteriorate. Then will have to be a second intervention, whatever is the transfemoral or whatever is TAVI or surgery. But anyways, only 3.7%. We did pretty lucky. We follow up the patient patient very cooperating and coming back for the echo. You can see the echo result for EOA all the way to 10 years gradient, and the EOA still is reasonable. This is the AR patient, and it is the stenosis patient. Slightly changed, but no significant difference. And the paravalvular leak still remains 70 or 80% is non-trivial. Slightly little changes over the years, especially after 5 years to 5 years to 10 years, but no significant difference. But the result is pretty good for heart function. Both stenosis and the regurg, as the patient, most of the patient, of course, over around 80% is class 4, almost no normal, no symptom. But from 5 to 10 years, because the patient getting older, some patients show the class 3 or class 2. That's all, but valve function is pretty good. And also the 10 years, we show the ventricular remodeling. It's truly remodeled and from the disease over bigger and down to the smaller and the systolic or systolic. And also lucky we had 1 year our transfemoral data. This data is pretty good too. For 30 days, mortality only 1.6, and AV blocking 3.9 only, and the stroke, no stroke. And for full 1 year, the mortality is 3.2, and cardiac mortality only 2.5. And AV blocking require pacemaker only 5.5. The stroke is 2.4. And for the performance, the valve performance pretty good, and gradient and EOAs remain in the very, very reasonable range. Paravalvular leak, of course, is not much paravalvular leak, and also shows ventricular remodeling. And heart function is significantly getting better compared to pre-op. Thank you very much. And also, by the way, at the end, and this valve is the transapical valve. But at my beginning, at the end, this is the transfemoral valve. At the beginning, this is the transapical valve. Looks identical. Thank you very much.
Thank you. That's great. Because of time constraint, maybe we allow only one question. Any question? Maybe I can address to you, Dr. Zhang. It looks like the transfemoral data might be actually better than the transapical. Do you think in the long run, in 5-10 years, this transfemoral device is going to outperform the transapical approach?
Well, I'm hoping overall, the result is hard to beat the transapical device. It could be better because, well, it could be, and let's see down the road. But I still feel transapical device may long-term result may be better.
Okay.
I don't know. I see because transapical device is porcine root, and the transfemoral device is the bow and pericardial. This pericardial is thinner than the surgical valve, and the transapical valve is exactly as a surgical porcine valve. That's why 10 years result is so good. The transfemoral, at the early stage, 1 year is good, but I'm not sure after 5 years.
Okay.
Let's see.
Yeah, let's see.
Yeah.
But at least it's less invasive and more acceptable by the patients. But anyway, thank you.
Yeah, for sure.
Thank you very much for your nice talk.
Thank you.
Okay, let's move on.
So the next speaker is Dr. Kenso. His topic is a dedicated device at Jena-Valve. Dr. Kenso, please.
So thank you very much. This is Kent from Hong Kong. In fact, I like the J-Valve a lot, especially the transfemoral system. So, but today I'm going to talk about the Jena-Valve for pure aortic regurgitation. So here's my disclosure. So I know Professor Yin has gone through some of the backgrounds, but I will still briefly touch on the AR situation in Asia, go through some of the clinical experience of the Jena-Valve trilogy in Asia, and also share 2 challenging case examples. So we know AR is a little bit different from AS. On one side, it's because of the lack of calcification, but on the other hand, it's because AR is also commonly associated with aortic wood dilatation. And the prognosis of AR is actually quite similar to AS. So when patient has developed heart failure symptom, their 5-year survival is actually very minimal. It's only around 30-something%. So we need to identify these cohort of patients and potentially to treat early. So one of the other very specific area of aortic regurgitation in Asia is because although we have quite limited epidemiology data nowadays, but then from China DVD study, it actually shows that AR is actually more common than aortic stenosis. And in contemporary studies from Korea and also Japan, it's also showing a similar pattern, except that the AR patient tend to be treated earlier than AS, probably because of the chronicity that the disease has been there for quite some time, so the patient need to receive treatment earlier. So Professor Yin has shown us that there has been different approach to tackle aortic regurgitation. So we have a number of different dedicated devices on the way of development. J-Valve, Professor Zhang has shown us the transfemoral version, and I will focus on the discussion on the transfemoral Jena-Valve, the trilogy system. So the Jena-Valve trilogy is having a unique design. So it actually utilizes 3 locator, quite similar to what we have seen in the transfemoral J-Valve, but then it utilizes 3 different locators. And to use the locator to get into the corresponding sinus, and then to grasp the aortic valve leaflet and use a self-expanding valve to capture the whole leaflet. And at the same time, the valve platform itself also has a very large opening, and with the locator themselves aligned into the sinus, it will be able to achieve commissural alignment. So the coronary access in the future will be optimal. So the Jena-Valve trilogy comes with 3 different sizes. So 23, 25, 27, covering a range of perimeter from 66 to around 90. And the larger version of the Jena-Valve trilogy is actually on the way of development. So we might be expecting they will be able to treat larger anatomy, which is actually a little bit more common than aortic stenosis anatomy. So this is the delivery system of the Jena-Valve trilogy. So it's divided into 3 different portions for the development, for the deployment. So the deflector is able to try to bend the delivery system to try to get coaxial alignment to the different aortic complex. For example, more horizontal aorta, you might be able to flex a little bit more. The controller is helping to control the depth of the locator Whereas the whole system, you also can still manipulate to gain depth or shed depth during the deployment process. And the deployer is very simple, just one single button, you'll be able to release the valve. And most of the time, it will release under rapid pacing. So it's actually quite easy to learn the whole deployment. So this is the Aligned AR study. Probably most of us is aware because it's published years ago in Lancet. So it's actually showing very favorable result, high technical success rate, and also minimal residual aortic regurgitation, less than 1% after the Jena-Valve is implanted. Notably, that's one major limitation with this device platform is new pacemaker implantation rate is around 24%. And so that's why people has been looking into why this is happening, and there might be some further improvement in the upcoming designs to improve the lower down the pacemaker weight. So apart from the technical success, you can see at 1 year of follow-up with the Aligned AR study, patient treated with the Jena-Valve actually has very substantial improvement in heart failure symptom compared to baseline. There's also very meaningful KCCQ score improvement from 55 to 77, and the 6-minute walk test also significantly improved. So in US, they also perform a continuous access registry, which was actually presented by Raj Makkar in ACC earlier this year. In fact, the continuous access, the results actually largely comparable to the Jena-Valve AR prospective registry. The pacemaker rate is still almost similar, around 20-something%, and there is minimal regurgitation after the valve is implanted. And you can also see that there's actually improving trend in the paravalvular leak after with time after the valve is implanted. So at 30 days, around 17%, but then with time, it's actually gradually improved to only around 4.3% of mild or moderate paravalvular leak, probably because of the self-expanding platform design itself. So in Greater China area, the Jena-Valve is having a sort of limited launch. I know a similar version is having, they have computer study in mainland China, but this is the case experience that we have in Greater China area. So there, up to March this year, there is a total of 30 cases being implanted, and the technical success rate is actually more than 96%. The different valve size is actually quite evenly distributed, and a lot of these cases, because it's mainly based on operating on high surgical risk cohort patient, in some of the areas still on limited launch for compassionate use. So the anatomy is actually somehow more challenging than the prospective registry. So here we're showing a little bit of different types of cases that has been done out of these 30 cases, including extremely horizontal aorta of 80-something degrees, borderline coronary height, a mixed aortic stenosis and aortic regurgitation cases in case of LVAC, and also in patient that has undergone a DAVIC procedure, which was actually done in Taiwan, I remember. So then I will finish with showing 2 challenging cases to illustrate how this platform is actually deployed. So the first case is an 84-year-old patient that has pure aortic regurgitation. So you can see from the CT a little bit of very common findings in pure aortic regurgitation patients. There's no aortic valve calcification. Wood enlargement, wood dilatation is actually very common. For example, in this case, although I didn't show the accurate measurement, but then it's approaching around 46 millimeter in the ascending aorta. So there is ascending aortic wood dilatation. And at the same time, horizontal aorta is also very common in AR patients. So in this case, it's around 82 degrees. Otherwise, the coronary heights is okay. So based on the annular sizing, we are choosing a 25 trilogy platform. So the major challenge that we're anticipating is the horizontal aorta. So this is the setup wood angiogram. So you can see very horizontal aorta. So what we have done before is we already get a snare, preemptively snare the LV wire. Although end up we don't have to use it, but then this is one of the way that we planning to mitigate so that we don't have to get the system manipulate a lot during the whole process of time, because there's actually an aortic wood dilatation. So, but then when we have inserted the system, so this is what we do. We have the system actually comes with a very long delivery sheath, which actually get all the way across the ascending the aortic arch into the ascending aorta at the sinutubular junction. After we insert the valve delivery system, we then unsheath and expose the valve delivery system, and then we try to use the deflector to adjust the angle. Although in theory it can go to 227 degrees, but then because you have a stiff wire inside, so the angle is actually at most, in this case, is only around maybe 180, 160 degrees. We are not able to achieve more than that of turning. So we have an MPA catheter inside you, which help us to inject contrast, and then we will be able to locate how much depth we have and whether the locators were going into the respective sinus. So you can see, if we remember the baseline aortogram, this is far more than this alignment. So this is not at the correct position. So what we try to do is we have to get back the whole system and then try to get engaged into the respective sinus. So one of the primary objectives is we need to get the left sinus being engaged. If the left sinus is able to be engaged, then we will be able to push in the whole system. Then the valve will be self-aligned. So this is the primary objective that we have in the whole deployment process. So end up with some manipulation, we're able to engage into the left sinus. This is not yet at that moment. So after some manipulation, we are able to engage into the left sinus. And we actually changed to an AL2 catheter and confirm that the delivery system is engaged in the left sinus after some sort of manipulation, turning the deflection. And then we check whether the other sinus are also at the corresponding position. So these projections we have to find on preemptive CT analysis. So this is corresponding to the right sinus, and this is the non-sinus, and we have already checked the left. So then we decided we are at the corresponding sinus, and then we further push in the system, allowing it to lie more flat to accommodate the horizontal aorta, and then we deploy the valve in underwrapid pacing. And this is what we find. The last final aortogram, you see there's a little bit of aortic regurgitation. Partly it's because of the atopy, there's a little central AR, but then the paravalvular is actually quite minimal at the commissural region. So end up we don't have to use the snare. And this is the first case that we're showing. The second case, I'll go a little bit fast because the deployment is actually completely the same, except in this case, it's a little bit young, but then the surgeon turned him down because he's in critical shock condition. He has a low ejection fraction, 20%, mixed AS and AR, borderline coronary, a little bit longer than the coronary height is actually a little bit short compared to the leaflet length. That's why we have a little bit of concern. We don't want to do leaflet modification because this patient is having low EF of only around 20%. So we just want to keep the whole procedure simple. So this is why we decide to use the Jena-Valve trilogy. This is one of the value of this kind of like relatively young cohort of patient and also have borderline coronary. So this is after the valve deployment. You can see because of the leaflet capture capacity, this valve is able to deviate the calcified leaflet away from the coronary ostium and has the potential advantage of reducing the risk of coronary occlusion in borderline coronary cases. And one of the highlights of these cases, in AS, we need to predilate to allow the valve to be better expanded. This is a little bit different from AR. So I want to show this image because we either in J-valve or Jena-Valve, because they use locator or graspers to self-align the valve into the corresponding commissure. So corresponding sinus. So after the valve's deployment, there is a very high chance that this valve platform is able to achieve a commercial alignment. So as illustrated in this transesophageal echocardiogram, so this is left main. And why this is actually particularly important in younger cohort patients, because there is a potential of future TAV in TAV, and this commercial alignment will be of value. So this is actually one of the highlights of this case. So to conclude, aortic regurgitation is not uncommon in Asia-Pacific region, especially in Chinese population. A dedicated transcatheter device has been proven to be effective and safe in treating pure aortic regurgitation. And initial Asian experience has been very positive in treating challenging anatomy. And of course, that more evidence is still needed to treat low-risk cohort patient and wider anatomical application. Thank you very much.
Thanks for the excellent talk. Because the time limitation, we proceeded to the next presentation.
Okay, yeah. Next, we will have Dr. Zhang Junjie from Nanjing to show us how he has been using the self-expanding valve to treat pure AR. Junjie, are you there?
Hi.
Hi.
Hi, Michael. Can you hear me?
Yes, we can hear you and we can see your slides.
Yeah, thank you. Thank you, Michael, for your introduction. And also thanks, Professor Yin invited me. So I would like to present self-expanding valve TAVG system for pure AR in mainland China and also our center experience. So actually, for pure AR cases, annual mortality rate is correlated with NYHA function class. So among patients with severe native AR, only 20% with LVEF between 30 to 50%, and only 3% with LVEF less than 30% were referred for SAVA procedure. Advanced age and comorbidity were often given as reason not to offer SAVA. So among these patients, the annual mortality of untreated patients with severe AR is up to 20%. So up to date, the ESC guidelines still recommended for severe AR with dilated ascending aorta refer for surgery. So actually, different to AS cases, in the early stage, our pioneer in structural heart disease society try to use TAVI device previous used to AS to treat it with AR. So you can see this result comparing the first generation TAVI procedure for AR compared with second generation, especially the early stage of Trans-Apex dedicated AR valve. Actually, you can see the device success and also valve in valve, and also the certain mortality was improved. So far in mainland China, actually the dedicated transfemoral TAVR procedure device for AR is still unproved, including Jena-Valve and also Jena-Valve just presented by Professor Zhang and Jena-Valve presented Dr. Hachinohe, and also several bands of domestic dedicated valve for pure AR. Let me introduce some case. It's an adult patient, 85 years old with severe AR with LVEF only 32. Actually is prohibited for SAVA procedure. This case is enrolled to the Jena-Valve pivotal trial. Actually, you can see according to the CT analysis, the aneurysm diameter was 29, and the decision was made to select the largest Jena-Valve 27. The oversight ratio only 1.03. Actually, we do the general anesthesia with T and the guidance. We successfully implanted this Jena-Valve 27 for this particular AR without any PVR, and the valve works very well. And this is another case about the dedicated valve for severe AR. Also very elderly patient, 80 years old, with a severe AR with a dilated LV and ARA. But LVEF was preserved 57%. And also this case was also enrolled the domestic pioneer dedicated valve pilot studies. The aneurysm diameter was 25, and the decision was to select the 27 PNAR valve. The oversight ratio was 1.06. And also we successfully implanted this dedicated valve for this particular case. Actually, so far, we still don't have a dedicated valve. For daily practice, I think 4 years ago, our center started to use a self-expanding valve for the treatment for the pure AR with a high risk for surgery. This is a live case from our center to Hangzhou, China valve 4 years ago. It's 78 gentlemen presented with heart failure, echo shows severe AR, with LVEF only 20%. CT analysis, you can see there is no any calcium. And the diameter of the aneurysm is 27, and the LVOT 4 millimeter below the aneurysm was 30 millimeter. So decision was made to select the Vita flow. At that time, this is the first generation Vita flow. It's a non-retrievable valve. The oversight ratio only 1.08. So we do this TAVI procedure under general anesthesia with TE guidance, rapid pacing, and also we pause the ventilator. And with TE guidance, we can precisely implantation the valve. Actually, you can see it's a simultaneous guided the TE during the valve implantation. Actually, this valve is the first generation. During deployed, a valve was a little. You can see the position and the coaxial not so good. And we retrieve the wire during the deployed and very stable. We rapidly release the valve. This is the final result. The valve position is good. Actually, you can see the position is quite high, but it's stable. Also, this case has accompanied with a coronary artery disease. Before the TAVI procedure, we do the LAD and diagonal bifurcation standing. So this is the final result, and also this is the 6 months follow-up. You can see the echo show the patient LV function was significantly improved. The LVEF was 47, and the LV dilated diameter was decreased to 58. This is another case of our center live case transfer to the TCT AP last year. It's also pure AR cases. It's also elderly gentleman, 79 years old, with a severe AR with heart failure, but the LVEF was preserved. LV dilated diameter was 60 millimeter. CT analysis shows there is no any calcium. Ascending aorta was normal, 37 millimeter. And the aneurysm diameter was 23, and the LVOT 4 millimeter was also 23. So coronary and the sinus is large enough, and there is no risk for coronary obstruction. According to the CT analysis, we selected 27 Vita Flow second generation. It's a retrievable device. This is the procedure. We still use the Landquest wire. With the TE guidance, we successfully deployed the valve at the right position. This is the final result of the angio and the TE result. Show the valve position. The depth is 4 millimeter below the aneurysm. There is no PVR, and the valve works very well. This is also another early stage case, also a live case transfer our center to Chinese Society of the Cardiovascular Society Conference. Also an elderly patient with a severe AR with heart failure. And also CT shows there is no calcium, and the diameter of the aneurysm is 26.5. So decision to made select VitaFlow second generation 30 millimeter THV system. Oversight ratio was 1.11. And this is the procedure. Also, we use TE guidance to deploy the valve. This is the final result. Very good result. There is no PVR. Valve works well. This is the intra procedure. Show how to use the TE guidance valve position. Actually, you can see at the beginning of the valve deployment at the non-coronary cusp, we just at the level, deploy level at the 0, just at an aneurysm level. Then with the rapid pacing, we gradually deploy the valve under the TE guidance. So this is the final result. So compared with AS so far, according to our limited experience, we still use a TE-guided pure AR procedure. This is another case. I think 2 years ago, we transferred to thoracic conference. It's also the elderly patient with severe AR, with heart failure. It's also there is no calcium. And also this aneurysm is quite large, 29 millimeter, and the LVOT 4 millimeter below the aneurysm is 31. The ascending aorta actually not enlarged, only 36. So decision made to select the VitaFlow 30 millimeter with oversight index only 1.07. So still we use the TE guidance. For this particular case, according to CT analysis, the valve anatomy above the aneurysm also have the angle zone. So for this case, you can see the position is quite high, just at the 0 placing at the aneurysm level on the non-coronary cusp. This is the final result. The valve position is good, works very well. There is no NAPVR. This is the intra-procedure TE guidance for this particular case. Final result. Show result good. There is no PVR of this TAVI procedure. This is the final result. Actually, you can see after the aortic regurgitation was resolved, the mitral regurgitation was decreased compared with the baseline echo result. So, so far, according to our daily practice for self-expanding valve THV for pure AR, 4 years ago, our center, Professors Chen Shaoliang and I started the citizen AR studies. This study including 2 arms. One arm is a registry arm. We totally invited 4 mainland big center to participate in this registry. We totally included 79 pure AR TAVI procedure from the 2019 to 2022. At that stage, the most of self-expanding valve was the first generation. It's not retrievable. And another arm is a randomized study arm. This is the CDNR randomized study. We totally invited 15 mainland center to participate this randomized study. Totally, we included 210 pure AR cases with heart failure and also high risk for surgery. Randomized either TAVR procedure with VitaFlow or GDMT medicine therapy. The primary endpoint of this study is a 1-year composite endpoint, including all-cause mortality, disabling stroke, and rehospitalization for heart failures. In terms of the inclusion criteria, most important is CT analysis. The largest, the aneurysm diameter should be less than 85 millimeter. And also the ratio between the LVOT and aneurysm should vary from the 0.95 to 1.05. Actually, this is the result of the register arm. Actually, the mean age is 72, and also the LVEF was 52. ST score was 6%. This is a collab CT analysis. The parameter of the aortic aneurysm was 78. The parameter of LVOT 4 mm below the aneurysm was 82. Ascending aorta diameter was 40 millimeter. The calcium only 6 millimeter cube, and 75% of cases there is no any calcification. It's a pure AR cases. Actually, you can see this is a paraprocedural characteristic. Most of cases was under general anesthesia and also 100% with the TE guidance. All the cases is done from the femoral approach. Nearly 80% of cases we use a Vita flow. The rest of the part use venous A. Actually, you can see nearly 80% of cases we use the early generation device. It's a non-retrievable. In terms of very important parameter, oversize index, it's early stage. The oversize index is 1.15. Actually, you can see most of cases, 56% we use the largest valve. And this is a procedure complication. Of course, mortality only one case. In terms of second valve used, it's early stage, nearly 20%, and the pacemaker implantation, 27%. And this is a one-month clinical outcome. Actually, also, of course, mortality only one case. Valve in valve, nearly 90%. It's comparable with the early stage of TVT registry. And we got a 6 months clinical outcome. MACE is 36%. Of course, mortality was 5.1, and one case with stroke, and 3 cases heart failure rehospitalization, and new pacemaker implantation up to 31%. It's quite high, but it's the first generation and the early stage experience. In terms of the predictor of the one-month device success, there were two predictors. One is the STS score, another is aneurysm parameter. And you can see this is ROC curve, and also we calculated the aneurysm parameter, predicted the device success. The cutoff value was 18.2 millimeter. So we divided this patient into 2 groups. The small aneurysm diameter less than 80 millimeter was associated with lower rate of MACE compared with the larger aneurysm diameter. Among these 79 patients at 6 months follow-up, 42 patients got echo follow-up. You can see for this patient, the echo parameter was significantly improved, no matter LVEF and LV diastolic diameter or LV systolic diameter. So far, in terms of our randomized study, CDN-AR trial, we have started 4 years ago. Now, by the end of last month, we have completed all 210 patient enrollment. So maybe next year, maybe TCT, we will present our CDN-AR 1-year result. This is our protocol published in American Heart Journal. So, ladies and gentlemen, let's take conclusion. Transfemoral TAVR procedure with a self-expanding valve could be considered an option in pure AR cases, not suitable for surgery, with acceptable device success, and increased pacemaker implantation, and also improved the LV function after success TAVR procedure. Device success and clinical efficacy could be improved significantly in our patient with appropriate aneurysm diameter. It's very important for CT analysis. We should get to the right patient. CDN trial is ongoing. You try to demonstrate the benefit of TAVR procedure for PAR with high risk of surgery. Of course, the dedicated TAVR device with a transfemoral approach needed to be developed for PAR. Thanks for your attention.
Okay, thank you, Junjie. Because of time constraint, we can't really entertain any questions, but thank you for sharing with us your very excellent result with this self-expanding TAVI valve device. Thank you again. Thank you very much.
Thank you, Michael.
Hope to see you next year in Taipei.
Yeah, hope to see you. Yeah.
Okay, let's move on to the next session. Thank you, the panelists, and thank you, Dr. Chow. Yeah, we call upon the next panel to be on stage.
The next session is a live demonstration. Can I invite all the moderators and the panels come up to the stage? Okay, Professor Yin, Professor Lee, you're on air. Can you hear us?
Yeah, very clear.
So let me introduce the moderators and the panel to you. And our moderator, Dr. Kentaro Hayashida and Dr. Shi Junmin, Dr. Shi Junzhe, Dr. Wang Yan, and participating experts including Dr. Zhang Chia-Hsiu, Dr. Chen Kewei, and Dr. Su Junhong, and Dr. Huang Jianwei. So can you introduce your case?
Yes, today we will do a mitral valve involved case and with LAMPOON procedure. We have already set up the rail, AV rail, and we are going to do electrocauterization of the leaflet. And because of the time and also Xiamen has already ready for transmission. So we will do the case, I mean the LAMPOON and the valve implantation. And then we summarize the case after Xiamen's live demo. Okay? So now we have already set up the AV loop. And as you can see from the fluoroscopy and the hemodynamic, we are trying to advance the atrial catheter into the LV. And now you can see the hemodynamic tracing. It's LV. We want to keep all the time the atrial catheter is kept in the LV. And then I will pull on the atrial side.
Professor Yin, can I ask, because this is a failed surgical bioprosthesis.
Surgical bioprosthesis.
Which leaflet are you going to
We
cut?
are going to ablate the anterior mitral leaflet. Because the aorta, can you see the echo, 3D echo?
Yes, we can see it.
Aorta is at the 12 o'clock direction. So we want to ablate the leaflet, the positive valve anterior mitral leaflet. All the way, if possible, we would like to ablate the tissue from 11 to 12 o'clock. So we may need more than one cut. So we are now at the 12 o'clock direction, and I will pull. Okay. Pull. As you can see, I'm pulling the wire, and you can see. And you can see the leaflet at the 2 o'clock direction have been pulling up. You can see that? And then I release my wire, and you can see I leave the leaflet, and there is a small gap there. So now I want to do electrocauterization. So I pull up again.
So how much the energy you deliver?
Pardon?
How much the energy that you deliver?
I will use 50 watts. Okay.
Yeah, ready.
Oh, okay, we will make cutting.
Cut. Okay.
Okay, stop.
Ready.
Release.
Long axis.
Please see the long axis.
Color.
Any change of the MR degree? Any change?
As you can see, there is a small jet. Just align the outer wall. An eccentric jet. It's small. You can see that. Can you show the baseline echo?
Baseline, okay.
So everyone can appreciate what we have done. The baseline one.
Okay.
Okay, wait a minute.
Baseline.
Okay, this is the baseline echo before the LAMPOON procedure.
The microphone is up. Please,
we can hear.
Microphone.
And now we see this is the live picture.
Okay. Not pretty much change. So we may try to ablate more tissue at the 12 o'clock and 11 o'clock. So in phase view. Advanced caster. Advanced caster. 进去，直接进，直接再进，再进，按 fresh 一点。OK， pull up。你太深了，你要看，你要 ventricle 的 pressure。
Sometimes the wire goes to the commissural.
Now to the commissural. Please advance. Astato. More. Can you show the Achilles? Achilles, we advance Achilles. Okay, unflex a little. Unflex. 太深了。我拉一下看看。As you can see, now we are attaching the 11 o'clock. 永再出来一点。Okay, can you see that?
No.
好，等一下，我是不是太近了？好 ，OK。OK, stop.
来
OK, evaluate again.
Can you change the T to the major screen?
Yes.
Yes.
A lot of MR already.
I think we have new jets, one to the right and one to the left. Dr. Liu, can you show the before and after imaging?
Okay. Okay, this image is before the procedure. And this is the live image. But we change a little bit scale baseline here to
This is the same scale, please.
Style of the MR. But
so would you use the cursor to show the new jet?
New jet, okay.
It's from here.
There is some small MR jet.
You mean the new one?
Aligned, yes, the new one aligned to the IAS area.
And on the opposite side?
Yes, in the opposite side.
No, I mean the.
If you look at screen, this point, I point this.
Is that the new one?
No, this jet is the former one.
Okay.
And this jet is a new one.
Okay. And can you show the in-face view to see the tissue?
Yes, of course.
So
the 3D view. Do you want the color?
no, I want to compare the before and after. It seems that we have a braid tissues at the 11 and the 12 direction.
The liver seems to be cut.
Yeah.
And how is the hemodynamic? Is it stable?
Stable, stable. Now it's 120. Okay. I think we have a braid enough tissue. So we will put the suffering wire into the LV. 你要进去一点，你要进去。
没有没有，对。
Caster，不，你抓好，对，要不然你转错方向了，对，不要急。
管子要先。
The Agility is still in the LA.
Agility 可以 advance 一点。Okay, we have get in the LV. Then I remove the caster. 等一下，你不要动。We will keep the AV loop for safety reason and do the valve implantation.
Valve 那个 septostomy.
Okay, 不要急，慢慢弄。
So how big is the surgical valve and the what name of the surgical valve?
等一下，讨论好了吗？好 ，unfreeze 了吗？抓好了 ？Yes。
Dr. Chao, this patient is receive mosaic 29 millimeter valve.
Okay. Different.
So mosaic.
What's the ID?
Yeah, what's the ID?
有到吗
24.
不好意思，确认一下。谢谢。
Can you show the Intellectual Chapter?
没有过。
No.
Different.
要出来进去了。
So what size of the balloon to do the septostomy?
12.
12, okay.
Inflate. 没有 no different.
Are you sure it is the system?
No. So we are advancing the.
Yes.
Yes, please. Oh, you see the waist.
Yes, it is.
So can you show the slide of the positive valve structure? I mean, we'll wait 1 or 2 minutes to inflate. 就是秀一下病例，那个 valve 的部分。
So during septostomy, we have prepared a valve. This is a mitral valve valve with a relatively small LVOT. 71 years old female, she got in for short breath and she had the episode of IE few months ago. Now the MR becomes severely and the coronary artery become less only okay. And the STS is 3.2. The patient was mobilized, and because of she hoped that she did not receive any further sternotomy, so she underweight the mitral valve involved. Next. So it's a baseline echo, and I think the severe MR quickly show here, and residual. There's a IE tissue over there. However, we check a blood culture 4 times. There is no blood culture positive evidence. Next. And the multi-site CD show here, the area is 382. The valve simulation is just like our left, and you know that's a mosaic without any metallic ring inside. So our landmark is upper cone. That's a 3 dot, 3 circle, small circle over there, and the AMA is 115. The LA diameter is 5.2. Next. And for app, the true ID is 24, and you can see that it's unbreakable. It's fracturable. However, we do not do the fracture because the neo LVOT is relatively small. So the neo LVOT is 131, and the valve to septum is distance is 7. And the puncture side, I think, is okay, and the septum is a little bit thickening. And I think it's a sapien 3 26 millimeter with 4. However, we think that 4 is around 10% oversize, so we add 1 cc more. Next. So today's procedure is right common femoral bend for the access, and we use the cerebral protection device. Tip to base LAMPOON was done just minutes ago, and today is sapien 3 26 minutes, 1 cc more. So that's now we remove the sheath.
So Dr. Lee, because the neo LVOT is small, 130, but according to our own data, if the neo LVOT is greater than 90, it is safe. The LV or OT obstruction risk is small. So in this case, why do you do the LAMPOON procedure? It's
90 should be after LAMPOON. So that we have never with neo LVOT obstruction. However, that's because in the literature 117 or 200 at least in the cases of the patient without LVOT obstruction. So the prevention is more important than the treatment, so that we do the LAMPOON first. Now you can see that we use the expandable sheath, and there's a transfemoral system of the sapien. And
the what?
Okay. And sometimes you should watch for the vascular injury. There's several cases reported. The venous system still have some vascular complications, so that if the device cannot pass through.
Why?
Freely, you must take care for the vascular injury. And then that's because IVC is not long enough, so that we will remove sheath a little bit. Now assemble the valve. So remember that always the E face down, and the E face down can later we will angle the commander system, so that we will face to the mitral valve.
Okay.
So for the mitral valve, you don't do the pre-dilatation of the valve?
No, for this case, we won't do because of severe mitral regurgitation and only mild stenosis.
Okay, boy. 等一下。Okay.
Much resistance the septal.
Yes, yeah.
Now it's called the septum, so that's a lot of VPC, so we saw the wire a little bit. So the landmark is 3 circle there. Do you see that? and remove the. Now we could remove the acetate wire.
So you align the outflow of the valve to the markers.
Yeah, it's a hard, very difficult. So that's
小心你的本的点，地方深一点没有关系，等一下再轻轻往外拉。
那3个点是最上面。
对对对，我知道。
要按。
我现在 pull back, pull back. Okay, I'm adjusting the coaxiality. And then I pull back the push.
The AV rail is removed.
Yes, removed.
AV loop have been removed.
Unflexible. Okay, so that's I think the trajectory is okay.
I release the lock. Lock. Okay. Advance a little.
现在是3个是最高的。
对，所以最后你还是要可能要调这个。
Okay.
哦，对。
So we start the inflate valve, passing on.
进去一点，是 OK 了。
All the way。
等一下，不要急。1、2、3、4、5。好，对底。
Passing off.
OK.
So you can saw a waste over there. Please, Dr. Liu, say the echo result.
Evaluate the.
It's okay.
I think the configuration is okay. And as you can see, we aim at the 3 small circles of the valve commissure post. So in this way, we can make sure that the atrial position and the ventricular position is about A to 2. 2 to A, I mean.
Post die.
Okay, we post die. Put it on.
So any affection to the LVOT?
Yes, later we will evaluate that. We have at 1 cc. Okay. And we pull back.
换回来一点。
你要留吗？
我再留 A 就好了。
Okay, you pull back. Unflex.
不要，
Unflex.
不要留。
不留的是吧？
再留在 LA 就可以。
好。Okay.
So Dr. Liu, please evaluate the echo.
And also the LVOT flow.
Okay.
As Dr. Cao, you asked before, usually we measure the near LVOT. If it was below 170, we will still do LAMPOON, even in mitral valve involved, because we cannot guarantee a 100% safety. And up to now, we have done 7 or 8 valve involved LAMPOON. So the result was really good. But for every mitral valve in ring cases, because the anterior mitral leaflet has not been removed during the surgery, so we cut all the anterior mitral leaflet in mitral valve in ring cases. And we found that after the implantation of the transcatheter valve, in valve case, there has been no any case of LVOT obstruction. However, in one patient with a near LVOT of 190, but the patient has a really long anterior mitral leaflet, 3.5 centimeter. The leaflet still was stuck into the LVOT and cause a residual gradient. So in that case, we have to send the patient for surgery. So nowadays, the cutoff of transcatheter mitral valve replacement for valve in ring, we still follow the cutoff of 190 or 200. But for mitral valve in valve,
we can accept that if the new LVOT was below 100, it's doable.
So there are three leaflets, and you only cut one of the leaflets. So how about cut the two leaflets? Is there any help?
The other two leaflets on the opposite side. So we only cut the leaflet face the aorta and the LVOT.
So Dr. Liu, please report echo result.
Okay.
This is LVOT.
Yes. We do the LVOT pressure gradient measurement.
We cannot see the echo.
Echo.
Oh, this is the LVOT. Oh, okay.
This is the LVOT pressure gradient. In mean gradient about 4 millimeter mercury. We do it at the transgastric view. And now we recall the data. You can see that this long axis view of the valve, the mitral valve seems very secure and the position is good. The pressure gradient is about 5 millimeter mercury mean pressure gradient. And this is the end phase view. And we see a minimal paravalvular leak at the lateral wall and a little bit at the posterior wall, but I think it's fine.
I would like to show the end phase view before and after cutting.
Okay.
The native, I'm the surgical valve. Surgical valve.
Surgical valve, of course.
Before we did a LAMPOON.
Before the LAMPOON, okay.
Before and after LAMPOON. So you can appreciate what leaflet we are dealing with.
Okay. Here is the valve before the LAMPOON procedure, and we show the color.
As you can see, there are tissues in the at the 11 to 12 direction and some small tissues on the 12 to 2 o'clock position. And after LAMPOON, please.
Okay.
As you can see, we make a big hole all the way from 11 to 2 o'clock to 3 o'clock. And the aorta is at the 12 o'clock direction. In this way, we can cut almost all the tissue facing the aorta. So in that way, no tissue will be sucked into the LVOT after implantation of the transcatheter valve. That's the effect of LAMPOON. So it's a successful one. Is that okay? Because Xiamen has already prepared, so please see the Xiamen's live first.
Okay, thank you for the very successful procedure and congratulations for the good outcome. Thank you. Bye bye.
Thank you.
Okay, next we come to Xiamen, and Professor Wang Yan is going to show us the case. Professor Wang?
Hi, hello.
Hi, this is Michael Lee speaking. We have a group of panelists here from Taipei Valves 2025. We welcome you on board and please show your case.
Well, thank you. First, I thank you for the Taipei Valves Summit to invite us to live demo this case. And thank you, Michael Lee and all the panelists there. Actually, I just, in our lab, we already showed the previous case, very nice mitral valve case, very successful, use the LAMPOON technique. Today, we are going to live demo a case for mitral regurgitation with the TEER system. I would like to introduce my team, Dr. Chang and my fellow from Mahmoud from Egypt and Chie-Hsiu Echo and Dr. Yan, anesthesiast. So here, I would like to invite Dr. Chang to introduce a brief history of patients.
Good morning. This is a case summary. She's a She's 87 years old lady. He has a very complicated clinical history. Before 10 years ago, he implanted pacemakers cause of 6 sinus symptoms and have 9 years long of atrial fibrillations histories, and also have hypertension, chronic kidney disease, and he have disappeared for 2 years and of ratings for almost 1 month because echo shows function MR degrees 4. And this information shows BNP shows more than 3,000 and a little low eject fractions about almost 50%. Next. So this is STS score shows 70.1%. Next. So this is EKG shows AF. Next. And this is a baseline TTE shows normal about eject fractions is 51%, but enlarged right ventricle and right atrium and enlarged left atrium almost about 79 millimeters, and the very height of PSP shows he was pulmonary hypertension about 75, and this is a baseline CAG normal sequence. And next. So we know we already do the right heart catheters before 3 months ago. 3 months ago, the mean PAP shows almost about 14, and the PAWP shows 23. And so, according to the right heart catheter result, it is a CPC PH, and it is widely high risk of adverse prognosis for this patient. So today we also do the right heart catheter test again, and it's also very high, about almost 14 mean pH and 27 PAWP. So this is a baseline strategies to do maybe mitral tears, maybe is good for this patient. So the anterior leaf list shows about 29, and the posterior leaf list shows more than 10 millimeters. Good anatomy atrial function MR to do here. Next. Thank you. So it's all.
Okay, thank you. So I think this is a case. It's a true FMR case, and it's a pre-FMR. The left atrium site is around 70, 75, something like this by echo.
79.
79, yeah. So we do a right heart catheter, try to now also left. We measure the left atrium mean pressure is 27, and systolic left atrium.
Systolic about more than 54.
34. The mean is 40. Mean is 40. Pulmonary artery. So pulmonary pressure mean is 40. Systolic is 70. 74. So yes, 64. So as we know, for the micro-TEER, all the research we if it's more than 70, it's some not included in this special cases. But for these patients, I think it's almost near the 70 systolic pulmonary artery, and left atrium pressure is high, and the PB PAWP is 27. So I think the patients got a lot of symptoms, and we hope the severe mitral regurg repair, we hope to repair the mitral valve can help for the patients. Because the patients previous use pacemaker lead also got a severe tricuspid regurg. Several years ago, the tricuspid is a severe, and mitral is a moderate. Now, the mitral got a severe regurg. So I think this is a 87-year-old patients and a high-risk surgeon. We try to repair the mitral valve. So here's the audience. I would like to use suggestion. Is that okay for this patient to do the repair?
Yeah, I think 87 years old, she's definitely not a surgical candidate. We have surgeons here, maybe they can comment. But for me, I think 87 years old with a lot of comorbidities and a very frail lady, surely she's an indicated patient for a transcatheter approach to repair the mitral valve. Any comments from our panelists or our surgeon?
I think this case is very risky patients, and also that I think not only the agents, the valve disease, they're also involved in the tricuspid valve. So I think this case is a candidate for the transcatheter valve. Okay.
So, Kentaro, you want to comment?
Yeah. So this is a very nice case for transcatheter therapy because the patient is quite elderly. And if we look at the leaflet, it's quite flat. So maybe we can, I would choose the mitral TEER with the mitral clip NT or maybe XTW. But we need to be careful that not to lacerate the leaflet at all. And the patient also have the tricuspid regurgitation, so we also need to think about the treatment of the TEER later, because my good friend Yohei published the data from our OCEAN Mitra Registry that if the patient has a residual TR, the prognosis will be bad. So we can also think about tricuspid TEER or TTVR. So we are included in the trial for the EVOQUE trial and tries in Japan, so the result was great. So maybe the combination of these procedures will be improve the prognosis of the patient.
So Professor Wang, I think we have the consensus that transcatheter approach might be more appropriate for this elderly lady. So which device are you going to use?
Today we select mitral clip, the G4 system. Can the echo student show us previously we got the echo? 从第一张开始来。哦 ，OK， can see yeah， 一张一张来 ，OK。OK。没有，就放那个 by commercial and this is by commercial. Yes. Yes, we can say. We see. Okay. It's a severe regurg used by commercial valve and go on, please. The posterior leaflet is relatively short, but it's at least 10 millimeter. It's a jet from the mid near to the medium. Yeah.
It's a A3P3.
Yes. You can see posterior leaflets a little bit restricted compared with anterior leaflets. And then second.
Okay, this is A1P1.
It's A1P1.
Yeah.
No jetting A1P1. Yeah. Next.
Yeah.
Yeah. Yeah. This is a. Yeah, this is a 3D. This shows a 3D. Yes.
Yes.
Add color, please.
Yeah. This is color.
Yeah. So I think we would like to choose a first clip STW to do the. Do you agree?
Yeah, it looks like a wide gap. XTW would be good. So your first target is over which position?
No, I try to go to the because the microvalve area is big enough to stick around 6, right? I would like to A2, P2. The most color comes from maybe A2, P2 near 3, right? And 2.2 or 2.5.
Okay.
Okay, I try to call to the student. 你给我那个左旁的那个我的 guiding 进去看看。Okay, this is my little bit, yeah. 我再把 sheet 推一点点，
Okay.
Is my sheet still inside about 1 centimeter? Dr. Chen Xiang punctured us about around 3, 4, near 4 cm because the huge one we don't want to puncture too high. It's around 4. Okay, my clip is a straddle. Yeah. Yeah, we check the orientation and use some M. Then like cut M.
Okay.
Yeah, more M. No, 你还是给我看那个，我已经很厚了。Okay, it's a fray. Distal is a fray, right?
Okay.
It's
Okay.
It's a lot of hug. There's lots of problem there. Okay. Yeah. We're almost there. Need more parts. More posterior. 就是你打一个标准的 bi-commercial view.
Okay. Okay.
你的 commercial view 打得更好一点点。
Okay.
Because it's enlarged left ventricle, so maybe the left ventricle.
Yes,
Okay, let's explain here. Yes, okay, explain. Yeah. Andy. Okay. 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 Shit.
Almost A2, P2. Please show me the color. Yeah, I would like to move a little bit to the medium side. 再速人再往 medium 一点点哈。
OK， 好。
Yeah， 再看一下来。
看了。去掉吧。
Maybe it looks like a little bit the air hugger and the meter trajectory.
Yeah, a little bit aortic hugger. So I would like to, because it's give some class to say any help for the aortic hug. Yeah, it's better.
Yep.
Now it's better, right? Got some hug, give some mic class. That's okay. Okay, please show the color. I think maybe this is a right position for the first clip.
And I also don't see the trajectory of medial lateral.
Yeah. 我们看一个，来 ，I try to the trajectory，速率我看看弹道怎么样，应该是可以的，好像有点 too much M，right？I try to reduce some M.
You can release M.
Release some M, yeah. A little bit M, more M. Okay, color please. Okay.
Okay.
Better. Now it's better, right? We can still release some M.
Yep.
Release some M and pull back the system back a little bit. Okay.
Put some plus maybe?
Yeah, a little bit plus. So for huge HMR, always a problem to get a very good position vertical to the valve area annulus. Right. Let's try to again, still 2M, much M. 是不是你给我一个标准一点的 ？OK， 对，这样好一点啊。
Maybe we should do some. I'm sorry. Maybe we should do some retroflex of the TE probe. It's still foreshortening now.
Oh. 你这边转一转你的 probe， 是不是？把那个心尖部打到最底下的方向最好。但是我的那个 case 我退了很多了，我怕都退出来。你 check 一下我的 case 还有多少，看看是不是？
对 ，2D。Yes。测一下那个。
Still 1 centimeter, right？
对。
One more, OK， 还可以退 ，OK， that's good。对，来回来吧。给我打一个比较好的，对。Oh, now it's better. OK， 够了。舌头你要推一点吗 ？OK。
再往左一点。
好，苏乐，你来给我调好 OK。好，我看看啊。但是你的 commercial wave 现在的弹道是可以的，但是 commercial wave 有一点点来的不是很好。啊？还行。变漂亮。这个你先给我打一个比较清楚的好的像。对，好，
来切一下。都看 ，OK。
前面还有吗？
角度有没有那个140？角度调一下。对。
前叶好像是跟那个夹子有点靠上了哈，
图形大一点。
你们推不出来了。
对，知道。深度再调试。
没关系，听下去呢。
深度调试，然后再放大。OK。
可以，是不是？再开了看看来。This time the trajectory is good. How about the 3D 你给我看看来。
OK。这样子。快一点。OK。OK。
color, please. Yes, this is the most color come from. I would like to. I think the orientation according to the X-ray is a very good orientation. Yeah, 回来 2D 来。
2D explain.
I try to open.
Try to
the clip here, right? Yeah, yeah. Open a little bit. 长一点点啊。Open. Open.
Did you check perpendicularity?
Attack. Okay.
I think they're checking it now because it's crossed the valve already. Yeah.
Okay.
Good idea. So it checks the orientation now.
Okay.
So 1 o'clock is clockwise, counterclockwise a little bit.
Okay, 再小一点。
关小一点。
对 ，OK， 就这样别动。
45 degrees.
No， 它现在旋转啊。好，现在12.6，传一下，传一下。
苏哲，你的声音小一点点，要不然都听到。Need more counterclockwise. Okay. 来，回来看，是不是 2D？ Anterior is inside, the posterior is.
Could you please put the echo image in the main bigger panel? Thank you.
I think both anterior and posterior inside. So then you just stabilize your echo.
Okay.
And then the anterior inside, right? Also the posterior inside.
Yes.
And show me the color.
Okay.
Yes, I think it's a position. 再看清楚一点啊，我们再 check 一下 orientation。
Okay.
可能就在这加第一个架子。Orientation, please. I think it's a not that well 6, or just need a little bit counterclock.
Yeah, maybe a little bit, but it looks quite good already.
Okay. Okay, back to the 2D. So the anterior is well sitting and posterior sitting in the arm, right? So do you suggest simultaneously grasping or independent for this case?
I think we can do simultaneous. Have you checked for independent grabs?
I'm sorry, I forgot to
That's okay.
check.
That's okay. Yeah, maybe.
So we try to, yes. Is the posterior enough or more posterior?
I would open the clip a little bit more and pull back more.
Okay, a little bit more posterior and back more, right? Yes, you're right.
Pull back more.
And yes, back a little bit more once. Now it's higher. 等一下，我再往 posterior better, huh? Okay, 准备 ready for diastolic down. Anterior inside, I can't see the posterior. How about the posterior? You can see the anterior bouncing, posterior seems good, right?
Maybe the
both
posterior
looks
movement
good.
is not as
Okay, both look good. Closely,慢慢的 close. Close, close a little bit. I think then close a little bit. I give you some close. Close. Lock. Lock. And close. Close. Close all the way. Close. Close. I think I'm satisfied with the posterior. Because the posterior only 11, we left around
very
2, 3, and 3 should be 8 inside. I think it's okay. Very close to.
yes, it's all the way.
Okay. Dr. Su, can you check the color, please?
Okay.
It's much better, right?
Much better, yes.
Small jet from the lateral. How about the
Yes.
medium?
I'll try
How about
to
the medium?
it's,
Check the medium.
It's,
Okay. I think medium is okay.
yes.
So, Michael, what do you think with the first clip?
I think the first clip looks very good already. It reduces the MR quite a lot. But still maybe mild. Let's see.
I think posterior residual about the 3 mm. That means previously measured 11 or 12.
You got
should
8
be at least 8 inside. It's enough. And 3D, how about check the 3D line?
Okay.
On that.
This is left ventricle.
之前的呢
28, 27.
Okay, color, please. I think it's good. Most of the color come from the left. Maybe after we before this clip, and maybe we can put another one in the lateral.
That's right, yeah.
I'm satisfied with the first clip. What do you think?
Yeah, can we check the gradient as well? What's the gradient now?
Okay, grading, student. Let's grading.
Yeah.
Grading. Huh? Okay, after the clips, the blood pressure raised about 20.
124.
Gradient 2.7.
Yes.
7.
So if you agree, I would like to release this clip.
I think it's good to release. Yeah.
Okay. 来，所有人 check 我们的家准备释放来。
Okay.
One hand here. One hand stabilize here. 来，所有人，我们准备释放啊。
Okay. 放大点。
It checks the lock function is good. 快点，快点。Yeah, check lock again. It's good. Okay, close. 安全阀打开。Yes. Okay. Turn 8， 把圈多一点。可以了吗？ Okay, the first clip is very stable according to the X-ray. Yeah, 是不是看知道我的 guiding 出来一下 ？Because I got a lot of 大鞘深度够了。OK。夫人，你 check 看看二尖瓣吧。It looks very stable of the first clip. Is it? Yeah, color please. It seems to split the color. 所以你 check 一下左右来看看。靠着夹子取样线放那角干嘛？取样线靠着夹子吗？打个标准的 commercial， 对对对对。来左右把取样线移一下，看看那边左边。有一点点。来右边来。OK， 看看 3D 了。This seems clipping the middle, we split the color.
Yes, the medial side seems to have a little more MR after release of this mitral clip.
Yes, yes. And I would like to put the second one to the lateral of the first one. Agree?
Yeah, I think
seems more
MR, yeah, more MR on the lateral, yes.
We would like to select STR. Yes. Okay. 来吧，是。刚才那个阀漏，不知道为啥，但是可以。
So you are going to use an XT, am I right?
Yes, XTR.
XTR, yes. You agree, Kentaro? Would you use an XT? Yeah, just XT, not the W, but XTR. And you plan to place it very close to the first clip, am I right? Just to close
yes, I think very close to the first one.
Yes, yes, that's right.
And got a very good paralyzed with the first clip. Yeah. 搞一声，在这里已经。Okay. That flashed. Yeah. Flash 出来。CT is good, right? 好，很好，可以。来 ，continue。orientation 调好。好，苏主任，我们把第二个夹子放到它的 lateral 侧啊。
哎。
来，我现在准备加 M， 一点。straddle, more M. Advance a little bit more M. Yes, good.
Good straddle.
Yes. Posterior a little bit. Like, okay, give some pass to 来，现在你给我一个X-ray， 把它搞到12.8点，再转一转。Release the tension. Yes, good. This one is good. Amen. 好，我们现在跟第一个平行的进去了啊，看着我，似乎再减一点点的 M。X-rays seems very paralyzed already.
Yeah, looks good. Very paralyzed.
Close to the first one, right? I still would like to give more plus. Yes, now it's better. Now it's better. Right? So I think the trajectory, everything is good. I would like to dive into the left ventricular. It's very near to the first clip. I can also see the X-ray to say how it's go inside. Yes, it's left ventricular. It's very close. Yeah. Release some M, right? More close to the first one. Release more M. Very paralyzed now. 苏任来看看这个地方啊，我准备打开它的夹子，来慢慢打开，慢点，基本上 orientation 是可以的，但是我做个微调 ，OK， 再开一点点，再打开大一点，高一点点。苏任，我来 check 这个 orientation 来。
OK。
Seems okay. We need a counter clock a little bit. Maybe better, right? So I tried to counter clock. Yes, now X-ray also counter clock very good. Now it's better. Agree?
Professor Wang, please continue your work. We have about 4 to 5 minutes left, but we would like to see your result. Please continue your good work.
Thank you.
Very close.
Very close, yes.
Okay.
2D.
Go to back. Explain.
关小一点。我在 posterior 区一点点哦。所有人注意看那个后叶还在不在里边
？OK。
我主要是看后叶，我要尽量的抓多点后叶，因为它的后叶比较短。
是。
这一点哈。
OK。
Posterior leaflet might be in and out.
Anterior is in.
Yeah, now it's in. Yeah.
Yes, anterior is in. Posterior seems also in. I would like to more posterior, right? Agree. 可以吗？那你再角度打大一点，打大一点，刚才有点小，大一点点。OK， very good。OK， 好，那我再 posterior 一点点哦。Yes, this time almost. OK， 我再高一点点就当了啊。
OK。
Yeah.
You got both, I think.
Yeah, both. 每一条要不要 posterior 再多一点 ？OK， 准备 down， close down 啊 ，close。OK， close， close。哦 ，OK， 好像离得有点远。Yes, close， 再 close。我在减张力呢 ，close more。后叶不够是吧？好像这两个还离得有点远，你先关了，我看一下，也离得有点远。Not it posterior， 打开吧，你先打开，打开 ，lock， 看一下。Okay. I would like to open it because posterior not enough inside.
Posterior leaflet, right? It's very short.
Yeah, very short.
Maybe you can check 3D if you want.
Oh yeah, later maybe. 来，作者你先稳定一下，我看看 check your orientation 哦。
OK，
来，再 check your orientation 3D 的。It's not bad, right?
Looks okay.
Right back to the 2D 来。
To the X plan。
我才离得有点远哦。
Left 里面那个火车 lift 短了一点。
I would release some parts that got a little bit hug because a little bit hug is good for the posterior. Anterior 在里边是吧？关小一点。
Yes.
再 posterior 一点点，是不是切到这儿啊
？OK。
posterior 够吗？
看一下，
现在差。
前叶是没有问题，后叶还可以啊。来，你切好一点，现在好，看到没？现在都在里面，两个靠的已经很近了，是吧？来，仔细切好，不要晃。有时候超声老师手很累。OK， 太高了，来顶好啊。Anterior inside posterior， 我再当一眼看看。Also inside, right？ 你再打大一点点。打大一点点，再大一点。This level， 打大关小一点点，一点点啊，一点点的它就，对，我说一点点就行。好，很重要啊，就在这儿准备了。关小一点点，再关小一点点，我再当一点点，关小一点点，关小一点点，好，好，就这样。就这样，我再厚一点点，对。I think the posterior enough this time. And very close to the first one. 来，准备 dose down.
Clip it down.
这边加 clip it down. I can see the anterior bouncing, not posterior. Close, 慢慢关来，慢慢关，看着那个 unlock。We lost some posterior also. Why? Yeah. Let's check color, please. We can touch just a little bit posterior, I think.
Maybe because you're a little bit aero to higher, and that's the reason why it's a little bit difficult to grasp the posterior. So
yeah.
I would recommend to do the independent grasping, to start from an anterior and then go to the posterior and open up a clip a little bit more and then grip it down, or otherwise you come back to the left atrium once.
Yes, this time I tried to grab the anterior first and then to go to the posterior. Great, thank you. That's anterior inside, right? 关小一点点，关小一点点。OK， 我们先 try to catch the anterior first。或者那个稳定住，我们准备，你先试吧，没关系。等一下啊，我先拉高一点点，再 anterior。Yeah, anterior here is OK。Yeah， 先下一个试一下。This is anterior, not touch it, not touch it， 是吧？ This is anterior arm. Fire a little bit more. 等一下啊。Yeah, you can down. It's catch it or not?
A little bouncing.
Bouncing, that's okay.
Yes.
然后 open a little bit more. 一点点啊，看到 X-ray. Okay, I got more posterior. Okay, 来，数人看到后叶啊，切好夹子，或者后叶一点。Now I catch the anterior and move to the posterior. What do you think now? 数人放好，整条线放好，看好后叶，稳定住。Is it posterior inside, right?
Yep. I briefly open the clip a little bit more and pull
open
back
a little bit more and pull back a little bit more.
Yep.
Yeah, open a little bit more. Open. Okay, just a little.
Insertion.
慢点啊，不要这样慢点。
And pull back more.
来，数人看好了，不用了，不用了。How about the posterior? Nine. 这个有 leaflet 在那吧？好，这是看清楚的啊。我再拉高一点，好吧 ？Okay, it's very posterior. It's fine. Is it bumping? Yeah. Oops. Yeah. Oh, one, down. I don't know. Seems okay. Close, just close, gentle. Yeah, just close. This time is better, right?
Looks better. I think you got it.
Lock. Lock? Oh, I release some tension there. Oh. Yes, close. Hold it. Yes, this time is better. It's very good suggestion. Independent grasping. Anterior is not inside? I don't know. Try to check the color, please. I got 3D. So, yes, a lot of posterior inside. Bridge is good. Color. Where does the jet come from? Still lateral.
Yeah, more lateral.
Okay. 你先看 grading 现在是多少是？ We try to optimize the second clip.
Yeah, that would be good, yeah. Gradient is a bit higher than before.
Yeah, student check 一下。It's okay, 2.6. I would like, still 2.
Okay.
So maybe I optimize the second clip to more test. Is that very good? Okay, bye.
Yes, Professor Wang, we let you work.
Yeah.
We go back to the Zhenqing cath lab, and then later on, if we still have time, we'll come back to you. Is it okay?
Okay, that's okay.
All right. Thank you. Very nice case. Yeah, thank you.
Thank you. Thank you.
And then we go back to Zhenqing cath lab. They want to show us a case.
This is a patient with 100 and the element disease was fixed, and now he got the aortic stenosis, so that we do the TAVR at the same time, at this moment. And this is a crossover view, so it's a center front. So we start at this point.
How old is the patient again? Sorry, 100?
150.
105.
105.
105. Wow.
Centenarian, and 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105. 105.
he is independent and then mentally clear. So we would like to show this case, just encourage the interventionalists and the surgeons to do TAVR in such kind of patient, which can really beneficial the patient.
Very nice.
I think this is the oldest one in Asia Pacific region. We have checked the literature. The oldest one is the 107-year-old. Yes. 我要顶一下。
But 107 is not in Asia, am I right?
No, not in Asia.
Yeah. So you can report this case.
Thank you so much. I ask you to review the case. Manuscript, I mean.
Okay.
Very nice control of the position. It looks very nice position.
Okay, pace up. LOL.
A little bit high.
Because your pigtail is a little high.
不要推，我收一下好了，好好做。这个老先生经不起什么风吹草动。Hold on，
跳出来。
对。
Okay.
Yeah, a little bit high.
Yeah.
Very sheath.
The pigtail might be a little high. That's
because the patient also have coronary disease, so we don't have to push too high. 不要急。好，下去一点。OK。Start from here。
等我一下。OK。
我们放4好了。3个点点再下去一点点。
没有。
对，它会滑下去。
再等我一下。
OK。Start from here。
再见喽。
这patient不必拼了，再下去一点。
140。
好。OK。Repeat。
再见，老婆。
Okay, very nice. I think because the patient also have coronary disease, so I think this death is okay. Do you think so?
Yes, that is very nice. It's right at the bottom of the pigtail.
Then we release the...
So the 3 markers are very useful now.
Okay, final release. Hold it. 转一下，再旋转。
Still attached.
OK.
So.
再见，老婆。
缩小。
Be careful of the nose cone.
OK.
What?
OK. Please show the echo.
Yes. This is the long axis view. The valve position is good. However, there's a 2 mild jet paravalvular leak.
会好一点的。
算了。
Well, do you think we should post-eye? That is the.
I think it's fine. It's very small. Besides, the valve position is quite good.
And the valve opening seems to be good at the leaflet level. It's circular in shape.
Yes. The valve leakage is quite small. I think it should be fine.
The leak is small. Michael, will you do post-dilatation?
Yeah.
Okay. No problem. Do a final angio. Yeah. 就留这个做。那个。哦，你已经搞进去了。你再推看看有没有进去。
还没进去。
不是外。 等我一下。好，可以。No，你如果进得去就先进去啊。Yeah, we measure the pressure gradient.
Yeah, maybe hemodynamic.
Yeah. Zero, please. Okay. Show the hemodynamic.
Zero.
Zero.
No gradient.
No gradient.
And a good dichrotic notch.
So bother us. Should you please post eye or just let it be?
Maybe one final angiogram because the valve will keep expanding.
Still some.
It's mild.
Mild AR. Yeah. If you want to be perfect, then we post there.
We can do that.
105.
Okay. We follow your instruction. Yeah.
Why?
Dr. Chang will have the final
we
word.
finish this case.
Post-dilate or not?
No?
Yeah, just leave it, yeah.
Yeah, just leave it. Yeah, thank you. This is the case.
Thank you. Very nice case. The first 105 years old. Thank you. So we changed panel? Yeah, we changed the panel and then for the next session. Thank you.
So can I invite all the moderator, experts, and come up to the stage for the next section? Thank you. Electrosurgery. I would like to invite Dr. Simon Lam to deliver the overview of this section. Thank you.
Thank you very much. So this slide are prepared by me and Eric because we worked together on the project. Just to say a few words on the concept of transcatheter electrosurgery. It's about tissue cutting without opening the chest, without any cardiopulmonary bypass. It's transcatheter based. The concept is you have to insulate the device or the catheter so that you concentrate the energy at a certain point. And then when you apply the energy only go to that point and go to the target tissue and create the cuts. Typically, the setting involves guide wires, and CTO wires are some tools that we usually use with a starter wire. Microcatheters, guiding catheters, if you cut leaflets, you have to go to different orientations, angles, and you need diaphragm electrosurgical unit or a radiofrequency puncture generator. So this is not new thing, and it is first actually reported in 1993. Eric Rosenfeld, a pioneer in in congenital heart in UK actually use this technique to cross pulmonary atresia lesions. And actually, we are doing transeptal puncture. You may be familiar with this. If you cannot get through the septum, maybe very fibrotic, you can apply electro energy, connect to diaphragm, applied energy to help you go through. So this is electrosurgery. So just go through leaflet modification as one of the most common indication for electrosurgery. Coronary obstruction risk, the multiple factor, and if we could modify this new skirt, we could help to minimize the risk of coronary obstruction. So basilica and unicorn are the two most commonly practiced techniques. So basilica, later we have a demonstration, and the idea is to make a cut at the middle so that it gives a way for coronary flow to the coronary ostium. And Carl will talk about that later on. And we have different types of modifications, include balloon assist basilica. All for is to maximize the opening to restore coronary flow. Unicorn is a concept that you have intravenestration deployment inside the leaflet without tearing it. And the concept is to use a peripheral balloon after a coronary balloon and put in a sapien valve. And we have modified techniques to put in a self-expanding valve, and we can share it with you later on. So commissural alignment is also a determining factor. If the original valve is not aligned properly, no matter what you do, sometimes you have limitations. Let's go to the mitral side, and we have a lampoon technique illustration and talk by Dr. Lee. And so the factors of contributing LV obstruction include the valve frame itself, but sometimes we focus on the leaflets, and mitral leaflet is too long. It just go across and obstruct. So we can do things, for example, in patients we're planning for valve in ring, we can do modification. So we have a flying V across that you can do tip to base or base to tip lampoon, so that typically you can see from the 3D image, you can have a cut in the anterior mitral of leaflets. So lampoon is a well-established procedure, so involve puncture at the base using electrified wire, and then form a loop with a snare, and then you formed, we typically in Hong Kong we use a flying V technique, and applied energy and pull and create a cut. So not only restricted to leaflets, you can apply energy to the myocardium, like in the sesame septal scoring along the midline endocardium to treat patients with HOCM or prepared for TMVR because of the risk of obstruction. So this is one case in demonstration in Hong Kong Valve about a sesame technique and by Jeffer, and it's kind of combination of CTO work skill and electrosurgery skill. So a lot of work has been going through to modify the technique. So don't forget transcatheter access is good for TAVI, transcatheter heart valve, also for ECMO, for large bore access. In case patient have unfavorable femoral arterial access, you can go through the veins with a loop that capture the wire that goes through, that punctures through the vein towards the artery. And then afterwards, after delivery of the catheter or the valve, then you use a ADO1 to close it. So a lot of things has been done, and a lot of work on the horizon include Batman, modified Batman, cathedral. Lamacon will be with a speaker to have experience sharing on this technique. Manoture, cleave, elastica. So this is one technique that is very interesting, because if you have a clip in the mitral position, then you want to put in the transcatheter TMVR valve, then you need to do some electrosurgery to remove, to detach part of the connection to the leaflet of the existing clip. So there are techniques developing. So thank you for your attention, and hopefully we can learn from each other on the APE project. So thank you very much for your attention.
Thank you, Simon. Thank you. So now we would like to invite the first speaker, Anthony Camiglia, to deliver the talk. Anthony, please.
Thank you so much for asking me to speak. I feel very honored and privileged to have the opportunity to present to you all. I'll just share my screen and we'll get started. Just as my disclosures, just acknowledge my colleagues. My previous fellow, Christina Mew, who's in Hong Kong at the moment, who actually prepared a lot of the slides. I would like to acknowledge her. But what I'm going to talk about really builds on the work of, well, a lot of you there today, Eric Chan, Emmanuel Wong, Simon Lam, as well as the Basilica pioneers, Jaffa Khan and Robert Lederman. So I just want to acknowledge their work, and what I'm presenting is really just some modifications of their work. They're the real pioneers in this area. So I'm just going to talk to you about what really is a modified unicorn technique to allow the use of self-expandable valves. So it's really just a modification of the Hong Kong unicorn technique. And we came up with the an acronym LAMPOON, which stands for leaflet laceration with balloon-mediated annihilation to prevent coronary obstruction with a radiofrequency needle. But what it really is in practical terms is the unicorn technique of fenestration of a surgical prosthesis with intra-leaflet delivery of a valve, but with a self-expanding valve. So I'll just go through the technique step by step. So we've done a number of these cases now. I think we're coming to about 20 of them. And we sort of have set it on a fairly standard approach. And then, as I showed you on the previous slide, we've published on it last year. So we follow the sort of traditional algorithm in terms of integrating when we think there's a significant risk of coronary obstruction, low coronaries, valve to coronary distance of less than 4, but 4 to 6 is kind of a grey zone. And in that case, what we'll consider are things like how high the coronaries are. Is it an externally mounted prosthesis like a trifecta or a MitraFlow, which are always higher risk. So the procedural setup, well, they're all in the cath lab. We use general anesthesia because I know this can be done without transesophageal echo, but I like having the transesophageal echo, and they're obviously anticoagulated. So the first step is the leaflet penetration, and we use the same sort of setup as most people would use for a basilica or a unicorn, some kind of 7 French guide, AL1, AL2 or EBU, a pigtail with the end cut off, and then a fine cross microcatheter. And I always tend to use an Astato XS40 wire and just set the cautery to 100 pure cut mode for the leaflet penetration. Once the leaflet is penetrated, we push the fine cross across, exchange the CTO wire for a safer wire. I just use an RG3 because it's got lots of redundancy. It's very long. And then we just sequentially balloon up the hole. I have tried taking shortcuts with this, but, and find that when I try to take shortcuts, I can't get stuff through the hole sometimes, especially for stenotic calcified valve. So I just find it quicker just to, rather than try to take a shortcut and just go straight to a big balloon which won't cross through the hole, I just follow the same technique now. So I start with a very small, like a 1.5 balloon, then a 4.0 coronary balloon, and then usually that will let me get a 5 French pigtail through the hole, put a safari wire into the ventricle, and then some kind of TAVI balloon or balloon aortic valvuloplasty balloon. I have tried a case where I didn't do that last step with the valve balloon and then tried to deploy the self-expanding valve. And amazingly, I was surprised because I had used a 1.5 balloon, a 4.0 balloon, and then a vascular balloon like an 8.0 or 10.0 balloon. I thought that should be enough to have sufficiently modified the leaflet, and there should be enough radial strength in the self-expanding valve. There wasn't. It was extremely constrained, and it was constrained in a way that suggested that there was like a hole that was being stretched open in that leaflet. So I had to take it out and balloon with the large valve balloon. So it is a necessary step if you're going to use a self-expanding valve. You really have to completely obliterate the leaflet. It won't necessarily. You can't just do the unicorn. You have to obliterate the leaflet. Then once that's done, you deploy the valve, post-dilate it. And it's a pretty reliable technique. The reason I went to this is when I saw your work from Hong Kong on the unicorn, I thought that it, to me, made intuitively a lot of sense. And Subsequently, Cahn's had some the Cleveland group have had some bench testing data, and it seems like you get more reliable and more effective destruction of the leaflet with a larger orifice into the coronary with these balloon-mediated techniques. So sort of gone with those, and this is just that patient's echo. Just because I've got a couple of minutes left, the analogous condition in the mitral situations, LVOT obstruction, obviously. And so there's this Batman technique described, which is actually a transapical surgical technique, but we've modified that and basically modified that, the unicorn and the llamacorn, and now we use that for our mitrals. So rather than lampoon, we do the same thing to the surgical mitral valve. We depending on the anatomy, we'll perforate the leaflet, snare the Astata wire, externalize it, and then sequentially dilate it up a hole, and then proceed with intravalvular, intraleaflet deployment of a upside down sapien valve. And we've done a number of these now, and we're getting down to what would have been a predicted neoskirt LVOT of much less than 1, but without any gradient. It seems to be very effective. I know it's just a single center and a single series, but applying that technique to the mitral valve and valve procedures seems to be just as effective at preventing neo-left ventricular outflow tract obstruction as when it's done in the aortic position for preventing coronary obstruction. As you can see there, we've been doing it on patients who would have had predictive neo-LVOTs of 0.74, 0.59, 0.84, and they haven't had any real gradient at all, and none of them have even looked like having obstruction. We haven't had to do any bailout procedures. We've done 5, so that's 3, and we've done 2 more since then. Again, I recognise this is just all sort of single centre stuff, but it's building on the humbly say again, it's building really on the work that you've done in Hong Kong and that was done in the US with the Basilica. Thank you for the opportunity to present.
So thank you very much for sharing your I'm Simon, and Eric is here, and also we have good panel and also expert in Taiwan who do a lot of electrosurgery. So it's always good to learn from each other, and we can share experience in this field. And okay, so maybe a quick question and go to Simon. So do you have any question on the technique? Yes.
I did not really get it. What's the difference between your unicorn and the llamacorn? What's the exactly different between these two techniques?
The only difference is when they published their unicorn paper, they made a point of saying that you can't do it with self-expanding valves, and I saw that as a challenge. So in their paper, it says it's a mandatory balloon expandable valve. I've never liked balloon expandable valves for valve-in-valve procedures. And most of these patients that we're having to do these on have small surgical prostheses. And I think putting a balloon expandable valve into that setting, there's always gradient. And I know there's debate about that, but it's hard to imagine that putting a balloon expandable valve into a 21 trifecta isn't going to degenerate early because of the gradient. So that's really, as I said, that's really I recognise the work of my predecessors with what they did with Unicorn. This is really just a modification of that to allow for a self-expanding solution.
Yeah, I think we can do a lot of modification and then we group together and find out different ways to implant valve. I think Anthony has shown a very good way because we have very small valve like EPIC 19 or trifecta 19. Definitely you should consider self-expandable valve. So llamacorn is one of the way to do. I think we learned from that paper as well, and also Minitor that was presented in meetings, and it's a very fine technique as well. So that's how the field going. Yeah.
And this is mandatory to do the cerebral protection for this kind of technique, no matter llamacorn or unicorn.
Maybe Anthony, can you show? We do 100%, but let's see what other people think.
We don't because we haven't. And I'm really after last year I was convinced I'm going to start doing it for I hadn't done it for any. And I know theoretically you say, oh, that's crazy, but the published data on cerebral protection, we're yet to see any large trial that shows any subgroup or anyone that benefits from it. Now, I understand that intuitively it makes sense, but we keep saying that about cerebral protection. The most recent study was even worse than the last one, wasn't it? It didn't really show any benefit at all. At least I think the industry-sponsored one showed that there was a trend towards reduced disabling stroke, but the most recent, which is basically a repeat of that study, the British Heart Foundation study, didn't show any benefit at all in any subgroup. So I'm in two minds. I kind of think that maybe we should be doing routine cerebral protection, but we haven't been. And it's difficult for me to justify arguing. See, part of our problem is in Australia, we have some things funded, some things aren't, and it depends what setting you're in. It's hard for me to find a cost-benefit argument based on the most recent publications in terms of talking to the payers for this, how they will justify paying for cerebral protection, especially in the light of the British Heart Foundation study.
Yeah, thank you for the comment. So maybe we keep it going, and thank you once again, and hopefully next time see you in Taipei in person. So thank you. So we can go to Xiamen. So yeah, let's give a big applause to Anthony. So they're going to do a wrap up for the case, right? Hi.
Okay, can you hear me? Can you hear me?
Yes.
We can hear you.
Yeah, this is Xiamen. I would like to spend the 2 minutes to finish my case.
Oh, yes,
my second clip, I just optimize a little bit more close to the first one and more parallel for first one. And the result is good. I think Dr. Su can show me the final echo. Yes, this is a two clip. Yes, very close. Yeah, by commercial. And next one.
And
yes, very good catch of the anterior posterior leaflets and the 3D, you can say color.
The color top.
Yes, still color comes from the lateral, but it's very polarized. If you put a SPW, may be good for this one. I don't want to put the third one. And the result is gradient. The final gradient is this.
Yes.
2.11. The gradient is good. And how about pulmonary vein? You can say this is after left side vein, right? Compared with the previous one.
This is
this is the previous. Now back. This is the reversed 现在的放现在的 Okay.
Yes.
I think it's a lot of chat. The most important, the Dr. Chang already do the right path. As the pulmonary artery pressure before is 65. The mean is 40. Now the systolic, you can say that show the hemodynamic now is systolic is 43, and the mean is 31, 32. And also the wedge of the TCWT, previous mean is about 28. Now it's 20 or 21. Also, we not got a very good final residue, maybe 1 and 1+ residue. I think it's good for the patients because a lot of symptoms the last several months, and this is a relatively high risk, and pulmonary artery and PCWP is very high patients. I think this should be benefit for the patients. Sorry,
Okay, and Wang Yan-Zhang, thank you for the demonstration. Very good result. Congratulations. Thank you.
Okay, thank you.
Thank you. So let's go to the next talk. The talk will be on another technique, and very important because it's set the basis for the surgery, and it's the #1 procedure that's performed worldwide as a basilica. So by Dr. Cao Poon, and he will be presenting online. So can you hear us, Cao?
Simon, can you hear me okay?
Yes. Perfect. So thank you very much for joining, and we look forward to your talk.
Simon, thank you, Professor Chang. Thank you. So first of all, apology I can't make it this year, and thank you to the organizing committee, Professor Wei, Professor Lee, and Professor Yin, our good friends there and some of the experts in the field. So I thought I might focus on basilica, mainly what I've learned rather than perhaps the data. It's very good to follow on from my good friend Anthony Camiglia, who really pioneered some of the Lama corn minotaur. So this is, I suppose, the basis of all this. Even over the past 10, 15 years, coronary obstruction still happens. I think, Simon, you've highlighted some of the predictive factors, but when coronary obstruction does happen, either in native, as in this case in the Spanish TAVI registry.
Hi, Carl. Sorry, the slides was not seen in our screen yet.
Oh, yeah. Let me see. How about now?
Yeah, we have that.
Sorry about that. Yep. So coronary obstruction, as I said, still high mortality, high morbidity, even if you succeed in opening up the valve or the coronaries. The initial predictive factors, 10 years ago, we learned from Ribeiro in terms of the length or the coronary height, as well as the sinus dimension in terms of the diameter. But Jeffer looked at this a bit more. It's not just the height. We do need either calcification or extension of the leaflet, and obviously the distance between the virtual valve and the coronary. So how do we mitigate the risk? We've already learned about the importance of electrosurgery. Having said all that, I think bioprosthetic coronary obstruction, bioprosthetic TAVI coronary obstruction is somewhat different because you have this added risk, not just from the leaflet, but the leaflet can be abutting into the sinotubular junction with the idea that you can have sinus sequestration where the leaflets get pinned to the STJ in such a way there's no flow. Somewhat a unique problem with TAVI in SAVI. So this is quite important in terms of what we need to do to modify the risk or mitigate the risk. So the left and the right, quite different mechanism of coronary obstruction. On the left of the screen, you have sinus sequestration, okay? So the leaflet, however you open up, it's not going to actually shut down the left main per se on the left. And on top of that, we talk about commissural alignment a lot, but sometimes even a surgical valve can be somewhat eccentric. So this was a very small trifecta externally mounted leaflet. And if I was to just deploy a TAVI of whatever device, there's very high risk of the leaflet touching the STJ, causing sinus sequestration. Now, in this case, any puncture in the left sinus will be enough to ensure there's some flow, even though it's eccentric, okay? But this is very different on the right. Now, on the right, you can see the left main almost at the sewing ring. This is also a trifecta, externally mounted leaflet. The leaflet, once it's pinned out or expanded, will obstruct the left main directly. The valve is also somewhat tilted towards the left main, so this is a much higher risk scenario. Not only could you have sinus sequestration, but you can have a leaflet obstruction or shut door mechanism, so high risk. The traversal of the leaflet has to be just outside the coronary at risk. I won't bore you with a very learned panel, what's basilica, but these are some of the things I've learned over the years, what I prefer to use. I prefer to use a shortened guide. You can shorten your guide yourself. However, you lose the talkability and sometimes you can disconnect halfway and really ruin the procedure after 10, 15 minutes of setup. So I always use a 90 centimeter guide, usually in AL. We tried ABU in the past, but we like the cut pigtail that Anthony mentioned as well. My mentor, Chris Raffle, suggested that many years ago to use a cut pigtail to give you infinite adjustability, as I'll show. We only use an XS20, but 300 centimeter wide. Don't use the 180, obviously. When I go to Proctor, I always insist to at least have one box of 5 because each wire can probably be used once or twice and then it gets really charred up and wouldn't traverse. Any microcatheter will do, although the original setup was the piggyback, although it's no longer in manufacture, as you probably know. And then the gooseneck snare as well as a stabilization 018Y in the ventricle, but the gooseneck snare, 20 or 25, size it to the LVOT. So this is sort of a setup where you still have the 2E there, and that's kind of important. Sometimes you do need to inject contrast, as I'll show in a native AS basilica. But this is the cut pigtail setup. So you minimize bleeding. We used to use an 8 French where you don't need support and you end up having a lot more bleeding. Now, this was available in the US, and I think maybe around the time or shortly after COVID. It's no longer manufactured by Medtronic, but this is to reference the pachyderm shape, which is on the top right. And with this setup, you have quite good coaxiality. You can see the valve is lined up here by John Lisco and Toby Rogers in the group. Very strong support, but it's sort of irrelevant because we don't have it anymore. So I was asking the pioneers, Jeff, Toby, and Adam Greenbaum, this was my 3rd or 4th case where I could not traverse. And this is one of the things in basilica. The Y is extremely stiff. Microcatheter, guiding catheter with, I think, an IM perhaps at the time, the Y kept sliding down. And this Y went into the left atrium multiple times, but could not traverse. I could not change the angle because the Y I felt was quite stiff. In the end, we aborted this case and we had to regroup. And that's when my boss or mentor, Chris Raffle, suggested perhaps old school, modify the pigtail yourself, cut it here, and then hopefully on the right you can see the Y is so stiff. So if you push it out, it tends to straighten everything. And with this particular setup, there's almost infinite angle of attack, and that's something we utilize quite a lot. Every left basilica, that's what we do. I actually like using the AL1 usually to engage the left main to ensure that we are in the right plane. So we've presented this last year at New York Valves about our experience, but hopefully I can click on all this in time. But I think we also need to recognize that not every basilica is the same. In particular, some are very visible, such as the perimount on the left. Some are slightly visible, like the trifecta. And then next, the mitral flow, the epic, which is only a line or suture. And then obviously native. And this is why I emphasize it's so important to have a means to inject contrast, because you need to know that the Y traversal is into the LVOT. You line up it as coaxial as possible, but sometimes you do need to see the sinus or LVOT. So this is a quick walkthrough. This is one of the cases we've done quite a long time ago, but the particular setup, I prefer the 90 centimeter guide. Fine cross or any microcatheter, that's 135, not the 150. Gooseneck snare. Traversal, a bit difficult to see, but the sort of suture on the valve. We sometimes check on the orthogonal view, as is advocated by the original pioneers, but it's getting less and less necessary. And this is when you traverse the valve, microcatheter in, snare close to the valve. We've also learned the hard way not to snare too far into the ventricle, where you may get entangled in the mitral cord. There was one case where we snared and then we pull. The mitral rigage became significantly worse, and we realized that we were catching some of the chordies. The flying V, the original publication, but I tend to just use my fingers to make the V and then scrape the middle. This is the laceration. This is in fact a teaching point of perhaps what not to do. So I think before you set up, you really should have tension on the leaflet. That means that both catheters should be on the inner curve. And then with a bit of tension, you deliver electricity. We've never had a case where there was hemodynamic compromise other than an unrevascularized left main stenosis and an impaired LV function. That patient did get sick with a more dramatic blood pressure drop that we had to expedite the TAVI implant. So the rest of this is fairly routine valve in valve. I agree with Anthony's point. I think if the valve is small, you're asking for trouble for transvalvular residual gradient. This was satisfactory, and you can see that the necessity of the leaflet modification with very little room there. Nowadays, I routinely re-engage, perhaps just to prove the point that the basilica is successful rather than just that the patient has not crashed with hemodynamic compromise. This was the case where they did not pick up the left main on the left main stenosis on the CT, and we had to do the basilica and then rotablate and stent into the left main after the basilica case as a stage procedure. So I'm sure those of you who go around to Proctor, you learn as much as you teach. So these are some of the commonest questions I hear. Our biggest question almost always is, how do you know where you're traversing? How do you know that you're traversing at the right spot? And this is actually significantly important, because if you do traverse outside the valve or on the top left movie, if you traverse outside the valve without realizing, you can either see it on TOE or you could have a catastrophic problem, particularly if you were to do a unicorn without knowing that it's outside the valve. Then obviously you will balloon and cause significant periannular damage. But I think the bobbing mechanism tells you that you're on the leaflet, preferably in the middle. You need to get the fluoroscopy right. So a bit of work on CT, but with TOE, I think we still do the majority of cases with TOE, particularly if it's not very visible, like trifecta or perimount. You can see the variation here. We always aim to go low, but sometimes certain valves you can't go too low. Okay, I think we like the AL1 engagement of the left main, mainly because the traditional or original method of using an AL3, you really need to be pinpoint accurate to be sure that you're outside the left main. But if you do engage the left main first, then you know you're probably close. This is the other point. The whole point about electrosurgery is it's not pushing hard. These are some of the demonstrations, I think, some of the examples, but you literally just need to have the wire on the leaflet and then deliver. You don't really need to push very, very hard. In my proctoring, this is, at least in the first case, or maybe first case in most centers, this is often the hardest part to teach. How hard do you maintain the contact? How hard do you push? And once or twice I've had to take over the traversal, but you can see coaxiality with the picta really does help. Even though this is sort of bouncing around with regurg, this was still within. But you can see that there's quite a potential disaster if the wire is in front or behind the valve that you can't see there. Now, sometimes you just can't traverse and you have to maybe readjust the position. Maybe there's just a blob of calcium right at the point of attempt. After the publication from the balloon-assisted augmented laceration, really in the context of TAVI and TAVI, it's our routine now to do balloon augmented or assisted. This is quite useful if you use a small balloon. You can actually show on TOE that you're right in front of the left main, because seeing the wire is a lot harder. And with so much equipment and like catheters and whatnot, sometimes it's hard for the echocardiologist to tell you. But with the balloon, this was a 5-0 balloon. We go 2, 5, and 5, sort of similar to Anthony. We always do a balloon for every basilica now. It's a cute little picture that the jet goes straight to the hole. I suppose the other possibility is to do the unicorn that Eric Chen and Simon Lam pioneered before other people have started. It's a misconception that if you do basilica, it's never going to lead to coronary obstruction. I think we've already mentioned how important it is in most cases, particularly if a shut door left main occlusion, to traverse at the right point. But sometimes the laceration can be not in the middle. as you can imagine, there's a lot of variety of how the heart is horizontal and maybe tilted. Sometimes you can lacerate in such a vector that it's not going to help. And this is why we always do a balloon, to improve our chance that there will be some gap for coronary perfusion. And lastly, there's been some case reports where the leaflet's avulsed or it's flapping around and it can still cause coronary obstruction. We touched on this. I have to say I don't use Sentinel routinely either. However, if the leaflets are particularly hostile looking, for example, there's already a little vegetation or a little blob floating around, I do use Sentinel, but again, evidence-free zone, as alluded to before. Not every case, and most of the time I think it's a bit of time, added time to the procedure. That's half an hour as it is. I don't use TOE routinely nowadays, particularly if it's a strong framed valve such as perimount or trifecta, but it is useful. This was our very first basilica showing the catheter position in the catheter position just outside the left vein. That's a bit eccentric to the post. I think if you can't see the valve, such as epic and mitral flow, obviously it's useful. And certainly starting off TOE is very useful, both to guide and to learn from. In native aortic valve basilica, absolutely important because there's no landmarks, obviously. So the worst complications, coronary obstruction despite basilica. So I think if the stakes are high, like the first case I show you on the right of the screen, then have guide protection. Traversa outside the sewing ring, I've heard of a few such cases, and there's very little survival possibility when you deploy a valve outside the valve. So in proctoring, that's why we're always very paranoid to make sure the first or second case, the operator gets it right within the ring. I myself have done a few traversa into the left atrium, usually recognized by the echocardiologist, but usually of no consequence. So I hope that's a quick run through. What I still think is a very elegant, perhaps not too complex a procedure. Once you've done about 15 or 20, it's fairly predictable, 30-minute additional to a TAVI. We have modified, we've learned from the Unicorn, of course, and Anthony Camuglia, what can be optimized further. I suppose with Unicorn that Simon and Eric have pioneered now, as far as I understand, most operators moving towards Unicorn and maybe shortcut in the US, although that's prohibitively expensive. So it is literally half the cost of a TAVI in the US. So it'll be interesting to see how that plays out. And may I send my kudos and appreciation to Simon, Eric, Professor Yin, Professor Lee, getting together on this important initiative, the APE working group. Thank you so much for your attention.
Thank you, Carl. This is Eric in here, and thank you for being a pioneer in the Asia-Pacific region, in Australasia. So quick questions for the audience, for you. I see that you do not do routine coronary protection, and also you do not have a safety pigtail or Y in the LV. Would you recommend beginners to still stick to coronary protection or things like that? Or like how to hasten up the valve delivery? Do you now put in a pigtail in the left ventricle before you lacerate the leaflets?
Yeah, so I would generally reassure the people I proctor that it's not too hard to recross the valve once you've lacerated. I haven't seen or had challenges crossing the valve after you've torn the leaflet, but you're quite right. The original manuscript was obviously having a pigtail to avoid the problems of not being able to cross the valve. But one thing though, I think if you do not have a pigtail, do not be tempted to cross with a guiding catheter. It's just so much harder with an AL1 guide, particularly 7 French. So take everything out and cross as usual, whether it's your 6 French AL or pigtail. In terms of stent protection, I think if you're not sure, particularly if it's an eccentric left main to the post, then perhaps a bit more important. And on top of that, the mechanism where the leaflet can obstruct the ostium rather than sinus sequestration. I think when the stakes are a bit higher, then have a left main or stent in the coronary for protection.
If there's difficulty in traversal, will you change the acetaldehyde 20 to 30 or 40 or increase the energy?
Yeah, so I think after maybe 3 or 4 burns, particularly in one of the cases where I showed the wire, it's almost like a matchstick. There's a little bob there. That means that wire is probably no longer all that useful. Maximum, absolute maximum 5 burns per wire, probably fewer burns. Then I changed the wire, and I also increased the energy as you suggested.
So thank you very much once again, Carl. We really want you to be here with us so that we can talk more. So thank you once again, because we have to move to the next talk. So thank you very much, and let's give a strong applause to Carl. So we have a talk on LAMPOON. So this is very important as well, because we have to modify the mitral leaflets. And Dr. Lee Yong-Tsai will give us insight and share experience on this very important technique.
Yeah, thank you, Simon, and thank you all that stay here with us. And we know that the LAMPOON procedure is very important for mitral valve in valve or valve in twin, even mitral valve in MEC. So that we have shown the procedures, and you may get this list from the APE group, or just send me an email, and I can give you a manuscript or how to do that. And for our preference is to use the Sentinel brain protection device, because we always catch something, and we need to do a lot of the evaporation debris from blood, and catch a lot of some material from that. And the most important one is when you puncture through the septum, and you can insert a Telomon wire externalization, and then use the Vanderbilt technique with a 7-French guiding catheter and a 5-French diagnostic catheter, and then exchange to acetate wire. So that during this procedure, you must be careful to separate the wire, so that we prefer use the guiding catheter but not the diagnostic catheter. And then you separate the catheter. Now you can see when we pull and cut, there's a lot of evaporized blood over there, and the tissue was evaporated, so that you can see that during this period you cannot see anything. So we always check the aortic pressure from the aortic side. And if the aortic catheter is in the left ventricle, you won't injure the aorta, and you can cut multiple side pines, and the anterior leaflet was cut successfully. So that our idea is modify LAMPOON procedure with a brain protection device and the catheter. We do not scratch the wire, because it takes time for scratch the wire, and you must adjust the scratch the wire, and the blind V is very difficult, especially you have a micro catheter. And now we use the dextrose flush, because they keep the energy high, and use the cutting energy. However, you do not need the dextrose water or the lower energy, and you can still use a multiple cut at this moment. So that we have a Transcatheter 139 and 13 without a multi-site in Commissural group, so we did not do a lot of the analysis in this 13 patient, and here is the result. The conventional procedure is 14, and the neo-LVOT average is 260. With the LAMPOON procedure, the LVOT is around 126. That's very meaningful that we push the limit to 90, and we did not have a LVOT obstruction. So that's mitral valve, and the mitral valve ring is very mandatory use the LAMPOON procedure to decrease the LVOT obstruction.
And in some cases, still the LAMPOON procedure cannot be finished, so that we need to know the base to tip, and we still try simplify the base to tip LAMPOON, and maybe that's in the future we can use the betterment procedure and introduce to you guys as mainly like simple and prevent the LVOT obstruction. And later we will have a workshop for that. We prepare some valve, and if you like to learn from the electrosurgery, just next door. That's every time we have 8 person can participate the procedure, and until 15 that we can learn from the electrosurgery. Thank you.
So thank you so much, and we learned from your experience as well, because definitely we could modify the procedure, make it modify it so that it can fit our patients and maybe actually improve the outcomes. And Eric, do you have a question?
Would you suggest beginners to put in a balloon pump because will there be much increased mitral regurgitation during the or after the laceration?
I think that the acute mitral regurgitation in this moment won't have something, because after you finish the LAMPOON procedure, although there's a lot of acute MR over there, however, because you keep the wire over there, and you can insert subarachnoid wire quite quickly, so that everything was done within maybe 10 minutes. So that it's a very simple procedure. So that we do not worry about acute MI and acute pulmonary edema. The patient always tolerate this period.
Yeah, I think that brings a very important point. For centers that newly start the procedure, they have to make sure before doing the electrocutting, you have had your valve ready. And because some center may starting that, may be good to have a pump, because they need time to streamline the workflow, and always safety is still the #1 thing in the procedure. And it's a good setting today in the lecture, and so we go towards the room for the very exciting workshop.
Yeah.
Thank you so much.
If you have you are interested in the electrosurgery, then we have a room for that. And Simon and I and Eric will all be there, and also Dr. Lin, and you can learn how the electrosurgery do. Okay.
Okay, so let's close this session, and thank you very much for joining, and thanks once again, Dr. Lee, in organizing, also Professor Yin. Thank you.
So we start now. And Dr. Wei-Hsian Lam is on Zoom. Everybody, good afternoon, and I apologize for a little bit late from the previous sessions. So this is a session on advance in transcatheter Cusp valve intervention, and my name is Krit. I'm from Sirat Hospital in Bangkok, and Dr.
I'm Dr. Zhang from Junjie Hospital.
Okay, and we had a panel here, Dr. Wei-Hsian Lam, Dr. Kenzo with us, and Dr.
I'm Dr. Chen from Junjie General Hospital. Okay.
And welcome. I think the first session is a cake clip and a T-TEER. This is by Dr. Wei-Hsian Lam, and he's online. Hello, Wei-Hsian.
Hello,
Yep.
can you hear
Hello.
me? Can you hear me?
Yeah, clearly. Yeah, you
All
can
right.
start now. Thank you
Can
so
you
much
see my
for joining
slide?
us.
Okay, thank you. Sorry, I'm in the middle of the cases, but I think it's okay. So I'm going to share about K-clip and T-TEER. So I think before I start, I would like to say 4 A's are usually to determine whether we have to consider either repair or replacement. I think would be relevant for discussion of this session. First, of course, is about availability of either TE experts or devices in your unit. So the green one is more favorable. I think TriClip or other TEER devices are more readily available in most Asian countries. So in most people in Asia, I think they will start with some repair device, especially TEER. And of course, anatomy, based on my experience with some LOX valve, I think for replacement, very nasty anatomy, I think replacement will win the battle. But there are some concerns with replacement. The other 2 A's, one is afterload mismatch, because replacement usually will abolish every TR. Then if you have low RV function, high PASP, then patient may have a tristomy post-op causes. And lastly, because most of the TR in Asia are atrial related to atrial fibrillation, and if the patient has anticoagulation concern in long run, then of course it's more favorable to repair. But having said that, these are just based on acute results. The long-term durability of these 2 approaches still remains unknown. For repair device, there's always a concern of progressive of atrial fibrillation, annular dilatation, and maybe the TR will come back. And of course, for replacement, the degree of tissue valve degeneration, durability is still unknown. So I think at the end, people have to consider RCT maybe in this area. So the TEER devices available in our unit is TriClip, so everyone familiar with that. And we also had a Dragonfly, which is basically similar, except that you use more AP control, AP knob in the middle, steering catheter. So this is Ken is in the meeting room. So Ken has kindly gathered the early experiences of TEER in Asia, and he found that most of the patients are having atrial functional TR. And despite the very experienced operators in these 4 centers, still around 25% of patients, we are not able to achieve moderate TR. So compared with other registry or triluminate study, we are not doing a bad job, but you see still 25% in very experienced operators, you still ended up with residual severe TR. And baseline torrential TR is a key predictor for that. If you're looking at TEER strategy, you will understand that usually anteroseptal anatomy, more jet, anteroseptal will be more favorable. But in fact, most of the TR is actually in the central. So in many of the cases, in order to achieve optimal reduction of TR, you need to add septal posterior, modified Clover technique. And in this technique, there are some concerns. One is you might pull up the AP Commissural, and then the patient has quite severe TR after you put in the second clip. And secondly, there may be a lot of chordae actually below the septal and posterior leaflets, which is far more than anteroseptal. below anteroseptal. So technically it's more demanding. And these are some of the factors telling us that, okay, if you have all these, especially star-shaped morphology, multiple leaflets, TEER probably won't end up with good results. Let's look at the K-clip. K-clip is basically a 16 French device going from the jugular approach. Is this this system of a screw going into the annular tissue and then the clip used to shrink the annulus. So nowadays, the no-fault approach will be at least 2 clips with more experience of the operators in order to consolidate the result of annular reduction. And they need some screening from CT, so you need some distance because the screw is around 3 millimeters. So you need around 3 millimeter away from the coronary in order to avoid coronary injury. But even with like coronary spasm during the procedure, if you're looking at these pictures, you understand that K-clip actually want to put the clip at the annulus level. If you put the clip more on the atrial side, which is where the coronary lies, then you may have more coronary spasm. So even with some coronary spasm during the procedure, you can actually try to put the clip more towards the ventricular side instead of atrial side. That may prevent the problem. So this is a classical K-clip strategy. I call it semi-devagar. The first clip usually is putting at the septal posterior region. You see the blue one, and we try to cinch the annulus here. Usually we use a relatively smaller K-clip, like 12 millimeter, and then we put in a relatively bigger one to cinch the anteroposterior annulus. Through this approach, we are actually not just shrinking the annulus, we also close the distance between the central jack, and there's also some effect of bringing septal and anterior leaflets together. So it may facilitate subsequent TEER procedure. If you look at the China NMPA study, around 20% of patients is actually similar to TriClip data. So about 20 to 25% of patients, they may have problem even with just single strategy. So you can see from this picture, TriClip is more friendly for anteroseptal pathology and K-clip is more friendly for posteroseptal pathology. So theoretically, if you combine the two, you might get a better results. So these are the possible combination therapies you can get with these 3 tricuspid interventional strategies. K-clip TEER is very attractive because, as I said, 25% failed to achieve TR grade to less than 2 with single therapy. There are 2 approaches. Either you do committed approach. So at the beginning, you think one strategy is not going to work. So you try both. You can be staged or it can be do at the same session. Or another one is, I think it's more practical, is for bail out. So patients start with TEER and anteroseptal, and then they have disease recurrence later in posteroseptal. Then you can do bail out later. There are cases that have been attempted in China where people have very bad afterload, and they try to do K-clip, reduce some degree of TR, and then do TTVR. Of course, in Hong Kong, Simon has done some cases where people have failed anteroseptal TEER, they can do TTVR. So these various combinations are always possible, depends on patient situation. So I'm going to share with you 2 cases that I tried with this combination K-clip and TEER. So this is a very complex case. You see this is definitely cross here in the transgastric view, very large gap, more than 2 centimeter, and there are 5 leaflets, including 2 septal leaflet, P1 and P2. What our strategy at the beginning is we try to target all these commissurals, and we plan to do 3 clips here. So we put in 3 clips, try to shrink the annulus, and this is during the procedure is T guided, and it can also be guided by ice. So in this case, we use both. You'll see there are 2 clips already being put in between septal and posterior, and the one between posterior and septal. And the TR reduced a little bit, but still there's something to be done. So we clip the anteroposterior annulus as well. So this is the picture. So you see the ice catheter. This is where we put the first clip. And this case also had already had some clip being done for the atrial functional MR. And because TR is so severe, you have to close the iatrogenic ASD. And this is the stage procedure. We do clip in postal septal region, and then posteroseptal, and then anteroseptal. So this is what, after the procedure, we do angiogram to make sure there's no spasm. And this is what happens in transgastric view after 3 K clips. You see initially there's a very big gap, super big. It's not amenable to TEER procedure. After 3 K clip, we see clearly shrinkage of annulus and the gap appears smaller. So 1 month back, we bring this patient back, and then we do a edge-to-edge repair. So we put 1 clip in the central. I think that's XTW. And then there's still some TR in the posteroseptal region, and then we do a modified Crawford technique. And we will be able to bring down this TR from very severe TR grade to grade 2. All right, this is what it looks like in the angiogram. There's a lot of flies with 3 K clips and two tricuspid TEER devices. So this is case 2, is 86-year-old. Again, with the atrial functional TR. Elderly, and we do K clips 3 years ago, and I think this is a classical story. The patient come back later with heart failure, and then you do echo again. This time you found not just TR is getting more severe, the MR is getting more severe, because I think atrial fibrillations affect both annulus. So this time we try to do MV and TV TEER. So this is what happens 2 years ago. This patient, I would say, is moderate MR, but very severe TR. So at the time, we think, okay, 86-year-old, mainly symptoms of right heart failure. So we go in with 2 K clips. So this is what happens after the procedure. 2 K clips, a little bit of spasm, but it usually doesn't have any clinical sequelae. And this is the echo after the procedure. You see the TR grade, we were able to reduce it to 2 to 3 grades, at least 2 grades reduction post 2 K clip. But clearly there are some residual TR from the anteroseptal region. And this time the patient coming in with heart failure again, after feeling good for 2 years, then you see MR is getting worse. And the TR, and there's MR also, MV has a clap. I think this makes the TEER procedure in the mitral position slightly more challenging, but clearly you see the TR is getting worse. And this case, I think at the beginning we decided not to do TEER because you will see the anteroseptal region, but just from this explained sweep, the septal leaflet is very thin and fragile. So we think there may be chance of SLDA. So that's why we go for K-clip at the beginning. You see very flail, short septal region. Even from transgastric view, you see that there's basically no leaflet close to the anteroseptal region. And so this time we do MV clip with Dragonfly because we can use 1 sheath to do both. I think Ken is also will also discuss about the chance of using tri-clip guide for both procedure. But in Dragonfly, you can certainly do that. So these are 2 K clips on the bottom, and then 2 TEER devices. One is in mitral and one is in tricuspid. And this is the final result. You see the MR. There's some MR. I think we are able to bring it down to grade 1 or grade 2, and without causing stenosis. And then this is how the tricuspid TEER was done. So I spent a lot of time trying to optimize the septal leaflet, make sure there's no SLDA. I think this is important. So you see in the transgastric view, I see very clearly there's a ribbon sign. And then the MR, the TR grade, we're able to reduce up to now is grade 2. I think we are happy with that. And so with time, I would like to summarize. I think based from current data, about 20-25% patient having significant TR, we cannot achieve with optimal TR reduction with either annuroplasty or TTEER alone. Combination is feasible, which based from my initial experiences will further improve the efficacy of TR reduction. But these two therapies together is really technically more challenging for both imager and implanters, as you have to learn multiple techniques. And of course, TTVR, because Professor Lux is here too, it would be also attractive options. Which one is better, we don't know. But I think more reasonable approach is not for the committed approach I mentioned at the beginning, but more for the bailout. I think you will be seeing more and more these cases. And we need a larger scale feasibility study to confirm the efficacy and safety of these two approaches. Thank you.
Thank you very much. You have any questions? Maybe one question.
I'm a surgeon, so when I do surgery, I always, for Chae, I always put an annuloplasty reed for every cases. But for transcatheter, when we do the edge-to-edge, should you think that we should always add a K-clip to reduce the annulus?
Yeah, that's a very good question. Of course, one of the considerations here is the cost, because you need additional cost for two set of devices. If cost is not a concern, I think optimal annular reduction is the key, because if you put in a TEER device, mostly as anteroseptal region, you're actually doing indirect annuloplasty at anteroseptal region. And as I mentioned in the talk, K-clip, I would call it like a semi-devagar. Semi-devagar means we can actually shift the annulus from the posteroseptal region up to the anteroposterior annulus. So what is left is the anteroseptal part of the annulus not being stabilized. So if, let's say, a company, I think it would be ideal for Abbott to acquire, let's say, the K, so they can provide the device as a package, then maybe this is really a good approach.
All right, thank you so much, YY. Hopefully you can join us in person next time. So we'll move next to Dr. Kenso from Prince of Wales Hospital in Hong Kong. He will be discussing on the combined mitral and tricuspid TEER. Please.
Thank you, Chairman, for the kind introduction, and also thank you for the organizer for the kind invitation. So YY has been talking about like having Abbott to acquire K-clip for a long time, but it seems there's nothing happening. So my talk today is going to share a little bit on a patient that has concomitant severe mitral and also tricuspid regurgitation, and when and how do we do a edge-to-edge repair. So here's my disclosure. So in the coming 8 to 10 minutes, I will be going through when, who, and how we should tackle these cohort of patients. So the background why we have to focus on this topic is because we know that in patient that has tricuspid regurgitation, the prognosis is actually very bad. And patient that has mitral and tricuspid regurgitation, they actually quite commonly coexist. So from previous data, around 15% of the patient that has mitral valve prolapse has moderate to severe tricuspid regurgitation. And in patient that has functional mitral regurgitation, that has, they already fulfill criteria to undergo surgery, actually around 14% of the cases, they also have moderate to severe tricuspid regurgitation. And in open heart surgery, when you go in for mitral surgery, you always consider concomitant surgery, especially in patient that has moderate to severe tricuspid regurgitation. And in some patient that has isolated annular dilatation, you still put in a vein. So it's actually very valuable to consider a concomitant procedure. So in patient that has undergone edge-to-edge repair for mitral position, in fact, we know that if you leave a residual tricuspid regurgitation untreated, it actually carries a very bad prognosis, even in organic or functional mitral and tricuspid regurgitation, as illustrated by this publication years ago. So what are the evidence of a combined procedure for edge-to-edge repair for mitral and tricuspid regurgitation? So although this is sort of a retrospective indirect comparison, but from these two large European registry from Chae and also TTVR registry, you can see in patient that has undergone an isolated mitral valve clipping versus those that has undergone a mitral and tricuspid valve clipping, in the background they have both mitral and tricuspid regurgitation. The prognosis for those cohort of patients that has undergone concomitant mitral and tricuspid clipping, actually the mortality rate over 3 years of time, over 1 year of time is actually improved. So this actually paved the background of a combined procedure. So then why don't all the patients go for a combined procedure? So the difference between an open heart versus a percutaneous is that they are not completely the same. In open heart surgery, because you open up the chest, stop the heart, so there's no way for you to do a staged procedure. So for percutaneous, you can always consider a staging procedure. So one of the hurdle, apart from the cost issue, is that 1/3 of the TR actually will regress after a successful TEER. So in combining the procedure together, there is also a barrier of a long procedure time, a TE-related procedure, and also the operator might be affected in the prolonged procedure. But then, if you think about it, if you're able to effectively combining two procedures without increasing the risk, then the patient will be able to avoid one more GA procedure, avoid one intubation, one vascular access, and also another hospitalization. Remember, the cohort of patients that we are treating are actually old patients, very old, frail patients. Another hospitalization is actually always an issue for them. So, in fact, there has been some registry data showing that a combining procedure has a similar procedure result in mitral and tricuspid valve TR regurgitation reduction. It's only like a 50 minutes longer procedure when you combine a tricuspid TEER to a mitral TEER. But the major limitation is the operator experience and also anatomy in this analysis is not taken into consideration. So who should we actually consider a combining procedure? So some of the factors that we have understanding from the literature is that in patient that has chronic atrial fibrillation or those that has a annular dilatation in the tricuspid area, or patient that has residual mitral regurgitation more than moderate at discharge, in fact, these cohort of patients are having a higher risk of residual tricuspid regurgitation after you have a successful TEER. So these cohort of patients might be the target of combining the procedure together. And in fact, these cohort of patients are the cohort of patients that has atrial functional mitral and tricuspid regurgitation. The reason why this problem is particularly important for us is because AF, MR, and TR is actually relatively common in Asia-Pacific region compared to Caucasian population, because our AF treatment is actually a lot delayed compared to the Caucasian population. And in fact, also in our locality, patients actually prefer one operation to two operations in general. And of course, reimbursement policy in this region is a little bit variable. So this is actually depending on which region you are doing the procedure. So the other considering factor is the team composite. So from previous data analysis, we know that tricuspid, especially tricuspid TEER, is actually having a learning curve. So when you do a combined mitral and tricuspid, if the center has the expertise, there is actually a significant trend towards a decreasing residual TR over the course of treatment. So center expertise is the other important consideration that you need to think about when you're considering combined. So how do we do combined procedure? So there are a few conventional ways of doing combined procedure. On one hand, you can use, in the old days, you use an off-label mitral clip steerable guide, but then you can actually pull back the mitral clip steerable guide to complete the tricuspid. But that is actually out of favor because we have a dedicated system for tricuspid edge-to-edge repair using the tricuspid system. So the other more conventional way would be, of course, using the mitral clip system. Using the mitral clip system for the TEER and then using the tricuspid system for the tricuspid TEER. Then that would be a dedicated device. But then you have to exchange the guide shift. That is actually a little bit troublesome. It's doable, but then it's longer procedure time, and also you have, during the exchange, there is a high bleeding risk, and sometimes you may lose the wire, then that would be causing a lot of trouble. And Pascal or Dragonfly might be the other option, but at this moment, at least, is not widely available. So the way that we are trying to do now, for most of the combined cases, we actually use a single tricuspid steerable guide to combine the mitral clip and tricuspid. So we name it strike TEER technique. We have already gathered 5 centers doing this in Asia-Pacific region, and the manuscript is actually under review. So that has a potential to reduce the need of catheter exchange, and also the tricuspid guide actually has an intrinsic advantage because it has an SL knot, and that would potentially help us to shed and gain height if there is a need to do that. So this short video is trying to show us how we actually do this combined procedure. So a lot of patients, because they have atrial fibrillation, so what we try to do is also considering whether they need to do an left atrial appendage occlusion. This is very similar to a surgical approach, right? So in cases that we need to do a combined LAO, we actually leave a 4 French MPA catheter in the LA. So we use the tricuspid guide to complete the mitral TEER. So in this case, the MR is gone. So we actually directly pull back the tricuspid guide into the RA and then complete the tricuspid clipping. And in this case, the result is actually very good. It's actually minimal mitral and TR. And then we go through the MPA catheter and to deliver the appendage occluder delivery system and complete the LAO occlusion. So this approach has been proven feasible and safe. So we are waiting for the other upcoming data. So to conclude, TR is common in patients that have severe mitral regurgitation receiving M-TEER. Residual TR after M-TEER carries poor prognosis. And serial monitoring versus and considering stage TEER after M-TEER versus a combined M-TEER and T-TEER is both actually a reasonable strategy. The optimal approach, I would say, it depends on patient's anatomy and also center's expertise. Using a single tricuspid guide is actually feasible for combining mitral and tricuspid TEER. Thank you very much.
Thank you very much, Kent. Can you share with us a little bit on which patient that you are planning? So from the study, which patient that you are planning to have a combined procedure? Because if you were to use the T-TEER, the T guidings from the beginning, you must already have in mind that regardless of whatever MR residue you have.
You're very correct. So I guess in order to maximize the benefit to the patient and reduce the number of unnecessary procedure, we only pick up those patients that will anticipate there will be significant residual TR after successful treatment of the MR. So those of cases from literature are those that has atrial functional and tricuspid regurgitation, and those that has a dilated tricuspid annulus. So in the data is actually 34 millimeter size of the tricuspid annulus. But most of the AF, MR, and TR cases, they actually have much larger than that. So from our analysis of the 40-something cases, actually majority of the cases are actually having AF, MR, and TR that we receive in these different centers.
Can you give us some percentage of combination MR-TR for the AF? What is the percentage in your center now?
So if the patient that has a severe mitral and tricuspid, if they have underlying etiology being AF that we see from the echo, we do it like combined 100%. But then if there is no severe mitral or tricuspid, of course, like we'll only tackle one side and see how the patient goes.
Oh, yeah. Oh, by the way, except the Oracle occluder in treating the AF, do you combine with the cardiologist to treat the catheter operation for the atrial fibrillation?
This is actually a very promising field, and in fact, you can see, I guess YY is doing a PFA from the power view catheter that we see at the back. So this is a very difficult to answer question. So ideally, all these patients should receive AF ablation to maintain sinus rhythm. But the limitation from our electrophysiologists is that because these cohort of patients are very end-stage AF, so they're anticipating a successful rate of far less than 50%. So they have a very strong hesitance. Unless they do we call it convergent procedure that do epi and endo, then we are trying to adopt that approach, but then we need more data. Thank you.
The next speaker is Durongpisitkul from Thailand. He is a well-known pediatric cardiologist in Thailand. Today, his topic is talking about the optimal timing of tricuspid regurgitation intervention. Please.
Thank you very much, and thank you again, organizing committee, for the kind invitation. So I will cover my agenda in the optimal timing. And from another standpoint on the congenital heart, I will give you some case of the ASD. We'll go over a little bit on the tri-score and the tri-valve. And then had a very, very small recommendation from a consensus meeting that we had it in the past 3 months. So everybody know that residual TR, the higher the severity of the tricuspid regurgitations, have a less survival ability. So again, we try to go after the residual TR. So let me give you some examples. So this is a 73 years old patient. He have an atrial fibrillation, have hypertension, CKD, and during the routine follow-up, the cardiologist over there suspect that the cardiomegaly is somewhat out of proportional. So they do investigation, and obviously in the cardiac MRI, they saw the ASD. So in 2019, he had ASD. Even before closure, they started to see the tricuspid regurgitation. So basically, we closed the ASD with the Amplatzer device. At the time, we do the balloon sizing and put the Amplatzer device. Everything looks fine. Okay. How do we know that what is a long-term follow-up on this patient? One of the studies showing that around 62% of the tricuspid regurgitation after ASD closure becoming better. Another 38%, which is somewhere around 1/3, either staying the same or progressing worse. So what is the prognostic in this patient? Of course, we're talking about atrial fibrillation. This is one thing, or even new onset of AF, because ASD device can create stress in the atrial and cause more atrial fibrillation. So in our patient, we thought that in 2019, we closed the ASD, and then 3 years after that, the tricuspid regurgitation start to come back and becoming obviously like in this patient, in the TE, like you can see here. So we decided to do the tie clip after the ASD device. You can see that atrial on the second panel here on the upper, which is a TE, and the lower is tie clips. The difficulty is that the clip actually gets stuck inside the ASD device. So we have to have doing some manipulation to get the clips away. So one of the things in combinations in the post-ASD device, it depends on the size of the device also. So eventually, we are able to do the tie clip in this patient. And you can see that on the last right lower panel here on the angiographic, that how to avoid it getting close to the ASD, why we use a LAO view. So this is something that we can catch up because the patient had and this is a post tie clip. Now, in the conclusion, I think it's a model care for this patient. We have a regular follow-up for patients who potentially can cause TR, and majority of the follow-up, since they have ASD device, we do the echo. That's why we detected the TR earlier. But this is not always the case for the patient with AF, because most of the follow-up is done in the outpatient clinic with some X-ray, and to detect the early TR, this is not always possible. So we have to think about how to design the model care for this group of patients also. So we understand that the TR, once the left severity, will impact in organ function like liver, kidney, and also all the GI, which has a malabsorption. Everybody try to avoid and get the optimal timing for this group of patients. The regular routine scoring, which is a Euro score for the STS score, which has been doing for the CABG, this is done to try to predict that. However, it's not specifically. So as we know that we have two scoring systems. One is called dry score. So they are basically using a lot of morphology, a lot of right-sided heart failure symptom, and also the end organ such as the kidney or liver. End organ kidney is a lower GFR than 30, and liver is like elevated bilirubin level, and also using the EF on the left side, which is LVEF less than 60%. For the low tie score, which is less than 3, you predicted 2 years mortality compared with the surgery. Its survival is 83% compared between surgery and normal therapy. So anything above 3, you started to have lower survival rate for the TRI score. So in the low risk TRI score, which is mean less than 3, the survival after tricuspid intervention And conservative treatment, which is a guidelines, it's a little bit better. It's 93, 87 compared to 73. For the intermediate stride score, that's mean we're waiting too long. If we're waiting too long, the survival are not that much. So even the stride score tell us that anything above 3, that's mean you started to be a little bit too late, unless you have a significant TR reduction. Once you have a significant TR reduction, the intermediate stride score, you have also better than the conservative treatment. Obviously, if you wait for the high-risk stride score, the survival, it's not much better than the medical treatment. The other scoring called TTVR, which is a proposed risk of score. So what they did is they added the atrial fibrillation, which is 1 point here, and the cutoff numbers try to be 2.5 because the scoring on the everything else is scoring as 1 point, except the LVEF, which is 0.5. So in order to understand this, if you wait until the TTVR more than 2.5, that means you're a little bit too late for this group of patients. So when you compare TRI-score and the TTVR scoring, both of them use 2 or 1 year mortality. With the GFR, bilirubin, and LVEF, it's about the same, and right side heart failure. And the TTVR, it's using the AF. However, all of this scoring are not including RV function or TR reduction, or even the tricuspid intervention is a little bit different from TRI-score is surgery. For TTVR, it's either TEER or tricuspid valve replacement. We understand that tricuspid valve replacement hopefully reduce the TR more than 95% compared to a TEER procedure. So what did APSC consensus doing? Everybody, several other on the investigator has been meeting in the past few months. And we met in person in Bangkok a couple of weeks, last month ago. And I think I will just only get the statement on the recommendations. The statement will look like this, but this is the slide that we use, that for a patient who have more than grade 3. So yesterday we discussed that all the grading, we are using 5 grade now. So anything more than grade 3, you consider that if patient have heart failure symptom, have less than 70 millimeter pulmonary artery systolic pressure, so that means no pulmonary hypertension, and unstable and reasonable guideline-directed medical therapy. We've been discussing a lot on how far along with the GDMT, but we think that there is no real conclusion, and obviously anatomical is available for TEER. So this means we will recommend for the TEER procedure. There are several other statements, but for the interest of time, I will only give you some. So the APSC guidelines are based on for general cardiology to refer to us, which I think is quite important how soon they can refer to us, because otherwise once we get referred, and this is also the comparison outcome of the tricuspid valve replacement, which we suspect that the higher TRI-score, which is more than 6, so that means it's a little bit too late for the tricuspid valve replacement. So I will finish my talk with that. In the beginning, if you have favorable anatomy, so that means TEER or tricuspid valve repair is a reasonable and suitable procedure because of the less side effect. However, we can have a discussion, but up to 50%, this patient will come back with more than moderate TR. However, on the other spectrum, you have less favorable anatomy, you have tricuspid valve replacement, you need more experience, and it's not always readily available. You may have more chance of either bleeding or has poor chance of pacemaker. So I think at the moment now, we have 2 scoring system to start to see that when it's too late. But I think we will be having another APSC recommendation and try to tell the general cardiology that how soon they should refer to us. And this is the final thought on when we should do the TEER or tricuspid valve replacement. Thank you very much.
Dr. Chen, you are a surgeon. Any suggestion or comment?
Okay. We all know that to treat the TEER, we should more aggressive, so the timing will massively advance. But my question now is that when is too late? When is too late? When we do a replacement, we eliminate TR, then we have a concern on the RV functions. Mm-hmm. So for TEER, you reduction the regurgitation, but you did not fully eliminate it. So some RV function is preserved. So my question always ask myself, when it's too late? If I close or I reduce too much TR, do I put more strain on the RV so the RV will failure? So my question is when?
So we saw that 2 score, but I already say that 2 score never included RV function. So in my practice now on the focus on this patient, I do a lot of RV function, or I told my echocardiographer like a strain pattern, or the global doing the free wall strain pattern. If I started to see some abnormality and not waiting for the frankly right heart failure, I think that about the time. But the problem is that our tool is only TEER. So we don't have a lot of tricuspid valve replacement experience. So I think it's a little bit, eventually even we make a decision, we might be able to optimal all the result in all the patients. So that's our limitation.
My personal clinical practice, I use the nuclear medicine to detect the RV function in resting status and dopamine stress status. If the dopamine stress could not increase more than 5%, that means the RV is going to decompensation. So I think that is the timing for the operation. Once you mean the RV dysfunction, the surgical prognosis is poor. So you need to operate more earlier. So you need to detect decompensation status.
Just to follow on Dr. Zhang's comment, so do you do the dopamine stress echo on all the patient that has suboptimal RV function, or you select a cutoff, and the measurement is on 3D or 2D, because there's a lot of issue with echo measurement on the RV function?
Echo to check the RV function is not so reliable, and once the patient has severe TR and under your medical control for 3 months, and the echo still show persist severe or massive tricuspid regurgitation, then I will arrange the nuclear medicine method to check the RV function under the dopamine stress. If the compensation is quite well, then I will wait. And if the compensation power is not good enough, I will arrange the further management.
I think the nucleotide is more accurate than stress echo because it uses the intensity, the absorption it's more objective, not subjective.
Yes. So just a quick comment. I think Dr. Chen asked about when it's too late. In my mind, I have no doubt that when symptoms starts, heart failure symptoms start, it's too late. So historically, surgery is performed based on symptoms. And that's why our surgical results has been proven to be over time and time again very high risk. So I think imaging becomes a very important aspect of assessing. So I think we really look towards the clever cardiologists to give us, especially imaging cardiologists, give us answers for when is the optimal time to go in. But symptoms, I think, is a late marker.
Okay, the next speaker is Lu Fanglin 教授. Today his topic is transcatheter tricuspid valve replacement. Professor Lu?
Okay, thank you. Thank you, Chairman. Thank you very much. Dr. Lu has an emergency task, so I will give this speech for him. And I am Dr. Qiao from Shanghai Hospital, and I am the Dr. Lu's ex-colleague. So I'm very honored to be invited to the Taipei Valve 2025. So can you see my screen?
Okay, please go ahead.
Okay. Sorry. My speech now
is innovations in interventional device for tricuspid regurgitation and interpretation of clinical outcomes of LuxValve Plus Travel 2 study. As we all know, the LuxValve Plus system is designed for the severe tricuspid valve regurgitation, and it has very innovative design. For example, the non-radial force anchoring design and the interventricular septal anchoring free from radial force, complemented by a multi-dimensional fixation design using dual leaflet grasping clips, and its innovative self-adaptive bridged ring, and effectively reduces annular dilation and reduces post-operative TTVR risk due to complex and anatomical structures. And this delivery system has the multi-dimensional adjustable.
Dr. Chow, can you play the slide? We can see the screen, but the slide is not playing.
Oh, okay. Oh, sorry. I will share our screen once more. Sorry. Can you see?
Okay, yes.
Can you see my screen?
Yes, yes.
Okay. I'm sorry. So this is the innovative design of LuxValve Plus. And there we go. And here, this delivery system has the multi-dimensional adjustable deflectable delivery system, and it precise valve release position during the procedure, and facilitates good coaxial alignment, reducing the risk of post-operative valve instability and PVM. So why we designed a TTVR device like that? Because we want to break through multiple technical difficulties in tricuspid valve interventional therapy. As we all know, multiple technical difficulties in tricuspid valve regurgitation therapy. For example, the tricuspid valve has complex and anatomical structure and the three-dimensional shadow-shaped structure. Tricuspid valve annulus is very soft and lacking the force of prophetic valve. So we designed the innovative interventricular septal anchoring technology, allows radial force free anchoring of this valve implant. And we designed the leak-proof self-adaptive branded ring is expected to effectively prevent valvular leakage caused by annular dilation. And due to severe annular dilation, the traditional radial force design is difficult to support a flexation of prophetic valve and the remodeling of right ventricle, and is prone to cause conductant block. So we have we designed the radial force free anchoring system to prove this to take over these difficulties. And for treatment in patients with pacemaker, it is necessary to avoid the pacemaker leads, which increases the difficulty of prophetic valve implantation. So the design of the design tends to avoid causing compression to the native valve annulus, which is expected to effectively prevent a conductor block. So here, this video is the simulation of the whole procedure, and we know some doctors, just like YY and Dr. Hsu, is very familiar with this whole procedure. And because of the innovative design, the LuxValve Plus system in China mainland admitted into the innovative medical device screen path by the MPA in 2023. And in Europe, it enrolled in the expert panel scientific advice pilot program by the EMA in 2023. And in the US, it's designated as the breakthrough device by the FDA in 2021 and enrolled in the total product life cycle advisory program, means TAP, by the FDA in 2023. And here is the simulation of the whole procedure of LUX-Valve Plus system. Here is the interventricular anchoring system. We use a hook to anchor in the whole valve into the tricuspid valve annulus. So based on this device, we designed the TAVR 2 clinical trial. And the TAVR 2 is a prospective multi-center single-arm clinical study conducted in China using the LUX-Valve Plus system for transjugular prophetic tricuspid valve replacement. This clinical study is to evaluate the acute and long-term safety and the performance of the LUX-Valve Plus system in patients with at least a severe tricuspid regurgitation. We will follow up from post-operative 7 days to 5 years. And the patients include criteria is just like age more than 50 years old and severe or more severe tricuspid regurgitation, clinical symptoms of tricuspid regurgitation. NYHA classification is higher than class 3, and high-risk patients who are assessed by a multidisciplinary cardiac team as no suitable for surgical procedures. The TAVR 2 clinical study was led by Zhongshan Hospital, Fudan University. A total of 15 centers across the country participated in the study, covering 6 regions. And here is the center's name. And the patient baseline, all patient is 96 patients, and age is more than 70 years old, and more than 85% is the secondary TR. And here is the whole baseline data. The safety endpoints of 96 patients of fast after 1 year follow-up is very satisfactory, and the device success is 96%. In 2 patients, valve was not implanted due to jugular access ensues, and no subject had a severe perivalvular leak and transferred to operation after the procedure. And procedural success was more than 95%. All-cause deaths in 1 year is 4.17%. 1 patient died as a suspected cerebral infarction after prolonged bed rest. Another died of a lung infection by COVID-19, and 2 deaths after falling. And we can see the TR reduction durability in this section, and the reduction in TR severity from baseline to 1 year after operation. We can see in baseline, there is a very severe tricuspid regurgitation, but after operation 7 days, nearly all the patients has only 1 or less TR. And in 12 months, 95% of the patients remained free of reflux or bad, only minimal regurgitation. And only 1.1% of the patients experienced moderate or severe regurgitation. So significant clinical improvements. We analyzed the patients' NYHA functional classification and 6 minutes walk distance by visit and Kansas City cardiomyopathy the score by visit. And we find that the cardiac function continued to improve over 85% of patients. NYHA classification after operation improved from the preoperative level of 3 or 4 to 1 or 2. 6 minutes of working distance increased by an average of 67 meters, reaching 377 meters after 1 year of operation. And KCCQ score increased by an average of 21 points after 1 year of operation. The 1 year follow-up results of 70 patients using the LOX-Valve Plus model with a 30 to 50 millimeter or larger valve annulus, we analyze these patients as the applicable range of patients with large annulus. And here is the baseline. The baseline is just the same as the full analysis sets. And in this 74 patients with the large annulus patients, the device success rate was 98%. And only one patient experienced the severe perivalvular leakage and underwent emergency open heart operation after the procedure. And the surgical success rate was 97%. And all-cause mortality rate was 5.4%. Just one patient died of suspected cerebral infarction due to the prolonged bed rest. One patient died of the pulmonary infection caused by COVID-19 infection, just like we mentioned before. And 95% of the patients remained free or had only minimal regurgitation 1 year after the operation in the large annulus patients. Only 1.41% of the patients experienced moderate or more severe regurgitation in this set of patients. And in the life quality, NYHA function classification and 6 minutes and work distance and so on, by analyzing the long-term follow-up results of patients with large annulus in the TAVR-2 clinical study, the safety and the efficiency of the LOX-Valve Plus system in treating patients with large annular bicuspid regurgitation were found to be not inferior to the result of the entire patient group. This is expected to provide treatment options for patients with challenging anatomical conditions of large annulus. We all know the TTVR procedures are products that rely on radial force have a higher probability of compressing the anteroventricular node and his bond, resulting in a higher likelihood of developing new third-degree atrioventricular block after operation and the need of permanent pacemaker implantation. And the unique non-radial force independent anchoring design of the LOX-Valve Plus does not compress the anteroventricular node and the his bond, thereby reducing the proportion of patients requiring permanent pacemaker implantation after operation. The 1 year follow-up results of the TAVR-2 clinical study showed that it was only 2%. And the design of the LOX-Valve Plus system anchoring prophetic valve onto ventricular septum with anchoring needle, preventing the valve from shifting or falling off. 2 leaflet clips, we call it rapid L's, hold the anterior and posterior leaflets, assisting in maintaining the stability of the valve after implantation. Because the anchoring mechanism does not rely on radial force, the stent of LOX-Valve does not exert force on native tricuspid valve annulus. The self-adaptive leak preventing braid disc is soft and naturally adheres to the area above native tricuspid valve annulus, preventing perivalvular leakage while not causing compression to native tricuspid valve annulus and conducting bondage. And we find the Lux valve system is benefit for post-operative right heart remodeling. We analysis these patients and find at 30 days after the operation, the patient's right ventricular and the diastolic volume and the diameter of the inferior vena cava had the end of expiration both decreased, indicating a trend of right heart remodeling. At 12 months after the operation, the average FAC of the patient significantly increased from 38% on the 10th day after the operation to 42%, and the right heart function also improved remarkably. And here are two cases to show the right heart remodeling after the Lux valve implantation. And the case one is an 81-year-old female patient with the NYHA class 3, and the STS score is 9.43%. It is a high surgical risk. And the patient has a hypertension, persistent atrial fibrillation, radio frequency ablation operation was performed in 2017. Coronary heart disease was diagnosed in August 2023, and mild impairment of liver and kidney function, stage 3 kidney disease, functional waterfall-like regurgitation of tricuspid valve, mild impairment of right heart function. TAPE is 28 millimeters, and the FAC is 45%. Pulmonary artery systolic pressure is 56 millimeters vertically. And the patient is very poor. And the echocardiographic findings is normal left heart function. LVEF is 71%. No abnormality in the aortic valve and mild regurgitation of the mitral valve and the pulmonary valve. And this patient, after a careful assessment by the cardiac team, this case is suitable for undergoing TTVR operation using the 30 and 65 model of the Lux valve system. And we can see the left picture is the preoperative echocardiography, and the preoperative measurement of the anterior septum diameter of the tricuspid valve ring was 58 millimeters. The transverse diameter of the right ventricle was 71 millimeters. The long diameter of the right ventricle was 79 millimeters. It's very large, and only 4 months after operation, the anterior septum diameter of the tricuspid valve ring was measured to be 48 millimeters. The transverse diameter of the right ventricle was 50 millimeters, and the long diameter of the right ventricle was 65 millimeters. For the images, it can be seen that the right heart was undergone significant remodeling and shrinkage. And this is the second case, and the patient is a 79-year-old female, and with NYHA class 3, STS is 8.14%, is also a high surgical risk. This patient has a hypertension, persistent atrial fibrillation, moderate impairment of liver and kidney function, diagnosed with neuroendocrine tumor in 2010. Of course, it is treated successfully. And echocardiographic findings is that functional severe tricuspid regurgitation, mild impairment of right heart function, TAPE is 16 millimeter. FAC is 48%. Pulmonary artery systolic pressure is 32 millimeter mercury, and normal left heart function, LVEF is 61%. Mild regurgitation of the aortic valve and the pulmonary valve. So this patient, after careful assessment by cardiac team, it is choose 65 model of the Lux valve plus system. And also The left picture is the preoperative cardio echo picture. The preoperative measurement of the anterior septal diameter of the tricuspid valve was 57 millimeters. And 1 year after the operation, the measurement of the anterior septum of the tricuspid valve was 51 millimeters. From the imaging results, it can be seen the right heart has undergone significant remodeling and shrinkage, and the right ventricle and the right atrium also shrinked. And we also analyzed the haptic venous diameters and the right heart ventricle with the CT scanning, and we find the haptic venous diameter and right atrial volume and left atrial volume are all decreased after the 6 months after post-operative. So this means the Lux valve plus system is treatable for these patients. So here's the summary. Patients with tricuspid regurgitation have a latent onset and a long course of disease, and traditional surgical procedures carry higher risk. The design of tricuspid valve interventional treatment devices not only needs to consider the short-term issue of valve implantation and fixation, but also needs to further consider how to be beneficial for the long-term sustainable improvements of right heart function based on the anatomical structure of patients with tricuspid regurgitation. And the unique design of the Lux valve plus system overcomes clinical pain points such as difficulty in anchoring during tricuspid valve interventional treatment, high rate of permanent pacemaker implantation after operation, and post-operative annular leakage. The 1 year follow-up data from the TRAVEL 2 clinical study demonstrated the reliable safety and efficiency of the Lux valve plus system in treating patients with severe and above tricuspid regurgitation. The low rate of permanent pacemaker implantation after operation and the facilitation of the post-operative right heart remodeling indicates that the structural design of the prophetic valve is conducive to the continuous improvement of the patient's right heart function. And we all know Lux valve plus device may still encounter challenges in treating tricuspid regurgitation, such as internal jugular vein diameter and the tricuspid valve and annulus being extremely large. For example, greater than 7.5 centimeters, we will not use this device. And extremely poor right heart function, multiple organ dysfunction, and biological valve failure tissues that these patients found out are not suitable for the Lux valve plus. So we look forward to the continuous innovation and interaction of interventional products benefits more patients. And thank you very much.
Thank you for your great presentation. Any question from our panelists?
Could you mind summary the sizing? How do you choose the sizing?
Okay, thank you for your question. The choosing sizing of the Lux valve is based on the TV scan, a CT scan of the right ventricle and right atrium, and of course, the most important, the tricuspid the annulus. And we have because this device is radio force independent, so we do not use very large overcome. The stent of this valve is all the same. It's just 30 millimeters, and we use we call it a skirt. We call it skirt the diameter to measure the to match the tricuspid annulus. So sometimes we just like 1 to 1. for example, we have the tricuspid annulus diameter is, for example, 40 millimeters. So we use the 30, 40, or 30, 50 devices. It's not very large. So the stent, the very high stent is all 30 millimeters. So we use this way to choose the right ventricle. But you can use 40 or you can use 50. This all also depend on the diameter of the ventricular, diameter of the atrium, and not only the annulus.
Just a very quick comment, and also to respond to Jimmy and also Dr. Chen's question on like when is too late. In fact, the TTVR technology has sort of like revolutionized my concept of like too late to treat TR. From the presentation just now and also for my analysis with European group in jet intervention, the large valve size for this LUX, the outcome is actually comparable to those that has smaller valve size, which actually not just talking about like the feasibility, but also implies that when you have patient that has grossly dilated RV, if you use a percutaneous approach to treat the TR, it seems there is yet to have a defined too late endpoint. So of course, I'm not saying that like we should treat patient very late, but then it seems the RV is actually quite resilient. Even if you treat it late, some patient can still recover. Of course, we're advocating treating early. Yeah. Thank you.
The time is out. We will close this section and we move to next.
Thank you so much.
Good afternoon. This session is Future Studies in Heart Valve Surgery. And I would like to invite Dr. Yohei Ohno to deliver his talk, the latest update in current TAVR trial. Dr. Ohno, please.
Thank you, Dr. Zhao. So for the next couple of minutes, I would like to overview some latest updates in current TAVR trial. It's difficult to pick the relevant topics because there are so many interesting topics around this space, but for the sake of time, I want to pick up these three: long-term data and bicuspid updates, as well as asymptomatic patients. So talking about long-term data, we know that Notion trial has, I think, the unique data that has provided 10 years data set comparing TAVI and SAVR. And this is for the TAVI arm, the classic core valve, so-called classic core valve was used. As for partner 3 and low-risk trial, low-risk trial, we have a data set up to 5 years, which we could say comparable between the two strategies. So Notion trial, a bit, this was enrolled in like 2013 to 2017 because we have now 10 years follow-up. All-cause mortalities showed comparable between the two arms. And as for the bioprosthetic valve failure, which was defined as the composite of valve-related death, aortic valve intervention, and severe SVD. These were comparable among the two arms. So based on this trial, we can conclude that at least for 10 years, the valve performance using core valve was shown to be non-inferior compared to the surgical bioprosthesis. which is quite promising, I would say. So what is the incidence of structural valve degeneration, deterioration, and reintervention rate, and bioprosthetic valve failure, which we are all interested in? As you can see, I just picked up the incidence, the rate of these events based on the literature. Up to 10 years or 5 years so far, we can say it's quite comparable between the two arms. But obviously, we need longer follow-up because low-risk trials are to be scheduled to follow up to 10 years. So we'll provide another data set. So as for the bicuspid updates, we had several topics yesterday as well, very interesting one. One is the Notion 2 trial. So this trial basically tried to investigate the low-risk severe symptomatic AS patients which age was below 75. And it actually includes some bicuspid patient as well. So this slide shows the overall cohort. So it includes both tricuspid and bicuspid group. Still only 1 year follow-up, so it's early to give a definitive conclusion. But in terms of composite endpoint of death, stroke, and rehospitalization, both arms were comparable. As for the death or disabling stroke, also comparable. This study included mean age of 71 and median STS of 1.1, so truly a low-risk cohort. So, so this shows the left side is the tricuspid cohort, and the right panel shows the bicuspid cohort. So it's only a small number of patients, so it's difficult to make a strong conclusion. But as Ole de Becker gave a very nice talk yesterday evening, but as for the bicuspid, there's some concern that at 1 year follow-up, there's some signal, although not significant, statistically significant. TAVI had some more trend for higher incidence of events. This table shows the first plot, which shows some entity or some subgroups which favors one to the other. Most of the subgroups are, we can say, comparable. But maybe in this specific study, the incidence of moderate or greater paravalvular leakage, in this aspect, surgery was better. So we need to take a look into the anatomy itself. Next, for the bicuspid study, it was really a very recent report from the EuroPCR. I believe it's still not published in the paper, but very interesting result. 5-year outcomes from the Evolut low-risk bicuspid TAVI study, which was presented last month. So, as you know, low-risk trial has a randomized control trial between the SAVR arm and the TAVI arm, but those kind of trials usually exclude bicuspid patients. So this study looked only for dedicated bicuspid groups. So it's a prospective single-arm study, not compared with a SAVR arm. Included 150 patients. And it's planned to be followed up to 10 years. So this was a report for the 5-year follow-up. So it included actually half and half of Evolut R and Evolut Pro. Latest platform was not used in this study. So as for the 5-year follow-up, the right panel shows the RCT that we know very well, low-risk trial, 5 years data set. And left one is the low-risk bicuspid single cohort prospective study. So it shows comparable hemodynamics, even though the patient has a bicuspid anatomy as a baseline. And as for the clinical event, all-cause mortality or disabling stroke, it also had similar numbers, including of these events. Once again, it's not a randomized controlled trial, a selected patients, so we need careful interpretation of this outcome. But I would say it's quite promising up to 5 years. So what were the event rate in this study? Most of the events are quite comparable between the bicuspid and the tricuspid study. But maybe it's important to see the rate of reintervention. So actually, for 5 years follow-up, this bicuspid Evolut cohort had 3.7% of reintervention, I would say more or less similar with a tricuspid evolute cohort, which was 3.3%, but seems to be a slightly higher incidence of valve thrombosis in the bicuspid cohort, which could be reasonable because of the not circular expansion of the valve in some cases, so it could lead to valve thrombosis. So we need to pay attention to that. And finally, talking about asymptomatic severe AS patients, I wonder what the audience think about the latest trial, early TAVR trial. So before that, to begin with, there was a study of early intervention in SAVR field, right? So there's two famous trial, recovery trial and AVATAR trial, which tried to investigate the benefit of early intervention for asymptomatic patients. So in the recovery trial, the definition of the inclusion was written here. And for the AVATAR trial, it included also with a negative stress test. This is very important, I believe. So in these SAVR trials, early intervention, although the patient was defined as asymptomatic, it favored early intervention for the surgical AVR. So what about in the TAVI field? So this trial was aimed to make some of the insights in this perspective. So it's an early TAVR trial that we know very well, asymptomatic severe AS patients. It was screened to make it very confirm asymptomatic patients based on negative stress test. Once again, this negative stress test is very important to make sure that patient is really asymptomatic. So it's a one-to-one randomized trial to transfemoral TAVR using SAPIEN and clinical surveillance, watchful waiting. So as you know, it was published in New England Journal of Medicine. I think it was presented in last year TCT. So this patient flow, over 1,500 patients were screened. A lot of exclusion, obviously. Around 42% were excluded because they had class 1 indication for AVR, or anatomical exclusion was quite large, like 30% of patients were anatomical exclusion. I think because of the severe LVOT calcification and so on. So finally, 901 patients were randomized to one-to-one fashion, more or less 450 patients in each cohort, in each group. So as I mentioned, 90% of, a little bit more than 90% of patients had negative treadmill stress test. So a very good study, robust study, which really identifies patients with really asymptomatic cohort. So, but there's some, this part is, I would say, controversial. What the trial endpoint in this study is quite, there's a room for debate, I guess. So the primary endpoint was, as you can see here, composite of death from any cause, stroke, or unplanned hospitalization for cardiovascular causes. So what is unplanned hospitalization for cardiovascular causes? It says that any aortic valve intervention in the clinical surveillance group within 6 months after randomization, or aortic valve reintervention in the TAVR group within 6 months after the trial procedure. So it means that, well, clinical surveillance, what so-called watchful waiting, what we do for those kind of patients? We go for close, thorough follow-up, and as soon as the patient develops symptoms or develops heart failure, we try to intervene, right? So I think with this approach, even patients had some intervention within less than 6 months. I think it should not be counted as a endpoint because that's what's the clinical surveillance is. So I think it should be included only heart failure, like a decompensation of the heart failure, those kind of events. So this gives me a very big question mark to this endpoint. So if you see the Kaplan-Meier curve, this is quite, I would say, strange, weird Kaplan-Meier curve, as you see here. This is a composite of death, stroke, or unplanned hospitalization for cardiovascular causes. Within a very early period, these two curves diverge rapidly. And it means that clinical surveillance group has a lot of event within this early period. Death, no significant difference, as you can see here. Stroke, slightly increase of trend, although not statistically significant for the clinical surveillance group. And once again, unplanned hospitalization for cardiovascular causes. So if you see this figure, once again, it's almost as identical as the primary endpoint curve, right? So it means that most of the primary endpoint was mainly driven by unplanned hospitalization for cardiovascular causes, which majority was symptom progression, but not decompensated heart failure. So let's say you or your parents was randomized to clinical surveillance group, and you were told that you have severe AS, which could lead to sudden cardiac death, but you still don't have symptoms, so we cannot treat you. And then if you once develop symptoms, come back to the clinic, and then we will finally give you an intervention. So this is a symptom called subtraction anxiety, that patients try to develop symptom in order to get a good intervention. So my takeaways from this trial is that early TAVI is not harmful based on this study, and sooner or later some treatment is needed at some point. And watchful waiting could carry some risk of sudden cardiac death and adverse cardiac remodeling. That's true. But based on this study, I would say early TAVI does not save life, based on this study, right? Most of the primary endpoint was mainly driven by unplanned hospitalization due to symptom progression. So that's called the subtraction anxiety. And patient may consider their treatment based on their preference and individual risk. So we need to explain our patients pros and cons of early intervention and watchful waiting. But anyway, I think thorough clinical surveillance and prompt reintervention once the symptom develops are needed. I think that's the bottom line key message from this trial. Thank you for your attention.
Thank you. Thank you, Dr. Ohno, for your outstanding talk. Any questions or comment from?
So quick comment. Yohei, you should have written the conclusion for that paper. But I completely agree with you. That research, that piece of research was designed for win from the very beginning.
Exactly.
Yeah. So I think as a TAVI operator, we need to look at the raw data ourselves and interpret it like what you have done for us. So thank you very much. I think your conclusion is completely justified. For me, TAVI, well, except with the first sentence that early TAVI doesn't cause harm. But we have to understand that the earlier we put a valve in, the clock starts ticking.
Exactly.
The durability clock starts ticking. So we need to plan it accordingly to give our patient the best long-term durability, best long-term management, lifelong management thing. And secondly, this piece of research tells me that maybe perhaps we should, surveillance-wise, we should look after our patient a bit more frequently. Instead of 6 months, maybe 3 months to 4 months, every echo, and they have that kind of gradient.
Yeah, completely agree with you, Jimmy. So I think, well, it's also different when we see a patient over 80 years and patient relatively young, around like 70. If you consider asymptomatic severe AS patients, when to intervene, right? If the patient is higher than 80, maybe as you mentioned, maybe one valve is enough for lifetime management. But for the early, younger patients, maybe we need two times if we start too early, right? So that's I think important.
So from the Notion 2 trial, all the data you presented is a patient with bicuspid aortic valve with severe aortic stenosis, the SAVR seems to be superior to the TAVR. So what is your thought at this point?
Exactly, but you know, bicuspid anatomy is very, very variable. So in some specific anatomy, we know that the result of TAVI is could be as good as surgery. But we know from the article that patient with severely calcified raphe with bulky calcification, type 1 bicuspid, that patients do not well with the TAVI device, current TAVI device. So those kind of patients, even though the patient could be a little bit older, I would send to surgery. Yeah.
Thank you, Dr. Ohno, for your excellent talk. Thank you. So because some of the speakers are catching the flight, so I would like to invite Dr. Wang Yan to deliver the talk. Wang Yuan, Dr. Wang Yan, Dr. Wang.
Right, hold up.
Okay.
Hello.
Please start your lecture, please.
Okay, thank you. I tried to, but this. Okay. Can I share my slide? 要前面那个讲者要退出来，我才能进去。OK， 曹教授好，我的声音能听到吗 ？Can you hear me？
可以，完全可以。
OK， 可能前一个要 share 退出去，我才可以进去。
这边已经没有 slides 了。
Okay, here shows need to. I can't share inside. I don't know why. 能后台帮一下，我这边 share 的时候，他说前面还在共享。My computer shows other presenters are sharing now. I'm sorry, Professor Chao, I can't share it now.
Or we proceed to the next speaker and then later on.
Okay.
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 Thank you. So next speaker is should be Dr. Wu Yongjian, but then Dr. Wang Yang will do the presentation for him. Dr. Wang, please.
Okay. Thank you. Dear Chairman, please forgive me to give this speech in Chinese. Because I received this service, so I prepare my slides in Chinese.
Can you share your slides?
Can you see my slide? Hello?
Yes, we can hear you.
Okay. So can you see my slide?
We cannot see your slides. Only can hear your voice.
I think it's the same problem. I can't share my slide also.
Yeah, maybe I can. That's some technical problem.
Have we closed any?
那个王墨阳，你的那个幻灯还是没有 share 上来，你是不是也进入不了？
王院长，您的也不行吗？
我的也不行，他说有人在占用着这个 share 的。
现在可能可以的。
各位专家、各位频道，大家好。那么今天呢，和大家一起来分享，就是我们在人工智能和这个结构心脏病中所做的一些工作。那么最主要的呢，是我们关于这个 Chip TAVR 手术方案的一个疗效评价与这个方法的一个进展。那么首先呢，我们看到。首先我们看到 TAVR 术式呢，目前已经发展到一个深水区。那么很多的复杂病例呢，尤其是这个解剖复杂，然后临床复杂的病例，需要更高级的这个评价方式和这个对预后的这种判断。那么 Chip TAVR 的话呢，这个概念应运而生，它主要是有一些临床情况高危、解剖结构复杂、术中严重并发症高危，以及植入短期和长期的效果和预后难以兼顾的这么一个特点。那么临床高危的这个 Chip TAVR 主要是血流动力学不稳定、心源性休克、恶液质，还有这个多脏衰的病人。这个需要呢我们去急诊的评估这个 TAVR 手术，然后进行全身麻醉，然后呢去器械辅助，然后以及一些没有条件做 CT 的病人，去用更好的这些影像方法去进行这种替代性的评估。这个是机械辅助的一些原理和这个应用。那么对于这个解剖高危的病人，那么尤其是以这个重度钙化为核心的这种解剖高危的病人，那么包括这种瓣膜脱位高风险、瓣环破裂高风险，以及呢瓣架形态这个膨胀不良，还有我们所说的这个瓣膜铆定区域的这个密封困难，以及术后这种瓣架形态导致的这个膨胀率和椭圆率不佳，导致残余压差高的这种风险的病人，那我们就需要更高级的这种评价方式。除了我们常规的这些术前 CT 的一些判读和根据经验的这种判断之外，那我们如何通过人工智能的方式去以这个更新的方式去理解这些病人的一些特点和预后。那么我们比如说我们通过这个人工智能的方式，可以把我们的这个术前 CT 进行一个钙化的精细的分割，然后呢将这个不同 HU 值的这个钙化进行这个对比，然后发现这种钙化密度非常高，同时呢钙化这个很坚固的这个部位来进行判断。同时呢，我们可以通过术后 CT 的人工智能的方式，把它进行这种支架模型的这个脱尾影，然后呢把它进行一个细致的切分。这样的话呢，我们可以把这个术后 CT 的整个的支架的形变和它的这个术前 CT 的这个钙化进行对比，然后来我们去仔细的观察到底这个去把这个术后 CT 作为一个学习资料，作为一个学习集，让人工智能机器学习去这个进行学习之后，然后呢通过术前的 CT 来模拟出术后的这个架体释放的这么一个效果。那么在这个前提下呢，我们可以做一些，比如说像这个重度钙化的病例，像这个1型2叶瓣，然后钙化非常的重那我们采用26的这个 Venus A 的这个数值模拟，就是通过人工智能深度学习，把术后 CT 学习之后，然后呢海量的数据术后 CT 学习之后，来进行这种数值模拟的开发。这种开发的功能呢，可以给我们一个术前的这种类似于这个仿真植入的这么一个效果。那我们看到这个26号 Venus A 的这个正常释放深度，发现这个架体压缩非常严重，所以的话呢，我们采用这个26号 Venus A 的瓣膜进行深放的模拟，那么结果发现它收腰部分正好是对应钙化的这个最严重的平面，那么导致了一个这个钙化和这个腰部能有很好的贴合，同时呢这个形态比这个正常释放位置要好，所以的话进行深放。那么这个病人的话呢，我们通过这个模拟的方式进行了一个同样的一个策略的这么一个制定和这个释放最终的结果呢还是非常的满意的。那么这个是它术后的一个 CT 影像那么我们看到就是说，在这个病例中可以看到，就是通过术后 CT， 包括圆度、膨胀度均满意圆度尚可，膨胀不佳，以及这个圆度、膨胀度均不满意，合并血栓这些典型的这个 CT 术后 CT 作为学习集，我们可以通过人工智能的方式去训练这个系统，然后呢让它去给我们一个更好的一个提示。那么此外还有一些是关于这个术中并发症高危风险的病人，比如说这个冠脉闭塞错这个风险很高的病人，那我们通过术前的这个 CT 的话，也可以进行一个术中的这个模拟，尤其是去做这个球囊扩张和支架释放模拟，去观察这个瓣叶的形变和它的位置的改变对于冠脉贴合的这个情况。那么这个病人的话呢，他是一个冠脉高危的病人，我们采用22号的命脉的球囊进行扩张，结果就发现他的左冠瓣这个翻起之后极为贴近这个左冠开口，所以这种情况下呢，我们是进行了一个非常好的这么一个预判，所以的话呢，建议进行这个术中的冠脉保护。 那么这个病人的话，我们进行冠脉保护下的这个球囊预扩张，并且呢，在冠脉保护下进行这个烟囱支架的植入，整个效果呢也是非常理想的，这是释放之后的一个结果。那么我们通过术后 CT 的这个精细的判读，也看到了整个的这个包括多目标分割、曲尾影、蹲面测量之后，看到了冠脉开口平面烟囱支架对于这个左冠确实起到了一个很好的保护的作用。那么另外像这种半周漏高风险的病人，那么同样我们在术前就判断到了，比如说像这个病人流出道到半环水平有一个团块样的钙化，半周漏风险非常的高。那么这个地方的话呢，就是上一排红圈所标示的这个位置。那我们也是采用同样的这个数值模拟的方法进行了这个植入之后呢，发现它这个我们选择了一款瓣膜，然后之后进行植入，发现它在右无交界，就是钙化这个地方还是存在有大量的反流数的。那我们采用其他的瓣膜进行这个换一个型号或者换一个这个特点的，针对这个病例，那么发现呢这个CFD 的这个仿真没有发现这个半周漏。那么实际我们选择了这个第二个型号的瓣膜的话呢，和仿真结果也是非常的接近也是避免了这个半周反流的这个情况的发生。那么此外呢，还有就是我们很重要的一点，就是兼顾术中即刻效果和术后长期耐久性的一个困难。因为我们很多的时候，我们在早期应用第一代瓣膜不可回收的时候，更多的是针对术中的植入效果。那么现在来讲，越来越多的我们的随着器械的进展，包括我们的这个对于手术的理解和这个能力的提升，那么对于即刻的这个把握还是比较大的。更多的是呢，我们想兼顾它的一个远期的这么一个耐久性，也就是说它的一个架体的形变的话，等于是它的一个中间值。如果说它形变这个支架形态好，它耐久性就越好，这个是我们所共识的这么一个内容。那么所以的话呢，我们通过刚才所说的术后的这个CT， 这是我们特别宝贵的一个这个影像学的财富，去通过人工智能的方法呢，把它进行这种精细化的提取，那么把它这个支架的这种金属尾影去掉之后，然后呢进行无限的切分，我们一般进行1毫米1毫米的这种切分，来看它整个的一个膨胀度和椭圆度。那么比过去这种用单一平面进行这种植入效果之后的架体的形变来讲呢，更为精细，更为准确那么这个是我们左侧是术后 CT 的一个结果，中间是 CT 去尾影的结果，右侧是我们根据 CT 去训练出来仿真的结果。这样的话呢，得到一个高度的一致性，使得仿真呢真正的能指导我们的术中的一个选择和策略。这个是我们去做的一个临床研究，那么是针对600多对的术前术后的 CT， 然后通过术后的 CT 的话去寻找它的一些危险因素，结果呢得到的这个结论呢是钙化是导致半架形变的最重要的危险因素。那么人工瓣膜核心区域的这个膨胀体积，而不是过去的一个单独平面的膨胀率那么是对它的术后的残余压差影响最显著。也就是说，我们通过形变到血流动力学有这么一个更深入的这么一个探讨。当然我们还在做一些包括 Stiflo 核磁洗超声等等这些动模态的这种研究。那么最后做一个总结，就是以 TTVR 为特点的这些临床高危复杂解剖的这个病人越来越多。那么我们通过人工智能数值模拟的方法来解决未来的 TTVR 是一个重要的方向。那么可以看到我们的 AI 加结构心脏病这个组合具有良好的发展的未来。好的，谢谢。
好，谢谢王教授精彩的演讲，谢谢。有没有什么问题要提问或者是 comment？ 请教一下王教授，像你这个就是说膨胀不良、这个高度钙化的，用人工智能可以判断得出来，术前嘛哈，那可以做一些瓣膜的选择或者脂肪的一些做个调整。那些高度钙化的地方，那个所谓的 calcium score 可不可以转换成 calcium score？ 大概多少 calcium score 的话，会预测它的膨胀不良，还是跟这个不一定有关系？是整个形状或怎么样？有什么特别的？
对，您提的问题非常好，就是我觉得这个目前来讲，我们觉得这个钙化它的导致膨胀不良的一个风险，不单单是一个 calcium score， 但 calcium score 包括 HO850或者其他的这种介质是一个很重要的方面。但就像刚才所说的，它的形态、它的密度、它的这个累积的范围，就比如说它的横向和纵向累积的范围，以及它的这个尤其是形状到底是一个团块状的，还是像一个回旋镖一样有一个比较细的这种腰，那么它是不是在 膨胀过程中会被撕裂或者会被这个崩解，这些都是它需要考虑的一些内容。所以这些内容的话，在我们人的这个考量中，可能这个变量就特别的多。所以我们通过这个术后 CT 的这个金标准去倒推的话，可以去更好的了解这个钙化的一些形变的这个预测啊。谢谢。
谢谢。不知道有没有什么 comment？ 那没有了，谢谢王教授精彩的演讲，谢谢，谢谢。
好的，谢谢，谢谢。
好，下一位讲者的是郭应强教授，郭院长对不对？好，他的讲题呢是 High Molecular Material for Heart Valve， 欢迎郭院长。
尊敬的主持人，感谢那个李永在教授的邀请啊，因为郭教授他本来是可以参会的，但是呢，就是因为稍微会议推迟了一些，所以他就刚上飞机了，已经登机了，就没办法来做这个题目，所以说呢，就由我来给大家分享一下这个题目。请问现在可以看到那个 PPT 吗？
可以了，可以。
好的，我把它放大一下。尊敬的各位教授，那确实不好意思哈，他刚刚登机，然后呢，就是我们今天的题目呢是新型半液材料和高分子瓣膜的演化进展，然后大家都知道，其实我们的心脏外科其实起步是比较晚的，其实在50年代才开始我们的各种的新的操作，那么在50年代呢也研发出来了。首款的这个球螺式的机械瓣，就标志着我们人工瓣膜的一个应用起点。那么后来呢，慢慢出现了一些单叶瓣呐、双叶瓣呐，那就形成了我们现在所使用的一个临床最常用的一个机械瓣膜。那么另外一方面呢，因为机械瓣膜它需要一个长期的一个抗凝，所以说另外一方面我们同期研发了一种生物瓣膜，那么生物瓣膜它就不需要我们的终身的一个抗凝的处理，也有一系列的产品，比如说我们猪的瓣膜来做成的瓣膜，然后我们的流心包的瓣膜，以及还有一些无支架的一些生物瓣膜，然后呢。最近从02年开始，我们的 TAVR 技术也是飞速的进展，那么也有了我们TAVR 的一个瓣膜，但是目前临床上实际上还是没有一个完美的瓣膜。那么从机械瓣和生物瓣的对比来讲的话，大家也知道它的整个的优缺点。从指南来看呢。大于65岁以上的病人，他可能我们更倾向于生物瓣。那么50岁到65岁之间呢，可能根据病人的选择，有些人可能会更倾向于机械瓣，有些人可能会更倾向于生物瓣。但是其实从现在我们大家对生活质量的要求来讲，其实很多的患者他类型来讲肯定是更倾向于生物瓣的。那而且来说。现在一些很年轻的病人，他可能也期望，不要去长期的抗凝，但是呢，因为目前的瓣膜限制，还没有这样一个完美的瓣膜。那么从生物瓣的耐久性来说的话，它的一个主要的导致生物瓣的一个失活的，它主要是它的一个生物瓣的一个结构性退化。那么大概来讲呢，其实15年的它的一个 SVD 的发生率大概在21%，20年的时候呢，可能达到了51%。所以说，我们其实外科瓣膜它的一个平均使用年限一般也就是10到15年。那么在介入瓣膜领域呢，可能早期我们都会担心这个介入瓣膜会不会比生物瓣膜的耐久性更差？但是从现有的临床结果来看，长期随访来看，其实它为瓣膜它的表现是不劣于这个外科瓣膜的啊。所以说我们现在可以看到，我们 怎么来植入这个瓣膜，可能跟它的耐久性并没有必然的联系。那么生物瓣的衰败呢，它有很多种的原因，就包括我们的生物瓣的一些钙化呀等等但是现在也出现了一些对生物瓣膜的一些新的修饰以及改造，希望通过这些技术去延长这个生物瓣膜的使用年限。那么这种我们现在有临床数据的比较好的就是这个Resenia 这个瓣膜，它的8年的一个免于 SVD 的一个发生率是非常非常高的，所以说也为我们可能感觉上也为我们带来了一些希望，就是说我们的这个又不需要抗凝，又能够长期使用的一个瓣膜，但是它的年限应该来说也不是说能够完全达到机械般的水平。那么有了这样一种理想之后呢，是不是能有一种瓣膜，它又可以有我们生物瓣一个良好的一个血流动力学表现，然后又能够得到一个很好的耐久性，能够长期使用，又不需要抗凝，那可能就是一个理想的一个瓣膜。那么这种高分子聚合物瓣膜呢，就是说大家也是一个研究的一个方向。那么最早的聚合物瓣膜可能在20世纪50年代提出的，然后60年代呢也做了一些相应的研究。它早期呢可能是有聚氨酯材料制成的瓣膜，但是这种材料在探索阶段就发现它无法提供一个足够的耐久性，最终是失败告终。所以说第一代的高分子材料它可能在很大程度上由于机械性能的差异等等原因，它有很大的局限性。那所以说后来就产生了第2代的一个分子瓣膜，它希望将天然的高分子材料与合成的高分子材料结合，以及来实现它的一个不同生物材料它功能性的一个特性的一个互补，那期望得到一个更好的一个结果。那么这个聚合物瓣膜的制备的主流技术呢，它也是在不断的进步了，比如说我们的电仿式技术3D 打印技术等等。那么这些技术也用于了其他的可能很多的生物，我们的一些材料的制备。然后呢，在体外实验来讲呢，我们也可以看到，聚合物瓣膜的性能，它可能它的瓣叶厚度要小于生物瓣，瓣口面积可以做到更大，可以得到一个更优异的血流动力学性能，它的抗钙化的能力也是很好的，那么也有良好的生物相容性。但是在体内到底怎么样，其实我们还需要很多的探索。那么目前临床上有的，其实国内在这方面也走得比较前列了，有我们以新研发的这个聚合物的一种自硼瓣膜，还有我们的新领麦德研发的这个我们的高分子的一个外壳瓣。那么这是 TAVR 这个瓣膜，它是目前可能研究走在最前面的。首个患者植入呢，已经超过了5年，无需抗凝。它的1年的中期结果呢，也与外科的生物瓣膜相似。那么它的一个2件瓣也进入了就是临床实验。那么我们其实最近已经得到了一个消息，就是这个它的瓣膜已经获得了印度本土的一个批准，具体结果怎么样，可能我们还是很值得期待的。然后这是其他国家的一些高分子瓣膜的一些研发的一些进度。然后在肺动脉瓣呢，它也有一些应用。然后这是我们国内的以新医疗，它是设计成了一个经导管的主脉瓣置换系统，可以看到它的一个早期的结果也是比较良好的。然后呢，这个是就是 这个我们的30天的一个随访早期的飞沫实验随访结果。然后这是国产的一个外科瓣膜的外科的一个高分子瓣，那么现在也是进入了一个临床实验的一个阶段，可能很快就会在全国很多个中心开始开展这种随机对照实验，可以直接跟外科的生物瓣两个来做对比，看它的整个的一个表现。那么早期结果是在2024年9月，那么上海已经完成了这个首例的植入，1个月之后的超声显示各方面的指标都是比较优异的。但是其实研究了这么多年，它为什么没有上临床？目前还是有一些待解决的问题，比如说它的一个机械疲劳度的问题，就是我们的长期耐久性以及临床数据的不足啊，这等等还有等等限制，需要进一步的去研究。所以说聚合物瓣膜呢，是我们未来人工瓣膜的一个新兴方向，有可能会解决，有可能会产生一个我们能够长期使用又不需要抗凝血、有动力学又很好的一个瓣膜，但是呢，目前仍缺乏它的一个长期的大规模的临床研究可能随着研究的深入，我们可能会得到一个很好的一个新的瓣膜谢谢，因为我刚拿了 PPT 不好意思。
非常精彩的演讲，谢谢您，非常 exciting 的一个 feel 哈。请问您在您的思想里面呢，这种高分子瓣膜呢，还有多少时间才会真正的到了临床的情况，让我们用来治疗我们的病人呢？
感谢。就是其实这个高分子瓣膜，6月5号我看是就是印度他们已经上市了，所以说其实已经接近临床很近了。那么我们国内的话也是有一款瓣膜，很快就会开展多中心的临床实验我觉得跟临床是比较近的，只是说最终它的结果怎么样，可能我们还需要长期随访来验证。
在这个领域里面呢，最大的问题还是存在在哪里呢？
就是我个人觉得可能还是它的是不是机械性能，它的一个耐久性的问题。
明白。好，还有什么问题吗？没有。这样，因为时间的问题，我就感谢您跟我们分享了你们中心的一些经验。这样，我们就要请下一位讲者来跟我们演讲了。好，谢谢您。
谢谢。
王院长，您好了吗？王院长在线上吗？王院长 ，OK。 about the TAVR in the bicuspid valve. Jimmy, please.
Hello. Hi. Thank you very much for your kind invitation and for asking me to speak in this very important Asia meeting, the Taipei Valve. So my name is Jimmy Hon. I'm a cardiac surgeon from Singapore National University Heart Center. I'm a cardiac surgeon. So my topic today is TAVI in bicuspid aortic valve stenosis. These are my disclosures. So as we know, bicuspid aortic valve happens about 1 to 2% of Western population. The natural history is that it's a progressive stenosis, and very often in their lifetime they will need intervention. The challenges of bicuspid aortic valve stenosis is that the anatomy is very variable, and hence there are many classifications to define how to classify bicuspid aortic valve stenosis. The most common one and most famous one is perhaps the Sievers classification. As we know, there's type 0, type 1, and type 2. By far, the most common one is type 1, followed by type 0 and perhaps type 2. Type 2 is also, as we know, probably the most aggressive kind of bicuspid aortic valve stenosis for treatment. Now, we said that Western population bicuspid aortic valve happens in about 1 to 2% of the population, and about 1 in 3 of these bicuspid valve will need intervention in their lifetime. But there is racial and geographical difference. So in Asia Pacific region, about 5 to 6% of TAVR were treated for bicuspid valve aortic stenosis. And in China, many of us will travel to China a lot. Over 50% of the TAVR cases were done for bicuspid aortic valve stenosis. The understanding of the role of TAVI in bicuspid aortic valve stenosis mainly derived from retrospective series, retrospective registries. And these, as you know, are fairly selected patients. The fact that we are doing these patients means that we think that they are doable. So they are inherently biased population. But nevertheless, there are many series, registries in the literature. I'll just pick up a few important ones. Partner 3 bicuspid registry, as you can see. This partner 3 is a low-risk group of patients, and they are highly selective patients to enter the registry. As you can see that the results for bicuspid valve are very good compared to tricuspid valve. The death, stroke, or rehospitalization after treatment with TAVI for bicuspid valve in this registry at least is similar to the tricuspid population of patient in terms of death, rehospitalization, pacemaker, and NYHA and quality of life as well. And for paravalvular regurgitation, again, most of these patients got no paravalvular regurgitation. A small number, about a quarter of them has got mild, and very few patients got moderate or more. So results are very similar to tricuspid valve patients. This is TVT registry, and this is all-comers registry. SAPIEN 3, the balloon expandable platform, also gives very similar results for death and stroke results up to the first year, very similar to the tricuspid cohort. And even for paravalvular leak and also vascular event, they're all very similar. Paravalvular leak, again, bicuspid and tricuspid, no difference in TVT registry for balloon expandable valve. This is low-risk TVT registry. So TVT registry looking at just a low-risk bicuspid cohort. And again, they are very similar between the bicuspid and tricuspid, no difference between the two groups. And there's no difference between the two groups in terms of paravalvular leak as well. So all good. Now we know that circle method is a very useful way of sizing bicuspid valve aortic stenosis from LVOT all the way up to ascending aorta. Just use the circle of the size that you think that you're going to use, the sort of valve size that you think that you're going to use, and predict the amount of oversizing and also predict the space needed for the heavy calcium to move out into, and coronary obstruction risk as well. And perhaps there are many different kinds of anatomy and different size kinds of shape of bicuspid aortic valve stenosis. And perhaps on the right-hand side, the tapered group, we want to size according to supraannular sizing. And also when we place the valve, we want to place the valve slightly higher, either 0 9-10 position or 0-100 position. Now moving on to look at some results from the self-expanding platform. Again, you heard Yohei earlier showing the low-risk bicuspid, Medtronic low-risk bicuspid cohort results. And you can see that they give very robust gradient and orifice area after treatment with the Evolute valve. And also those results are very similar to the tricuspid main trial results. And this is the all-cause mortality and disabling stroke. Again, 30-day, 1 year, up to 5 years, they are very similar to the main low-risk trial tricuspid cohort. And having said that, you know, Partner 3 and Evolute low-risk trial, these are all very selected patients. So what Yohei says is correct. We need to really look at these results with caution. So I've shown you all the very robust bicuspid valve trial results. So is TAVI in bicuspid valve stenosis all good news? So I'd like to share a few results from the literature that perhaps is not very well known, but it's something that concerned me as an implanter personally. So this is a paper that was published just under 2 years ago by Didier Chichat, and you know that Didier is a good friend, and he's a very, very well-known European implanter, one of the highest volume in Europe. And this is a low-risk group of patients, but they are fairly old patients, 78-year-old mean age, SES score of 2.6 only, and their 1-year stroke rate was reported at 4.7%. So 4.7% is not very high, but certainly is higher than what I am personally used to looking at. And you can see that not just the stroke rate is 4.7%, but the pacemaker rate is also a bit trended on the higher side in double-digit area. So that's that. And yesterday, you heard Oli Becker presented the Notion 2 trial. He presented these data in last year's EuroPCR and basically showed that in low risk, these are truly low risk patients, surgical patients. So in this group of patients, the stroke rate seems to have a signal to show that it's a bit higher than the surgical cohort. So if you look deeper into the data, it is really the bicuspid group of patients who's really driving this difference. So if you just look at a bicuspid patient, there is a signal towards higher stroke rate from 30-day up to 1 year. And yesterday, when Oli Becker spoke to us about this set of data, he mentioned that these are patients that normally with the valve, they are not fully expanded. And those are mainly in patients who are heavily calcified, that valve cannot be circularized. And so if you look at this chart, the stroke rate is a bit higher in the bicuspid group, but also the paravalvular leak and also pacemaker rate is also trended on the higher side for this group of patients. And this paper was published also in the last 2 years, also showed the same thing in bicuspid, low-risk bicuspid aortic valve patient, stroke rate at 30-day was 4%, new pacemaker rate at 15%. So, and last but not least, and this is a surgical paper that was published just under 6 months ago, and also showed the same thing. So in this particular paper, they mentioned that the TAVR associated with the TAVR in low-risk bicuspid patients are associated with higher longitudinal stroke and also composite stroke rate over the period of 1 year. So this is something that does worry me as an implanter. So I think this topic will not be complete if I don't mention a few words, just 1 minute on surgical treatment for bicuspid aortic valve. How safe is bicuspid aortic valve being treated by surgical treatment? So these are very common results that you can see from the literature. 30-day mortality is really running below 2%. And if you just look at the low-risk cohort, 30-day mortality is 1.4%. So it's a fairly safe way of treating bicuspid aortic valve stenosis patient. And this is a 5-year result for surgical treatment, very, very similar to tricuspid patients over 5 years. So both in terms of mortality and also in terms of stroke as well. So this is another very similar paper as well, showing you in a very low surgical mortality in bicuspid aortic valve patients, particularly the low risk, the young patients, okay? So that's that. And this is a Swedish paper that shows you that over a 12-year period, if you treat a patient with surgery with bicuspid aortic valve, their lifespan really goes back to very similar to the Swedish population lifespan. And you can find lots of these sort of results in the literature. So one thing that I think not touched upon a lot in this particular meeting so far is the question on aortopathy. So aortopathy, the guideline is very clear. If you're treating surgical treatment of aortic valve for bicuspid aortic valve stenosis, if your ascending aorta or your aortic root is 4.5 centimeters or more, then really you should be treating the aorta as well, because patients with bicuspid aorta, they do have much higher rate of future ascending aorta pathology, dissections and rupture in the future if you don't treat it. And if you do have to do a bentole operation, in addition to just a simple aortic valve replacement, it is also a very safe operation. Mortality can be under 2% as well. So that's that. So because of these complexity and ambiguity, we recently came out with an Asia-Pacific consensus statement, and that really highlights that heart team have to evaluate individual patient to choose the best treatment for that particular patient. And that really focuses on heart team looking at patient's age, patient's aortic root anatomy, and also surgical risk of these patients. So this is a flow chart. You can easily find it in this reference by Dr. Blackman from the UK. And so there are many challenges still for bicuspid aortic valve patients' treatment, and there are future considerations that we need to think how to bring this topic forward. In my mind, definitely RCT is long overdue. We really need an RCT to really decipher, to refine what we know about bicuspid aortic valve, who should treat and who we should perhaps think a bit harder. And just my summary slide. So bicuspid aortic valve stenosis patients are a heterogeneous group of patients. They are not one size fits all. TAVI in bicuspid aortic stenosis patient is safe and effective in most selected patient groups, okay, as we have seen from the partner tree, the evaluate low risk. So we know that they can be a safe treatment for those patients. Balloon expandable valve seems to have an advantage in this group of patients in terms of PVL, in terms of pacemaker rate, and potentially future coronary access, because these are younger, low-risk patients. However, there are potential signals point towards a possibly higher stroke rate and pacemaker rate and PVL rate compared to surgery in some selected low-risk bicuspid patient groups. So in my mind, I've mentioned earlier that further studies, especially RCT, is urgently needed to define which bicuspid patients will benefit from the current generation of TAVI prosthesis. This presents a big opportunity for innovations and studies to further refine TAVI devices, specifically for bicuspid aortic valve stenosis patient, and also to discover new devices to mitigate what we are facing now with TAVI treatment in this particular arena. But remember, until we get the perfect solution, remember that surgery is still a very safe alternative. With that, thank you very much for your attention.
Thank you, Dr. Hong, for your excellent talk. Any questions or comments? Yeah.
Okay, can I ask Jimmy? Yeah. So stroke is more common in bicuspid aortic stenosis, so compared with tricuspid. So probably that is due to heavier calcification. So, but do you have any opinion? So are there any reasons, because you are a cardiac surgeon, so you can see directly the aortic valve?
Yes, definitely. The bicuspid aortic valve stenosis patient, definitely they are heavily calcified. So when we go in, the annulus is calcified, and also the valve, the raphe, can be very calcified. So decalcifying it is a trouble. So I can imagine why doing bicuspid aortic valve TAVI can cause more embolization. That is just one part of the story. Because from Notion 2 trial, you know that they continue to stroke after the initial treatment. And the theory is that maybe it's because these valves are not fully circularized, not fully expanded. And Oli de Becker yesterday mentioned that when they did a deep dive, the cases that had stroke after the first initial implant were those cases that the valves were not fully circularized and fully expanded. And these are normally the cases that are heavily calcified, that the valve cannot open fully. So I suspect that may be then reason. I mean, the original answer to that is yes, bicuspid aortic valve are very, very calcified, causing embolization, possibly causing embolization, and possibly also causing the valve not being able to fully expand.
And because the time limitation, proceed to the next speaker. Yeah. Professor Wang, I think you are ready to talk, right?
OK，
院长，
好的。哎，现在可以看我分享的内容吗？
可以看到，可以看到。哎，现在没有，现在看到您的影像。
OK。
您这个题目非常精彩，而且很有意思。
OK，how about now？
一定要等到您可以讲。
可以吗？现在可以看到。
现在可以了，
现在可以了。OK， thank you very much for the TAVI Valve invite me talking about the robot system to help to do the TEER and TAVI case. I would like to talk about two topics. One is a robot assistant TEER, another is a robot assistant TAVR. I think it's a very interesting topic. One company come to my office 3 or 4 years ago. They want me to do first in TAVR cases use a robot system. But I think it's a too dangerous one. You use control the whole system, use this robot. If the patient's got a severe problem and hemodynamic unstable, it should be dangerous. So I asked them, is that possible to start from the TEER first? So this come from the company. We got this machine like here. One is instrument platform, another is host trolley, and the third part of the platform is the doctor's console. The console's in the control room, so that's you can see this machine combined with the DSA machine. The system like this. We use this transcatheter edge to use this machine to do the transcatheter edge to edge repair.
王院长，您的 slide 没有播放。
Okay, how about now?
It's the same. 可能右下角那最右边那个要按一下。
我这边是有的播放的。哦，很奇怪。
您的 slide 也没有动，就是在第一张而已。
Yeah. 现在呢？
都没有，跟原来一样。
Why? I'm sorry. 我这已经在不断的在动啊。
留在标题这个 slide 而已。
啊，我这为什么不是这样？很奇怪。我一直在可以再往下走。
这样可以。
Okay. This is our robot assistant TEER. This is our platform. In the cath lab is instrument platform. Outside we use the doctor's console in the control room. You can see this is a machine like this. We use this machine to connect all the TEER system. We can use the G4 system to connect with my robot machine in the operating room. This is a control button. You can see a lot of buttons there, left and the right, posterior, anterior, bending function, P and plus, a lot of function. We can use this button to control our clip. We start off first TEER operation in 1.5 years. I think the end of 2022. 2023. We finished the first in human use this machine to use our domestic clip, because the Senchi clips are going to approved by China maybe several months later. We use the robot system to control our Senchi clip successful to finish the first in human. And then we, in the last year, we use this one to first finish the in human use the G4 system, and it's also very successful. Now, this is our first 5 robot TEER cases. You can see a relatively good result, and the mean age is a 76-year-old. The 5 patients all successfully. We can see the patients previous is 4+, and most of the cases reduced than 2+, and 3 patients need 1 clip, 2 cases needed 2 plates. This is our first 5 the robot case. Now, I think the result is good, and no complications. This is a 30 days follow-up. It's over the first. And now we have totally finished 14 cases. 4 cases been done in Anjing Hospital and 10 cases in our hospital. Couple of months ago, we started the RCT. It initiated from our hospital. So far, we have randomized 5 cases, all successful, and the result is also good. In the next couple of months, we are going to start our RCT in 5 other hospitals in China. Totally, we would like to finish 120 cases, maybe 60 cases in control group by experienced doctor, and 60 cases controlled by this machine. And I do like this machine to do the robot TEER. I think it's very use-friendly. Our first in humans study is a pretty good result. I'm going to show a case. It's a mitral TEER case. Is first my robot case is a 55-year-old lady is presented worsening heart failure, and it's a DMR patients and posterior prolapse case like this. Oh, okay, it doesn't moving, right? Okay, I try to big screen to say it's moving or not. Okay, is that okay?
No, the same.
No, the same.
It's moving or not?
It's not.
It's not.
Why? Here. Sorry. How about now?
The same.
The same.
Uh-oh. But my computer's moving, I'm sorry. Okay, anyway, can you hear me?
Yeah, we can hear you.
Yeah, we can hear you.
Okay, so I'm sorry, you can't see the moving picture. I'm just tell your story about the first case. I don't know what happened. This is a patient's the T shows and posterior prolapse, and this is in the A2P2. It's an eccentric jet and posterior leaflets. You can see the color come from the posterior jet like this, and this is a puncture septal. We got a 4.28 centimeters height. Position is good. And after this puncture the septum, whole system we handle to the robot machine to control the button. We can use all the system to bend the clip to get a very good trajectory, and we can use the plus and minus function, and also clip control the clip up and down. And finally, we got a relatively good position is a A2P2 position near the medium, and you can say it's a 12:15 o'clock. We counter clock a little bit. All this can controlled by the machine. You can see very good position, and we capture the anterior first and then capture posterior. Can you see the slide moving?
Yes, we can see it.
That's okay. I'm sorry I can't show the moving picture. I just slide by step to tell the story. Finally, we catch the posterior and anterior leaflets. You can see very good result after the clip and the trace regurg. This is our experience about the robot assisted for the TEER. 2 months ago, another company would like to use the robot system to do the TAVR case. And I also finished, I think it's a first in human also case use this machine. You can see the different type. We call it a reach shuttle system to do the TAVR case. The machine like this, you can two buttons. One is can insert the system, another can rotate the system to deploy and retrieve the valve. All can controlled by outside the control room. This console, we can control it. I think our first case is a 70-year-old male, like the anatomy like this. This one is a bicuspid case. And I came in my control room to control the whole system. I'm sorry, the picture not moving. After I put the wire in the left ventricular, you can handle all the system, the valve system to the machine, and I can control the outside to advance the system inside and cross the valve and the gentle to deploy. You can also can get the feedback of the resistance and the transmission of the force is good. If you cross the aortic valve, it's got a little bit resistant. If you smooth in the smooth position, it's good. Sometimes it's touch the aortic valve, you got a resistance. Can feedback by your hand. I think it's very good. And according to the X-ray, you can see we finally successful deployed in very good position, and you can do all the things use outside control system, and very successful to finish the TAVR cases. So far, we have finished 3 cases. We are still on first in human study. After we finish 5 first in man. We would like to randomize the clinical trial, use robot assistant to do the TAVR. So I'm sorry the picture not moving. I don't know what happened, but I'm going to tell you that all the results is very good. And when we first to start the operation, after 2 or 3 case robot assistant TEER, I do increase the very interestingly control the button. It's a very nice system. This is all my presentation. Thank you.
Thank you, Dr. Wang, to introduce us the very fascinating system to doing the TAVR procedure on mitral TEER. And for the robotic assisted TAVR, can this system used to deploy the balloon expandable valve?
We can use this system to do the balloon expandable valve, but I don't think it's useful because when you finished all the system, you just put the wire in the valve in the very good position. The final step you hand it to the machine. Actually, you need only maybe 10 or 30 seconds can finish the operation. You use balloon expandable valve. It can, but it's too complicated. No need, I think. Because for the self-expander, you could take time and gradually you can retrieve it and deploy it. Whole system you can control there. Even sometimes when you use the balloon expandable valve, the position is not very good. Sometimes once the balloon up a little bit, you can one hand you can control up and down to reposition the. But the machine at that short time to do is maybe dangerous. And I think it's a very good use of self-expandable valve, not the balloon expand. It can, but
thank you. Yeah. Yes.
Yeah. Thank you very much, Dr. Wang Yan. Very exciting lecture, and I thoroughly enjoyed that. Can I ask, the puncture of the atrial septum, was that robotic guided as well, or was it done used manually?
Okay, it's done manually. So a lot of a doctor, especially from American, they told me, is that possible future for puncture also use a machine? I think so far it's difficult to do things. It's all manually. After puncture the left atrium, and you handle the whole system to. So that's why we randomized our all patients now after successful puncture. And then we randomized to experienced doctor and robot.
I see. And I see a very big usage in remote proctoring. So you may have a center in the darkest corner of the earth that requires this sort of treatment, and all you need is puncture skills. They set it up there, and you can be operating the machine in China, helping patients far, far away.
Thank you. We hope this year we are going to do a live remote control overseas. Maybe we can do the operation in our Xiamen hospital, and we control the system in American or Europe. Some countries. We are planning to do these things. It's possible.
Okay, Professor Wang, because the time constraint, thank you for the very interesting talk. And sorry for the slides transmission, but we learned a lot and enjoy your talk very much. Thank you.
Thank you. Thank you, Professor Chao.
Thank you. So we close this session. Bye. Can I invite the other panel on come up to the stage? So the first talk would be Dr. Liu Junting. Her talk is CT imaging analysis in reduced TAVR. Dr. Liu, please.
Thank you, the honored moderator and panelists, and every doctor here. I'm Chunting Zhu from Zhengxin General Hospital, and the topic today would be the CT planning of reduced TAVR. So, based on the methodology outlined by Sorry, fix the technique problem. Okay. Based on the methodology outlined by Vinay Bepot in his 2024 publication, the CT planning process involved the following key steps, including confirmed indexed valve, choosing second valve, and define the coronary risk plan, identify new skirt plan, and we will follow it. So in the meantime, we must consider the feasibility of reassessing the coronary artery, as patients are becoming younger and younger and are more likely to require PCI at some point in their lives. So you can evaluate the patient's risk of coronary obstructions by measuring the height of the coronary and the new skirt plan. The ideal scenario is when the coronary plan is higher than the new skirt plan, indicated a low risk. However, if the coronary plan is lower, lower than the new skirt, And the further assessment with measurement of like VTC, VTSDJ, and VTA is necessary to accurately determine the risk level. So in this presentation, I want to share some case example to show how we go through analysis the CT image step by step to find the important clue. So this is an 84 female patient who underwent a TAVR with a 26 millimeter core valve 8 years ago. A pre-operative CT reveals that the previously implanted core valve has migrated significantly towards the left ventricle, so it results in an estimated implantation depth of approximately 13 to 16 millimeter. And her coronary level is higher than the Nielsen level, indicating a low risk of coronary obstruction. So the original TAVR valve may have become very deformed over this time, leading to a size smaller than the original prosthesis valve. So we still recommended using CT for accurate measurement, but not only according to the app. And now, according to the measurement on the CT, we can find out that the index valve is very under expansion because the inflow is only 24.6 millimeter and the narrowest waist is only 19.3 millimeter. It's very under expansion. And there, according to the measurement, we choose the Sapien 23 millimeter, a little bit oversizing to a little bit much oversizing, but since the coronary plane is above the Nielsen plane, there is no concern of coronary sequestration. So in combination with post-dilatation methods, this approach will likely improve the effective orifice area and overall hemodynamic outcomes. The VTC would be about 2 millimeter, but after the post-dilatation, it may become smaller, about 1 to 2 millimeter, but it's just fine because the coronary plane is higher. So we can see that after the post-dilatation and the hemodynamic is good, is about 4 millimeter mercury. So the next patient is a 73 female post core valve, 26 millimeter as well. But you can see the difference is this patient's coronary level is lower than the Nielsen, so it has the risk of the coronary obstruction. It falls in the scenario of 2A or 2B. So we have to further measure the VTC, VTSDJ, or VTA. So this patient is have small VTSDJ and small VTC of the left main, but relatively suboptimal of the right coronary. The right coronary VTSDJ is 3, but big VTC. So this patient have high risk of left coronary obstruction. We come up to measure the inner diameter of the core valve inflow is about 20.7, and the narrowest waist about 20.3 millimeter. And you can see that this core 26 valve is under expansion as well, but it have different issue of the coronary obstruction. So according to the measurement, we choose the size is Sapien 20 millimeter rather than the 23, because this case is not supposed to over expansion the valve, because we have to prevent the coronary sequestration. And as well, we found out this patient have the coronary obstruction risk, so we have to implant the valve just below the coronary ostium. Besides, we have to perform left coronary artery and right coronary artery modification. So according to the measurement, we do this patient with a 20 millimeter sapien 3 plus unicorn technique to the left coronary artery plus RCA protection. And in combination of all the treatments, the final result is very good and no coronary obstruction, both left and right coronary artery. And the final result is pretty good. The pressure gradient measured by T is about 6 millimeter mercury. But not always the VT-STJ is very useful, because we have a kind of valve called lotus valve. And this valve is very stiff. It has very restricted post. It's not by, it's very hard to expansion by the balloon. So this is the case. An 80-years-old female and underwent the lotus 23 millimeters 9 years ago. You can see that valve is not very well expansion as well. The inner diameter is about 20 millimeter. And this patient has another issue, like the valve alignment is poor, is moderate, and small sinus vasava and small STJ was noted as well. So the patient's coronary level is almost the same to the neo skirt. When we simulated an absolute 23 valve inside, we can see that the VTC is already set by the index lotus valve. So no matter how we put the second valve inside, it won't change the VTC or VTSTJ. So after all, we still put an absolute 23 millimeter inside, and the final result is quite acceptable, but a little bit higher of the pressure gradient is 13 millimeter mercury. So after all, I come up with a conclusion is we have to get information of the first CT data if we have. The point is to know the native annular size. We won't want to post dilatation too much, and we want a classification of distributions, and we get information of the index valve, like what type of the valve, the size of the valve, how we implantation depth, and is this valve alignment or not, and is this failure mechanism is stenosis or regurgitations. And we measured the inner diameter of inflow annulus plane, the narrowest plane, the STJ plane. And we define the coronary level and the neo skirt level and measure the VTC, VTA, VTSTJ if the neo skirt is above the coronary height, above the STJ. And next, all the measurements, we have to choose the valve type, and we have 4 combinations like short in long, long in short, short in short, and long in long. And each classification have each issues, like short in short, it may have a poor hemodynamic, and the long in long may have a challenging coronary reassess. So we always choose the short, mostly we choose short in long or long in short, mostly in our hospital. And finally, the ideal implantation that is considered of the neo skirt plane, the align of the second valve below the lower edge of the lower coronary ostium will be our choice. And this my presentation. Thank you.
Thank you, Dr. Liu, for your excellent talk. The redo TAVR is much more complex than the first TAVR. Any comment or question? Okay, so
yes,
so lecture first.
Yeah. So let's keep moving and let's discuss everything. Yeah. So next we have Kent, Professor Kensel from Hong Kong, talk about TOR in short.
Thank you. Thanks once again for the organizer, Professor Wei, Professor Yin, Dr. Lee, for the invitation. So this is a very educational course. So my task is actually very easy because tall and short is actually doesn't have lots of things to cover. So I would try to go fast. So here's my disclosure. So a little bit background. I think it's very important to understand why we have a special workshop on TAV in TAV, because TAV in TAV is actually quite different from TAV in SAV. So TAV in SAV, we always know that in surgical AVR, the valve is implanted at the annulus level. And most of the surgical valve actually has similar height. And most of the time, commissural alignment is sort of like guaranteed. Whereas for TAV in TAV, the depth of the first implant actually varies. So it really depends on how you do the first TAV procedure. And the index TAV also has different kind of structure. It could be superannular, intraannular, tall, short, different kind of combination. And the in vitro and in vivo shape or the size of the TAVR valve platform can be very, very different. So it's actually very critical, as Dr. Liu has mentioned. A preoperative CT planning and analysis is actually the most critical part compared to the procedure itself. So there are a few important decision makings when you have the CT ready for planning. First is on which valve platform to use, and we have 4 different combinations which I will go through very quickly. But the ultimate objective is you want to prevent the risk of coronary occlusion, and preferably you also want to maintain the future coronary access. And of course, if the patient is relatively young, you also want to plan ahead whether there is a chance of third intervention. And then, based on the CT, you want to choose an optimal valve size, because if the valve is too small, if the valve is size too big, then there will be wind pulling of the newly implanted TAVR valve. And subsequently, the final part is the CT is going to tell you whether you need to do any adjunct therapy like unicorn, basilica, and the implant depth, and also the degree of oversizing. So as Dr. Liu has mentioned, there are 4 different combinations, but I would say very high chance that these companies has to work together. So if the first valve is a short valve, then the subsequent valve usually has to be a long one. And if the first valve is a tall one, the second operation usually has to be a short one, mainly because if it is short in short, usually the EOA will have some limitation. And if it is tall in tall, then you don't have a coronary access, very likely you don't have a coronary access in the future. So short in short, Simon is going to tell us more. So I'm going to illustrate a case of tall in short, so which is actually pretty easy. So the concept is actually, the reason why we need to pay attention to the CT analysis is because the concept of neoskirt and also neoskirt plane. So the neoskirt actually is created because of a combination of the index TAV pinned leaflet together with the inner skirt of the second TAV valve platform that would potentially be obstructing the coronary flow and also could be interfering your coronary reaccess in the future. So in case of short in short, this blue line is illustrating the highly possible neoskirt plane, whereas for tall in tall, usually the neoskirt plane will end up at node 6 of the TAVR valve, and whereas in tall in short, usually that would end up at the top of the SAPIEN valve platform. So that, because of that reason, tall in short is actually kind of like easy for planning, whereas for for the other last combination, tall in short is a kind of complex. So I'll finish with one case example. So this is an 80-year-old patient that has a BMI of 17, has a severe aortic stenosis. He actually underwent a TAVR using a SAPIEN 323 back into 8 years ago, CAS 3-4 at baseline already, and he actually also has a background of lung cancer in remission after radiotherapy. His STS score calculated is over 17%, which means that he's not a surgical candidate, and together with the age. So this is what we found on the CT and also baseline aortogram. So he's kind of like having a mixed AS and also aortic regurgitation. The AR is just moderate, but the mean gradient is over 50. So the EF is actually bad. It's maybe probably around 30%. So this is not the focus, but this is the case that we have faced some sort of challenges because the vascular access is actually very bad. From the CT scroll through, you can see it, on the right side, there's not possible to go through because of the narrow segment and also very calcified vessel. On the left side, it's also very, very marginal. So for this case, we actually decided to go transcatheter, but that's not the main focus for today. So the important thing is actually lying on the assessment of coronary obstruction width. So from the baseline CT, from this CT, you can see the RCA is actually lying above the neo-skirt plane. So which means that you don't have risk for the RCA to have occlusion. And together, we access if you have commissural alignment for the second valve implanted, that will be possibly be achieved. The left side is the one that might have potential of coronary occlusion because it's actually below the neo-skirt plane. So if the valve is below the left main is below the neo-skirt plane, then what you have to see is you have to assess the VTC distance and also the STJ consideration. So the valve, index valve is actually kind of well expanded. The area is actually 379. Which is actually pretty good. So we are able to put in a 26 self-expanding valve with this kind of area. So as I mentioned, so because the left main is below the neo-skirt plane, so what we do the next is to measure the VTC distance. In this case, the VTC distance is actually over 6.1 millimeter. So we try to simulate to put in a self-expanding valve inside the short valve. So you can see there is a high chance that the valve is, there is still a possibility of getting coronary perfusion. So then this patient, of course, he is 80, so we don't have a lot of consideration for the third implantation. But let's say if this is 75, then he might have a chance of going in the third time. So we also try to assess whether it's actually feasible for going for a third operation in percutaneous way. So we also try to measure the VTC STJ distance, which in fact is actually pretty reasonable because you can see all of them are actually above 2. There's no definite cutoff, but then it's because it's actually a three-dimensional structure, so we anticipate it's actually still feasible if we have to put in a third valve in. So, so this is the case summary. So we decided to put in a 26 effluent FX plus inside the SAPIEN 3 transcatheter access. So this is just the transcatheter access, and then this is baseline aortogram, and then we pre-dilate because it's a stenotic valve. So then we put in the valve. As I mentioned, the commissural alignment, we didn't go through the crossing of the aortic arch, but then because the commissural alignment is actually very important for planning for future coronary access and also planning ahead for subsequent procedure. So we also pay attention. You can see the C-tab is actually, the C-tab is actually at the outer curve, and so we then believe there has a high chance of commissural alignment. So we intentionally land the valve a little bit lower, but this is what we see before we fully release the valve. And this is after the valve deployment, this is the result. So there's no peak-to-peak gradient, there's no aortic regurgitation as you can see. And the coronary perfusion for both sides is actually pretty good. So we also have a little bit of discussion because you can see the first and the second valve there is still a gap because it's a stenotic valve, right? So would you actually post-dilate? This is a very important discussion. But then for this patient, because we think the result is actually pretty good, so we actually decide not to post-dilate. But we can have some discussion if we have time. So to conclude, TAV in TAV will become more common in the current era of TAVR. Index TAVI decision and implantation is actually very important for patients' lifetime management, including you need to make a wise choice of valve and also to achieve a commissural alignment during the index implantation. And when you're doing a TAV in TAV, meticulous planning is actually very important. A few considerations including the neo-skirt plane, valve choice, and also to consider the lifetime management, including coronary access and also a subsequent TAV in TAV procedure. Thank you very much.
The next topic will be delivered by Simon Lam from Queen Mary Hospital in Hong Kong. He will talk about short in short. Yeah, that's right.
Yeah, so this is about short and short, and actually short and short is not too difficult, and I mean, just interpret it as a short presentation in a short period of time. I think because just now it's over good summary of different combination, but just highlight the key facts. You need to know the original native anatomy. So we always go back to the first CT. So whether there's anything that can optimize based on that, maybe the valve choice at that time with deflate the balloon, less overfill, then maybe we can optimize it before putting in a second valve. Second is know the first THV, as we said, maybe it's kind of recoil afterwards that creates gradient. So we have to understand that instead of just jumping to the procedure. Third is know the original procedure. Is a reason, any reason for putting the valve in that position, whether why we choose the valve, is there any reason? And so we have to go through this process, and then we have to optimize before second valve. If you find a recoil, especially for patients who have rheumatic heart disease, you put in rheumatic AS, and you put in, maybe with time it comes back like narrowing, you can see waist over there. Then if the original CT measurement allows, we'll optimize the first stent before putting the second one. Because when you put in the second sapien, it's no longer to have enough force to open up the first valve. So you have to optimize it in the first place. So use of good shot, I think is reasonable because you want to choose, maybe you're facing original valve is the first generation, maybe you could use newer generation for that, especially for smaller valve selections. The new valve like the Resilier Ultra, then they can have a good opening at the commissures that could potentially improve some hemodynamics. So careful CT planning as mentioned, and implantation level, usually I would just focus on the original annulus plane. But definitely, I would try to aim it a little bit higher because I would try to avoid the restriction, but just as in general. But most of the time is because the reason for first valve, choosing a short valve is because the risk of coronary obstruction, low VT, small VTC, no more sinus. So we have to address with that. And sometimes we have to adjust according to the original anatomy. So implantation, as I said, and sometimes we need a coronary assessment and protection. And just show one case is a unicorn case, but you can see because we don't pay too much attention when we implant the valve. There's no concept of valve involved when we implant the first valve. So we leave behind that patients may have unfavorable coronary access. I mean, they will have new skirt covering. Like this one, it pushed to the other side. It's a kind of patient with fusion and push towards the left main. And then you have no VTC. And so this is a unicorn case, but it doesn't really focusing on that, but you can see the deployment. So how to position a valve? So usually if there's not a reason for to put it that low, we'll put it higher. Just like valve and surgical valve, you want to have a better flare the outflow, better opening, post-dilatation. But if there's really a concern for coronary obstruction, so we just position the upper part of the frame, just at the coronary plane, just below that. And then we just let the lower part to flare up. So, and before doing that, we have to make sure the original valve is optimally expanded. If you think there is a room for further expansion, we'll do that earlier on. And then, so you can see that this is one of the cases that we put quite low, which is unusual, but just because of the coronary risk. So we decide the level according to the surrounding anatomy. So, and also we're facing more actually with the XT, because the first batch we do TAVR is XT. So just to highlight, usually they're shorter. So when you position the valve, they may be slightly different when you're doing an S3 and S3. And problem, they don't have commissural alignment even at this time. So this is a drawback of short valve, like the sapien. And so that's the reason why we have to look at the individual features of the valve, take that into consideration when you plan the procedure. So thank you very much. We'll stop here. I think we'll just carry on with the discussion and complete the list. Thank you very much for your attention.
Next speaker will be Dr. Li Yong-Tsai, whose topic will be short in tall.
I think that this is the most hard topic in the redo table because short in tall is very difficult and a lot of things to decide. So Dr. Liu have introduced some idea. However, there was three important issues to note. The first one is a failed leaflet, and the short is a scoop space occupation. So when you open up the new valve, the lesion will compress your new valve. The second one is the original annulus could not be opened again. So when you open a new valve, the original annulus is the limited point, so that you cannot further opening the annulus. The third one is such as we do before is in acute regurgitation cases, and when you do in the short in toe, that the valve can expand quite well without any limitation. So that you must need to know these three things and have a good idea plan. So that for me, I don't check. I usually check the original valve plan and the new valve plan because always the valve is tilting in some place. So at this case, the left is 24 and the right is 16. It's got very difficult to decide which one is a good plan. So that we all know that node 1, node 2, node 3, and the gear pattern always told everybody to do the count the node and need to know. However, the problem is during this short period, maybe that's 10 seconds, could you not know that which one is the best node for the patient? So it got very difficult. For this case, we have the coronary protection, so you can count the node. However, in most cases, if you do not have a coronary protection wire over there, and it got very difficult to know the node is. So the first thing is implantation depth for left side and the right side. So you need to know the coronary. And the second is you must know where is the constricted area and the inflow and the outflow. And the constricted area is usually at the annulus plane. So there's the calcium and a lot of things limited the valve further opening, and such as in core valve, in the middle they have a waist. Waist can open. However, if the annulus limited the valve, so that the waist cannot open too much. So sometimes you need to downsize the valve quite a lot. So that we need to know that the defibrillator overhead, such as this case, that's H3 23 minus 2, and the height is quite high, and the defibrillator overhead is quite small, and 20 plus 1 is about 21.5. So that's for coronary and a lot of things quite okay. And for this case, the inflow area is around 300, and the limitation area is around the 330, and the outflow is 590. So we can know that the commissural alignment for this case is good. So that's good for the redo TAVR. And we do the unicorn for this case because when the valve open, that's just Dr. Liu say that the defibrillator may be pushed to outward, so that it's got a very important problem, and we protect the right side. Now, it's a very important thing that we just aim the coronary at our target, so that the coronary is around 6, so that when we implant, we just aim to the coronary, and we know that the coronary is your good reference. So that the limitation area is the annulus, but not the waist or any other way. Someone tried to use 26 with 23 sapien. However, you can see here the annulus is still limited the valve expansion, so that even you choose the 20 plus 1, still got a very difficult opening. And here is final result. I think that most of the show in toe, you might do the basilica or the unicorn procedure because of high chance of the obstruction. And here you can see the commissural alignment is quite good, and some defibrillator overhang. However, the whole procedure is quite safe, and the patient is getting well after a couple of months.
And finally, for the
2x2 combination of redo TAVR, like in tall in short, short in tall, short in short, and finally we come to the final tall in tall. But the topic for Professor Yin today is why should tall in tall be avoided? Professor Yin, please.
Thank you. I would like to briefly discuss the issue regarding redo TAVR. And this is I think this has been mentioned before. There is extremely high demands in the next few years. Therefore, combination, as mentioned before, I think the complexity of redo TAVR depends on the interplay between the arterial anatomy and the valve combinations. We have done analyzed our own data for about 40 cases with valve-in-valve TAVR or repeat TAVR during the first procedure. And as you can see, we divide the cases into two groups. The index valve is a tall valve, or the index valve is a short valve. As you can see, the hemodynamic performance was better with a tall valve as the first valve. However, the core issue is also higher in tall valve as the index valve. And furthermore, the paralytics was worse with the use of a self-expanding valve as the index valve. This can be further analyzed. We further divide the patients into 4 groups: tall in tall, short in tall, tall in short, and the short in short. As mentioned earlier, if the first valve was short valve, the hemodynamic performance was not good. However, the coronary risk, if you take into a deep look in that, the first valve, if it was a tall valve, the coronary risk will be higher. And the PVR was also higher for the tall in tall. So I briefly summarize our strategy in dealing with redo TAVR. First, proper sizing is crucial when selecting the second valve. I show you an example. In this patient with a failed 26 sapien 3, intuitively we use 26 to do redo TAVR. However, the procedure was end up with a high residual gradient, up to maximum gradient, a mean gradient of 19. This is because, as mentioned before by Dr. Lee, there are tissues or valve tissues or degenerative tissues or PNAR formation in the first index valve. So this may constrain the second valve and develop pinwheeling, and this may compromise the hemodynamic performance. So as mentioned before, proper sizing is crucial. If you measure the inner diameter by CT, you will downsize of the second valve may be needed. As this patient have already shown to you, we choose a 20 sapien 3 in the failed 26 core valve. Secondly, we should stratify the risk of coronary. As mentioned before, if the SOV was shallow and the waist are narrow, you should consider leaflet modification, Germany stenting, or even surgical explant. If the anatomy is big, as in this patient, you can do valve-in-valve without any difficulty. However, if the sinus was effaced, then you need to do a leaflet modification before implantation of the second valve. Regarding the position, this have already mentioned by Dr. Lee. The key is that if you want to do high pressure inflation, you should keep that within a safe range. That means valve expansion itself will reduce or compromise the VTC. And secondly, you should keep the Neal's curve always below the coronary risk plane. In that way, you can keep patents and the reaccess of the coronary possible. So finally, the selection of valve. Why toe-in-toe should be avoided? This is an example. If you put the valve high and you did not notice the commissural alignment, like the case on the left-hand side, you will not get into the, you will be unable to get into the coronary anymore. Unless you put it deeper with a good alignment, then you may have the possibility of getting to the coronary easily. So according to previous literature, it is really hard to get into the coronary. You will get 23% of sinus sequestration after toe-in-toe combination, and up to 78% of the cases, you cannot reaccess coronary anymore. So this is on the opposite side, is that if you use a short-in-short, almost 80% you can get into the coronary easily. Regarding the hemodynamic performance, although the toe-in-toe is best in terms of hemodynamic performance, however, as we shown in our analysis, the paralytics was more severe in toe-in-toe combination. So in consideration of all this, I think toe-in-toe should be avoided in redo TAVR combination if possible. I thank you for your attention.
Okay, thank you, Dr. Yin, for the talk. So any question or comments from the experts?
So I think this is a very good session that we have comprehensively listed out all the opportunity, all the possibilities, and so we know the limitation of valve-in-valve with the existing devices. And I think maybe we need some dedicated device for valve-in-valve, because it's very stupid to put a short-in-short, but there's a skirt there, and the skirt actually creates gradient. And secondly, if you put in a torque, actually don't need that much metal, because you just have original anchoring, just less metal, then you can create better access to coronaries. So maybe you can share experience around the table. So any special cases that you could recall during TAVR that give you a headache and a nightmare?
Can I ask a question?
Yeah, please.
I have a question for Dr. Liu, that when we do CT imaging measurement for TAVI and TAVI, should we measure the metal frame, or we measure the true inner diameter, including the soft tissue? So what should we do? Because in today's case, I see most of the CT measurement, we do it on the metal frame, but we tend to downsize.
I think nobody knows that when you deploy the first valve, especially the balloon expandable one, have you under fear? And do you know the exact inner diameter? And also, for those with a complex anatomy, such as heavy calcification, even you use a self-expanding valve, if the valve was implanted too deep and constrain the leaflet, then you don't know what's the real inner diameter. So that's why we recommend to use CT measurement. The other thing is that there is still some room to be enlarged by implantation of the second valve. But that should be done within the safe range, as I mentioned before. So I think to measure the ID from CT using the metal frame is okay.
The problem is from the data deals, they check the outside the metal or inside the metal, and the company that's I think that's a Medtronic or Edward, they just check in the middle. So there's a recommendation of Vinny or Gilbert. I saw several times they suggest check in the middle. they say that in the middle maybe that can further expansion. However, when we implant a valve inside the XT, ST is have a very strong stroke. So that's when we implant the ST, that's a ST maybe there's a 1 millimeter or 2 millimeter inward. So that's when you open, that's a name, that's a flare the valve. So it's also my question, the inside, outside, or in between.
I think the waist should be the level to measure the ID. And also, we should consider the valve itself. For instance, if the valve is a lotus, it's almost impossible to dilate it. But if it is a self-expanding one, we still have room to open up the waist.
Question for Simon. So the short in short, the new skirt plan is the shortest. But for the so in what situation? But if you put the short in short, the hemodynamic would be I think the worst in the 4 combinations. So in what situation you select the short in short?
Yeah, so I think usually the first valve we choose is either short valve. The next one is very reasonable you choose a supraannular valve. But there are still scenarios that maybe the coronary height is very low, the sinus sequestration is so high that you need to consider short and shorts, especially if the degenerative mode is AR. Then the patient may be able to tolerate a little bit of the gradient. But just not advocating short and short for all cases, but if there's a reason to do that, then you have to optimize it in a way that it performs well. So I think it's highly selected. So by default, it's still a supraannular in a short valve to be my first planning.
I want to raise a question about if the cause of the degeneration of the index valve will influence or raise any concern when we plan the next valve, and also the like a porcine or bovine valve. Will you think about when sizing? You will think about the thickness of the valve, and will this make any concern when we plan it?
Yeah, I think that we played a role in the selection, but usually we still target, no matter what kind of degenerative mode, you still want a better hemodynamic, longer durability, good protection of the coronaries. But just we mentioned, in some cases you really need to use a balloon expandable valve. Then if the mode of degeneration is AR, then the patient will be really better out of the procedure. But if the patient, you do it just because of elevation of gradient with time, if you put in a second valve that carries a high intrinsic gradient, that may not be that desirable. Yeah, but I think bovine will be thicker, and calcified valve will be thicker. So I think also same with the surgical heart valves, right? So mitral fold is very hard, then your trifecta is thinner. So I think that plays a role, but bench testing may be important to know about that.
I would like to also raise a question for Professor Yin, and I'm totally agree that we should avoid core valve in core valve because the coronary access will be the big issue. But currently, for the long valve, we are not only have the Evolut systems, maybe for the future FX Plus, or even for some self-expandable valve with very good coronary access. Do you still think that toe-in-toe we should avoid?
No, maybe in the next 10 years, I will change my mind.
So how about, how about put like a portico valve or Navitor valve or accurate neo valve in the fail core valve currently?
Yeah, you are talking about the coronary issue. But if you're concerned the coronary issue, why don't you just put a short valve? That can solve everything.
I think it's never still an intraannular valve, but I think for a company it's not labeled for use for valve in valve for that purpose. But I think, the fact that it carries less metal is an advantage. So I think we should work on that direction. But still, some patients theoretically will be good with toe-in-toe, but it doesn't work with the existing system.
For putting a new valve into the short valve, and how do you adjust the implantation depth because cancer is not here. There's a T-shoulder case is quite deep. However, we try to use the self-bending implant higher. However, the 0 is okay, or we need to expect the aneurysm, so just inflow to inflow.
You mean a tall in a short?
Tall in short.
So how to
I'll
control?
just ask him. He told me that it doesn't matter.
Yeah, so but then it's good that it's retrievable. It's always could adjust in case you need that.
Yeah, for that case, I think it's lose the advantage of superannulus properties of the toe valve. Yeah. So can I have a last question?
My question is, do you think we have the third TAVI valve for the next time? I mean, it's difficult for TAVI in TAVI. Now the TAVI in TAVI, it is possible?
It depends on the anatomy of the patient. As I mentioned, if the anatomy is good, you can do whatever you want. But I think Professor Wei also have another idea. You can excise the leaflet and put a new valve in. That can, get some room to expand it and avoid too small valve as the third valve. Yeah.
Some cases that we have acute neo cases and it's too high, the leaflets. You cannot do leaflet modification. So a surplus procedure is something that we do.
Yeah.
So open up, it's an expensive procedure. You open up, cut the leaflets, but I think you can share experience. It's difficult to extract the frame because now we optimize, expand it, it's touching the wall. You have to do like root replacement, and this is a way that you cut the leaflets and just deploy sapien inside.
I think the anatomy, if the STJ or the sinus is big enough, I think it's okay. It can be considered there.
Professor, we want to comment on this?
Well, they heard about the surplus, right? That's the mentioned that the point you do the second time operation for the previous patient implanted with TAVR, and well, I think that we don't have to totally remove the TAVR valve. Just leave the metallic portion inside, and just to cut the to cut all the valve tissue, and leave the metallic portion still in the annulus, so that you can put another TAVR valve inside, so that will decrease the thickness, and you can use a bigger size of the TAVR valve. Why I prefer to do this, because in one situation is if you do the TAVR to do the second operation for the surgical aortic valve. Sometimes I just no, I don't have many many cases for this, but at least I have done one. I just cut the metallic valve, not the tissue valve. That's previously implanted surgical aortic metallic valve, and cut the metal portion, okay, of the valve, and I leave the sewing ring on side. Then I put another, and then we do the TAVR valve on inside the annulus. You can do that. And another condition is that you leave the metallic portions in the TAVR valve, previous TAVR valve, and you still can put another one. So you don't have to remove the whole thing. When you remove the whole TAVR valve, you may have to do the bento operation. That's more difficult. So this is what I suggest to do. So anytime you have any trouble, you just call your surgeon to do this. Okay. Okay.
Because of the time limitation, I think we need to close this session. I thank all the speakers to share their excellent case and good information. Thank you. Closing Yingqiang院长。
Well, I have to thank all of you for your enthusiastic support and for being with us during the past few days. Well, over the past few days, we have didactic lectures and live demonstrations, interactive sessions, and case discussions. All of these can update our knowledge regarding the valve therapy from last year. So I think we hold this meeting is the purpose is to enhance our knowledge and improve our skill so as to provide better patient care. I think this is all of you being here, you agree with this. So I think because of the schedule was really tight, so maybe there are some shortcomings regarding the logistic and the arrangement of the meetings. So I hope that you can forgive us if there is any shortcoming and give us feedback so as to make us to make a better meeting next year. I thank you for your attention. Same.